Good morning, everyone, and very soon we are going to start the session. We are expecting, we already have Dr. Sushil Jindal, who's one of the senior most endocrinologists from India, and maybe the only one from this part of the country in central India. And we are also waiting for the first speaker, Dr. Sunil Ambulkar. If suppose he gets late, then we'll start with Shinjan Patra, who's the second speaker. He's already there. And I'll humbly request after 5 minutes, if he doesn't come by 9:15, we'll start the second session with the permission of Dr. Sushil Jindal, if the first speaker doesn't come in time. So, but we are waiting. We have to wait for another 5 minutes. Hope all of you have completed your breakfast. Thank you very much. We had wonderful session last 2 days, and those who are coming here for the first time, I feel I also welcome Dr. Lakshman Chandrasekhar, who has come all the way traveling from Chennai to Siliguri, and then Siliguri to Nagpur, and now Nagpur to Chennai maybe today evening. So we welcome you, Dr. Chandrasekhar. And those who were not there for last 2 days, just let me tell you that we had wonderful session. Our all sessions went very well in time. There were little hiccups yesterday as per as timings are concerned, but ultimately we concluded well in time and everything started at till every. We had around on the very first day we had session of 11 hours, and yesterday we have session of 12 hours. So we started at 9 and finished at 9 yesterday. So I feel Sunil Ambulkar has arrived, and let's give a big hand to the first speaker and the opening batsman of today's CME. I feel the big hands, the multiple hands are there. I feel Sunil, please do come upload your slides. Yeah. So uh, इथे करून दे. ते आतमध्ये जाऊन पाहून घे कोणता आहे तुझं. एकच आहे का त्याच्यात? दाखवा लागेल ना तुला. सो मे आय इन्व्हाइट CV है सर इधर. Can you upload the CV of Dr. Sunil Ambulkar, please? So may I invite Dr. Sushil Jindal. I told you he is possibly in first three senior most endocrinologists who are active endocrinologists in the country. And he is one of the guide and mentor for me when I started my practice in 1994. And he is instrumental in guiding me throughout. And still whenever I get any academic and glitches in my practice or in my anything in my life, I still talk to him every time and he guides me. He will talk to me for half an hour for this, and we have very close knit as a elder brother of mine and a elder family member of ours. So he is a DM endocrinology professor in head department of endocrinology, People's College of Medical Sciences, Bhopal. Sir, we welcome you and invite you to please occupy a chair and conduct this session. Dr. Sunil Ambulkar's CV is there on the screen. By the time he uploads his slide, you can just introduce him and start the session. Thank you very much. We have each session which is 15 minutes, which we say that 12 plus 3 minutes. So you should finish your session in 12 minutes, and then 3 minutes should be given for discussion. Over to Dr. Sushil Jindal, sir.
Thank you, Sunil. Now I'll introduce another Sunil. He's Sunil Ambulkar, again a very good friend of mine. We have been together in many conferences. So Dr. Ambulkar is MBBS, MD, and DM endocrinology and DNB endocrinology. And he has also done MRCP general medicine from UK. Professor HOD endocrinology, Government Medical College and Super Specialty Hospital, Nagpur. He has many fellowships and he is also very active in academics. Have published many papers, and also we saw him delivering very good lectures in various conferences. So over to Sunil Ambulkar.
Thank you, Dr. Sushil, for those kind words. Congratulations to Sunil. This is his 10th diabetic academic function. The topic allotted to me is a bit different from normal. It is non-diabetic hypoglycemia. I will go through the slides within 12 minutes. Next slide. Now, hypoglycemia means you have to satisfy Whipple's triad. Whipple's triad is symptoms of hypoglycemia, relief of symptoms after correction of hypoglycemia. It is a form firstly of Addison disease, multiple endocrine neoplasm type 1, congenital adrenal hyperplasia, and growth hormone deficiency. Sometimes it can present to you with a bizarre presentation. It can present with a psychiatric wards, angina pectoris, or Todd's paresis. All said and done, 60% hypoglycemias are because of insulin, alcohol, and sulfonylureas. 15% are because of chronic renal failure, and 15% can be because of acute fulminant liver failure or chronic liver disease. Falciparum malaria is seen rarely now. The disease itself can cause hypoglycemia, and the treatment of disease also causes hypoglycemia. Then there is artifactual hypoglycemia, where high loads of cells like leukemia, hemolytic crisis, polycythemia vera leads to hypoglycemia. We are using continuous glucose monitoring system for monitoring patients. In a lower range of CGSS, we get artifactual hypoglycemia. Then, of course, delay in processing the sample will also lead to hypoglycemia. Now, if you look at ADA 2024 guidelines, hypoglycemia is classified as level 1, level 2, and level 3. Level 1 is when the blood sugars, plasma glucose levels is less than 70 but more than 54. Level 2 is when the plasma glucose is less than 54. And level 3 is a severe event characterized by altered mental and physical status requiring assistance of a treatment for hypoglycemia, irrespective of whatever the blood glucose patient has. As I said, they have adrenergic symptoms, neuroglycemic symptoms. Adrenergic symptoms are norepinephrine mediated, like anxiety, palpitation, and tremors. Acetylcholine mediated are sweating, hunger, and paresthesias. Neuroglycemic symptoms are weakness, behavioral change, confusion, convulsion, focal neurological deficit, coma, and death. The body has an inherent tendency to fight hypoglycemia. Whenever the glucose level falls to 80, the insulin secretion goes down. When it falls to 70, epinephrine and non-epinephrine secretion goes up. Similarly, glucagon levels goes up. Over a period of time, growth hormone and cortisol hormones will rise. This is the defense mechanism of a body. Fasting hypoglycemia means it occurs after 5 hours of meal. Postprandial means which occurs within 5 hours of meal. While evaluating a patient of hypoglycemia, we have to look at the patient. Is the patient ill appearing or is the patient is healthy appearing? That will give us a clue. Fasting hypoglycemia and postprandial hypoglycemia are common in insulinomas, autoimmune hypoglycemias, and adrenal insufficiency. Then there are a host of the causes which I would like to deal with a case presentation. There are various different drugs which can cause hypoglycemias. They can be pentamidine, clarithromycin, SNRI, SSRI, tramadol, gabapentin, acyanthrite fruit, long QT intervals sometimes associated with potassium channel problems. Recently, I saw a patient of CA prostate on LHRH agonist. I investigated him thoroughly. I could not find a cause, and then I got a reference that LHRH agonist can sometimes rarely cause hypoglycemia. I will go through 2 to 3 interesting cases to find out what is the importance of non-diabetic hypoglycemia. He was a 14-year boy from Bhilai steel plant, known case of IDDM since 2009, on basal bolus therapy, diagnosed classically on the presentation. He had 2 episodes of decay, one was spontaneous and one was with otitis media. He had recurrent episodes of hypoglycemia, especially after food, that too after night dinner. He had history of drowsiness. He had seizures. Blood sugar recorded was 31 to 38. Patient used to feed a thick sugary syrup. They used to prepare a thick sugary syrup, and throughout night, one of the parents used to remain awake. This fellow has put on a weight around 10 kgs for last 6 months, and his calorie intake was like to 4,000 to 5,000 kilocalories. In the morning, he'll become all right. He went throughout India, throughout all places in India, but he could not find the cause, and he came to me. And I will tell the story in detail now. He was not on insulin for 24 hours. Blood sugar at 8 p.m. was 367. He was treated with Apidra 2 unit and Lantus 2 unit. After 1 hour of dinner, his blood sugar dropped down from 64 to 34 within 15 minutes. He was treated with 25% dextrose followed by 10% trips. I have never given in my endocrine practice that much of dextrose which I given on that day. Patient received 20 vials of 25% dextrose and a 10% dextrose drip. The dextrose drip is very irritant to the veins also, and sugary syrup. Endocrinologist has no habit of remaining awake at night. I don't find endocrinologist goes in the ICUs and stays with the patient and stands for 4 to 6 hours. On that day, I was awake throughout the night for the first time. He was drowsy in the night. He was refused to eat orally, but in the morning he was perfectly all right. His investigations were normal. He was investigated further. The differential diagnosis of this condition is honeymoon. Honeymoon phase lasts for less than 1 hour, 1 year, not like this. Insulinomas, we did a CT scan was normal. Retroperitoneal tumor, CT scan also normal. Then there is an entity called autoimmune hypoglycemia. The entity composes of two things, insulin antibodies and insulin receptor antibodies. Insulin antibodies is the erratic release of insulin from these insulin antibodies. And the tendency is to release this insulin at night after dinner. So huge amount of insulin is released. Initially he was acting like IDDM. After food, huge amount of insulin is released and he is acting like insulinoma. And this patient had severe hypoglycemia, insulin receptor antibodies. This can occur in diabetic, non-diabetic, especially sulfhydryl group of drugs. Neomercazole is one of the drugs which can precipitate such kind of pictures. The parent said, डॉक्टर साहब अभी छुट्टी कर दो, अब सब घूम के आए हैं, आपको भी आजमाया है, आपको भी समझ नहीं रहा इनको क्या हो रहा है, you just give us discharge. So I told him that we have to do insulin antibodies. It will take 4 days from Bombay to come the report, but he didn't stay in the hospital. And after 6 months, I had a contact with him. These antibodies disappear within 3 to 6 months, and this patient do not have hypoglycemia now. He's on original insulin dose. This was a case of autoimmune hypoglycemia, non-diabetic hypoglycemia. Insulinomas are very common. This is a big businessman, industrialist of Nagpur. The story is interesting. In the morning, he used to get up, married for 25 years, and the wife said, सवेरे उठता है और गंदी गंदी गाली देना चालू करता है. इतनी गंदी गाली देता है कि मैं आपको बता नहीं सकती. और जैसा मैंने शक्कर वाली चाय इसको पिला दिया, ये शांत हो जाता है. अदरवाइज ही डांसेस ऑन द बेड एंड सबको घर को सबको गालियां देता है. He came to my chamber. His blood sugar was low. He took a sample for insulin. Insulin was more than the blood sugar. Did this CT scan. The CT scan showed tumor at the tail of pancreas. While evaluating a patient of suspected insulinomas, we have to do either 16 hours or 72 hours fasting hypoglycemia state. The diagnosis depends on various parameters. The parameters are fasting or random blood sugar less than 45, insulin is more than 3. In fact, any amount of low glucose, if there is a reasonable amount of insulin present in the body, that becomes inappropriate insulin secretion for pancreas for that kind of hypoglycemia, that kind of levels of blood sugars. C-peptide has to be more than 0.6. Pro-insulin we don't do. Still we do ketones, but best is to do beta-hydroxybutyric acid, antibody screen, sulfonylurea screen in urine for sulfonylureas and meglitinides. Then we do a glucagon test. Give 1 milligram of glucagon there has to be a rise of 25 milligram within half hour. So these are the tests which we do, and we do a CT scan. Insulinomas are equally distributed in head, body, and neck of the pancreas. 10. Insulinomas are the second pancreatic neuroendocrine tumor. First is gastrinoma. 1 to 5% of MEN can present with insulinomas. We used to have contrast enhanced CT with a rapid arterial and venous phase for early detection. Now we have Dotatex 68 gallium Dotatex PIT. The recent armamentarium addition is 68 gallium extending scan, CT or MRI. This is the investigation of choice today. This is another lady of 46 years old, was admitted in the hospital, Sims Hospital here. This patient with hypoglycemia. If you look at the first, second, and third and fourth picture, within 2 minutes, the dye was appearing. The second, there was a dye. Third, the dye gets fading. And fourth, there is no dye. So if you do a sequencing in arterial phase, it has to be done within 2 minutes. Otherwise, you are going to miss this insulinomas. CT contrast disappears within minutes of administration. As I said, these are the tests. Then there are different other investigation tests like endosonography, USG surgery. We do selective intraarterial calcium with doubling of insulin levels. If you have operated insulinoma and you fail, then you have to detect head, body, and tail. Give selective intraarterial injection. If you give it a supramesenteric artery, inferior mesenteric artery, and splenic artery, and find out the insulin at the hepatic vein. If it is more than 5 times the expected normal, then that part of the body of pancreas have tumor. Then we have to go again for surgery. This test we really don't do, but still this is the important test. We have now seen many bariatric patients now. Bariatric surgery has become very common. We have bariatric surgery complications as well. We have post-bariatric surgery hypoglycemia. It is a form of mild hypoglycemia, but it does occur after 6 to 12 months of surgery. Early dumping occurs within 3 to 6 months. This is a sort of late dumping syndrome which occurs 6 to 12 months after surgery and after 1 to 3 hours of food. Many top guns of Nagpur city have this problem. What is the pathophysiology? Pathophysiology is there is a greater secretion of GLP-1 and insulin. There is a lower insulin clearance, diminished beta cell suppression, impaired counter-regulatory response. The diagnosis of this condition is on say blood glucose monitoring and documenting Whipple's triad or mixed meal challenge test. Treatment of this condition is use of complex polysaccharides rather than glucose, change to fructose, give adequate amount of fats and proteins, alpha glucosidase inhibitors. While patient is on alpha glucosidase inhibitors, you can't give sucrose. You have to give glucose for reversal of hypoglycemia. It is alpha. It's important to know diazoxide, somatostatin analog, calcium channel analogs, GLP receptor antagonist exentin trials are going on to treat this. Just last 1 minute. Gastrostomy tube. I will finish my talk by one interesting case. When I was resident 32 years back in Nair Hospital, we had a case of insulinoma. At that time, CT was also not evolved. At that time, radioimmunoassay of insulin was also not evolved. But we got a report that a suspicious lesion in there in the pancreas. It lasts 1 minute. We got insulin level of 5 to 6. Patient went for operation, did 2/3 distal pancreectomy, but hypoglycemia persisted. Then patient had absolute constipation. Surgical reference was made. Did a PR. In the PR, they found a large tumor in the rectum, post-rectum place. That tumor was secreting IGF-2. Patient got benefit of surgery. The tumor was removed. We could not do IGF-2 at that time, but that was a sarcoma and patient got relief. This is IGF-2 producing sarcoma. So in short, I told you about hypoglycemia, non-diabetic hypoglycemia, manifestation and treatment with rare presentation. Hand over to chairman.
Thank you, Sunil. I think you have nicely covered and also had some anecdotal cases. House is open for short 1 or 2 comments or 1 or 2 questions. Anybody? Shinjan? Sunil, what is the role of measuring ketones in blood or urine when doing an
If
extended?
the insulin is high, ketone has to be low. When the insulin is low, ketones are high. So whenever there is a hyperinsulinic type of hypoglycemia, urinary ketones has to be low, but we don't measure that beta hydroxybutyric acid. Westerners do it. We don't have that facility at present here.
Suppose you're doing extended GTT and patient throws ketones in urine or it's high beta hydroxybutyric acid, then we can presume that there is no insulin.
Definitely there is no insulin. If insulin is high, ketones has not to be there.
Thank you, sir, for a wonderful talk. Sir, what's your experience currently in practice for last maybe 5 or 10 years about the incidence of this autoimmune hypoglycemia? Like the incidence, is it kind of
No, I have seen only 2 cases in last 30 years. I think Sushil must have seen some cases.
See, we have seen a few cases, I cannot remember, but at least 4 or 5 cases, and we call it Hirata syndrome.
yes,
You're right.
So
It's a Japanese syndrome.
yes,
yes,
The Japanese syndrome. Japanese scholar has described this syndrome.
right. So it's
Recently
not,
this description.
it's really quite rare. I mean, in practice,
We are now insulin antibodies available. Insulin receptor antibodies are not done.
insulin autoantibodies are available,
Available.
cost approximately 4,500.
Yes, that are available. I did it for some patients.
Right.
I did it for autoimmune diabetes patient. It's a very interesting case. Autoimmune diabetes mellitus.
thank you. Sir.
Anything?
Thank you very much. I request captain.
Yes.
I request our captain
Thank you, Sunil.
to
We'll finish this.
felicitate
Thank you.
Dr. Ambulkar at the felicitation terminal, right side of the stadium, our podium. The next captain is Dr. Prashant Govardhan. Dr. Prashant Govardhan is associate professor at Priyadarshini Institute of Engineering and Technology, Nagpur. Is a past secretary, Diabetic Association of India, Dr. Prashant Govardhan.
Good morning, everyone. Our next lecture is by Dr. Shinjan Patra, sir. He is a present designate assistant professor and consultant endocrinologist, and he is affiliated to Department of Endocrinology at All India Institute of Medical Sciences, Nagpur. Over to you, Dr. Patra, for your deliberation.
Thank you, respected chairperson, for the kind introduction. At the outset, I must thank Dr. Sunil Gupta, sir, for kindly inviting me to this conference. This is my first time in this Hello Diabetes. I really feel privileged and honored to be here. So, I am Dr. Shinjan, assistant professor in AIIMS, Nagpur in endocrinology. So, I will be talking about in next around 12 minutes about the current status of Liraglutide, its biosimilar form, which is currently used in India as well, obviously approved in US and European Union. So we'll be briefly discuss about the role of Liraglutide, its current efficacy, safety data, and how is it good for weight loss. And we are using it quite often in our diabetes practice, and as well as the use of biosimilar in currently in Indian setting. So this is from a ICMR India study which has been published in Lancet. The publications is going on. So from the main article which has been taken as the prevalence, where the prevalence has been the diabetes prevalence and the pre-diabetes prevalence is alarmingly high. It's going into the double digit, and the diabetes is 11%, and we are definitely becoming the diabetes capital in next few years. But the most important is this concept of diabetes and obesity, which is currently about 60 to 90%. So the diabesity is actually a serious metabolic complications of diabetes. The diabetes and obesity having a very much common, strong pathophysiological link, and the ideal treatment should address both of these concerns. So what happens with the comorbidities in cases of diabesity? So the diabesity leads to MSLD, which is a metabolic associated steatotic liver disease, obstructive sleep apnea, ASCVD hypertension, and dyslipidemia. The mechanisms like the hypoxia with OSA leads to insulin resistance. There is lipid imbalance leading to adipose tissue deposits. The endothelial damages lead to CVD, and ultimately the structural damages to the kidney. So obviously what happens, the diabetes and obesity leading to the multisystemic involvement. So what's the guidelines currently about the type 2 diabetes and the obesity? So this is from the ADL latest 2024 guidelines. So what we can get is in the type 2 diabetes, what the option we have is the semaglutide, the GLP-1 analog, the GLP-1 receptor analogs. The very high efficacy has been shown by semaglutide and tirzepatide. But today's topic of discussion in my talk is about the liraglutide, which has shown a pretty decent efficacy as well. So what happens with this, what's the choice is that in a type 2 diabetes with ASCVD with high risk patient, we will choose this GLP-1 receptor analog, which is shown, which has got a proven ASCVD benefit. And that's why it has been good again in NFLD or what is called an MSLD right now. So what are the evidences we can see? And also the glucocentric algorithm from the AACE guidelines also have highlighted that whenever the patient is having type 2 diabetes with overweight and obesity, our first choice should be between GLP-1 receptor analog and and SGLT2 inhibitors. So a basic discussion of the liraglutide, what will we do about the holistic management? So it's going beyond the glycemic control and what's the extra glycemic benefit. So this is a data of the NFHS, which has got the which shows the prevalence of the overweight and obesity, and which has increased to about 20% till 22 to 24% in the various states of India. So the scale study is one of the landmark studies in the diabetes in liraglutide. So what it had got a 3-arm. One had a subcutaneous liraglutide of 3 milligram, another has a 1.8 milligram, and another was the placebo arm. So it included the obese patient, BMI of more than 27, more than 18 years of age, and on patients with metformin, thiazolidinediones or sulfonylureas, and HbA1c of more than 7 to 10%. So what they study is the endpoints were the relative changes in the weight and proportion of the patients losing 5 to 10% of the body weight. So it shows a definite benefit in terms of change in fasting, change in body weight, as well as the change in fasting blood glucose level as well. So the weight loss was significant, about 6% in liraglutide in a 3 milligram dose and a 4.7% in 1.8 milligram dose compared to 2.2% with the placebo. The next study was published in NEJM about the healthy weight loss maintenance with exercise, liraglutide or both. So what it had also 4 arms. So it was a exercise group, one had only exercise, one had only liraglutide, one has exercise plus liraglutide, and another was a placebo. Similarly, it was obese with a BMI taken was 32 to 43 along with a low calorie diet. Similar endpoints were used. So what we did get here is, So what we did get here is among the 4 groups, the maximum weight loss response was obtained in the combination group. It was around 9.5 kg, and only in liraglutide it was in 6.8 kg. So the combination of exercise liraglutide has shown the best of the responses. Again, the next study was published as a scale obesity and prediabetes. It was also similarly double-blind study. Here, the important thing was that the liraglutide was studied only as a 3 milligram dose and included patients were non-diabetic patients with a BMI of 30 or 27 to 30 with a comorbidity. Similar endpoints were used, and what we get here is similarly, the body weight, the reduction in the body weight was significant in the liraglutide group, and compared to the placebo, the percentage of the patients receiving having 5%, 15 or 10% or 15% body weight was more in the liraglutide group. So coming to the slightly lower dosage of the liraglutide, we have used in 1.8 and we have used in 3. So this was a study published where they have shown the efficacy of the low-dose liraglutide among the Taiwanese non-diabetic patients. So it was a liraglutide injectable of 0.6 to 1.2 milligram per day, and it was shown to, the study was about for 12 weeks. And so the efficacy percentages were also here significant, where 44% achieved a weight loss in 1.2 milligram group and 32% in the 0.6 milligram group. And the odd factor, the young age, was found to be an important predictive factor. So then they come as a meta-analysis for liraglutide. So they have collated all this phase 3 data. Total phase 3 studies were 7 and randomized control were 4. Total number of population were little over 6,000, and they have shown a significantly beneficial role of liraglutide with patients without diabetes, with diabetes, and no specific diabetes state. Similarly, as I have already stored, the non-alcoholic fatty liver disease or the MSLD, which is a common pathology currently with the diabetes, so it has shown a beneficial effect on that. And this was a meta-analysis published where versus placebo with pioglitazone, the liver fat content was decreased mostly significantly. The forest plot showing mostly favoring the experimental or the liraglutide group, and similarly when we talk about the BMI, it's mostly favoring the liraglutide group. About the meta-analysis which was discussed here, the various studies which were included, the most importantly, the outcome were studied or the diagnostic was quite different, like MRI, ultrasound or liver biopsy, and all of them had a decent follow-up of around a year or half a year, and it was a control was kind of a metformin or other anti-diabetic drug, and the liraglutide fared well in all these groups. So the liver fat content in this meta-analysis had also a mostly a significantly benefit with using a liraglutide. So what it does actually, the liraglutide in a diabesity patient, so obviously it's a genetically engineered GLP-1 analog. So the most important thing is does is that delays the gastric emptying, reduces the glycogenolysis, gluconeogenesis, and obviously it will stimulate the insulin release. But I would like to highlight this point. It has been shown to act on the hypothalamus, decreases the appetite and improves the satiety. So ultimately, patients, the calorie dense snacks which the patient used to take, the obese patients or the type 2 diabetes patients, have a significant reduction by using GLP-1 receptor analog, mostly as a class effect, and liraglutide is obviously an example of that. So the FDA approval of liraglutide stands currently in type 2 diabetes patients. Victoza was the original brand of the liraglutide. 0.6 milligram to start. We should increase to 1.8 milligram. This is only about the diabetes. Where to use diabetes adjunct to diet and exercise to control the blood glucose level and to reduce the CV events. But for only obesity without diabetes, the Saxenda brand was initially approved. It has to be started at 0.6 milligram per day, and the target dose is 3 milligram per day. So that's 1.8 milligram, and here for obesity only 3 milligram. But again, with the advantages, it comes with the basic problem is about the access. It's basically about the cost, and in Indian setup we need to take care of that, and by that the concept of liraglutide biosimilar has come. So what's basically liraglutide biosimilar? This is an area of kind of a biosimilar, and from Indian market, from US market to European market to Indian market, the biosimilars are a hugely popular, and they have occupied a huge market level as well. So what we are seeing between the biosimilar and the reference biology, the difference is very little. It's mostly about the product, like here the propylene glycol, and here the glycerol has been used. The pH is slightly different. For biosimilar, it's 7.2 to 7.5, and the reference biologic is 8.15. So the phase 1 study, which has shown the pharmacokinetics of between the biosimilar and the biologic, has been very similar, where we have shown the Cmax area under curve has been similar. The bioequivalence acceptance criteria has between 90% of the confidence interval, and here we can see the ratio has been 90 to 125, and the ratio is between 110 108 has been that. So the Tmax, the T half, and the elimination constant has been very much similar between the biosimilar and the reference biologic. So the phase 3 study, which has been the most important in the liraglutide biologic, so it was a randomized multi-center parallel arm blinded assessment containing 256 patients, and it was divided into two arms. One had a biosimilar and another had a reference biologic. So the primary endpoints were HbA1c, and the secondary endpoints were the fasting PP, body weight, and the percent achieving the target HbA1c of less than 7. So this was the baseline characteristics. It was mostly similar between HbA1c, fasting, weight, BMI between the biosimilar and the reference biologic. So what we get, both of them had shown a very similar reduction. Yeah, it's 1 minute left. I will finish it within. So it's similar HbA1c reduction between biosimilar and the reference biologic. And importantly, the secondary efficacy data were also very much similar. The body weight reduction, the fasting blood glucose, and the postprandial blood glucose reduction. And there was no statistically significant difference between the liraglutide biosimilar and the reference biologic. About the safety data, obviously it's very important. The adverse events, the treatment emergent adverse events, and the maximum severe, mild, moderate to severe adverse events were also very much similar between the biosimilar and the reference biologic. And what we can see, the autoimmune pathology when we use and some other new drugs, the antibody titer, low antibody titer was found in few of the patients, but otherwise medium and high was none was found. So low immunogenicity found in both the groups. So the benefit is biosimilar is obviously it's very promising in terms of efficacy, safety, and most importantly about the cost, because the cost is one of the major hurdles, and that's why the Indian Drug Control, the DCGI, has granted the authorizations of the biosimilar. Some just last slide about the new evidence of the liraglutide, where it has shown apart from DPP4 inhibitors, the increase of the GLP-1, it has got a pleiotropic effects as well. So it has been definitely much beneficial compared to the DPP4 inhibitors. And if we talk about this glycemic deterioration, weight gain, or recurrent hypoglycemias, these poorer outcomes is very much less chances with the liraglutide. And last is about the health-related quality of life, where the liraglutide has fared well compared to the other anti-diabetic. So just to summarize, that diabesity is one of the most important concern in our country as well and in the whole world. And the guidelines has recommended GLP-1 receptor agonist to be one of the important one of the important choice of therapy. Scale trial was initially one of the study which has given the liraglutide a very much good beneficial among 8 to 9% of the body weight reduction, and it has established it has a therapy in type 2 diabetes with the CV events. The biosimilar product of liraglutide has shown a non-inferiority, and definitely it has got a more access into the lower cost. So thank you for your kind concern. I will be happy to answer any of the queries.
Thank you, Dr. Patra, for the excellent lecture. Any questions from the audience or any comments?
Yes, sir.
Dropout rate, dropout.
Sir, in which studies, in scale or studies? Because sir, in scale studies, the initial liraglutide doesn't have much of a dropout rate. For the last, which I have shown in a 256 patients between biosimilar and the reference biologic, there was only 3 patients were dropped out. This was.
Out of how many patients?
This was in the last, it was only about between 256 patients, among 256. Yes, sir. So I've in my practice I have used I think around 3 patients of this biosimilar liraglutide. I think it's just for the initial phases. One of the patient has come back after taking around a month, and the dose has been escalated to the 1.8 milligram. It has been still showing he has lost. I think the patient was female, so she has lost weight, I think around 3 to 4% in around 1 month of therapy, but it has still a long way to go till we take it as a very much definite choice of therapy. Actually, the problem is the real concern, or I think the basic practical concern, is to compare with the semaglutide which we have as an option as an oral semaglutide, and if you like compared to the injectable liraglutide. But as an injectable choice, especially when diabetes with obesity is there with a CBD events, it's a very much reasonable choice, and we definitely can use. And within a year or so, I think we'll have a good data to actually stamp its use more in our clinical practice.
Over to organize it.
Hello. Thank you very much,
Thank you.
pilot sir and captain sir. I will request our captain to felicitate our pilot, and I request Dr. Sunil Gupta to join at felicitation sir.
And meanwhile, let us move on to our next slide, that is celiac diseases in type 1 DM, an underestimated entity. And for that, I would like to call upon Dr. Smith Srivastav sir, who is the professor and head in the Department of Cardiology at JNM Medical College and Bram Hospital, Raipur. And he's a winner of National Gold Medal and the best paper at the Cherry-Gon. So we welcome you, sir.
Next.
Okay, and Dr. Praveen Pant, sir, who is a cardiologist, senior cardiologist from Chandapur. We welcome you, sir.
Good morning. Here I call the pilot, Dr. Ashish Dengra, who is a diabetologist, thyroid and obesity specialist, a director of Mahi Diabetic Thyroid Care and Research Center, Jabalpur. He is a diploma in diabetes, Cardiff University, UK, and CPS Diabetology, All India Institute of Diabetes, SL Raja Hospital, 2008. He is an organizing secretary. He was an organizing secretary of a lot of conferences and preceptorship course in diabetes in Italy in 2011. Over to Ashish Dengra, sir, please.
Thank you. Thanks a lot to Gupta sir for inviting us to this very interesting flight that is Hello Diabetes. And I hope in this Sunday morning we all are flighting safe and may reach the destination very soon. So without wasting time, we will be discussing in this journey of Sunday morning session, which is dealing with the celiac disease in type 1 diabetes, which is very underestimated entity. We all know that it is not screened in the type 1 diabetic patient so commonly, in which it is seen in the nearly 6% of patients. So we will see how it is important to check the patients who are having symptoms of GI. We are getting confused with the gastroparesis or any other symptoms. So the celiac disease and type 1 diabetes, they are immune mediated, and they share common susceptibility factors, notably HLA genetics. So what is the link between the two? The link is in type 1 and type 1 diabetes and celiac disease was first established in 1960, and the estimated prevalence of celiac disease in patients who are having type 1 diabetes is about 6% and 1% is in general population. So we see here that the 6% in the type 1 diabetes and is estimated, and the thing is that we are not checking for the celiac disease in the patients in our busy schedule. So due to the significantly higher prevalence of celiac disease in patients with diabetes, many doctors recommend to get screened for the celiac disease after the diagnosis of type 1 diabetes is confirmed, or vice versa. If the celiac disease patient is coming to your clinic, you may screen for, you should screen for type 1 diabetes also. So 7 to 12% of those with type 1 diabetes have celiac disease, if we see vice versa. Common presentation is unpredictable blood glucose. Hypoglycemia may occur in these patients who are having celiac disease due to the nutrient absorption problems. And deterioration of blood glucose control suddenly if the patient of type 1 diabetes comes to your clinic and he says that he is having GI symptoms, which we'll be discussing, and its glucose are going haywire, you should suspect the celiac disease. And the GI symptoms may mimic, or you may get confused with gastroparesis, because we have been taught that in diabetes there is gastroparesis and all the symptoms of GI are related to gastroparesis. That's why we should be vigilant, and patient coming to your clinic may be asymptomatic and having celiac disease. So what is celiac disease? It is an autoimmune disorder of the small intestine that occurs in genetically predisposed people of all ages from middle infancy. Celiac disease is caused by reaction of gliadin, a gluten protein found in the wheat, barley and rye. So it is commonly used cereal which we are using in our day-to-day practice, and it is an autoimmune disorder in which the villi is disturbed and they become like tiles, flat. So the absorption is a problem. What is the incidence? It is commonly seen in 1 in 100 people worldwide, 4% in South America, 0.5 in Africa, and 0.6 in Asia. And the prevalence in children between 2.5 to 15 years of age is 3 to 13 per 1,000 children, approximately 1 in 300 to 1 in 80 children. Risk factors: any family member who is having celiac disease, type 1 diabetes, Turner's, Down syndrome, rheumatoid arthritis, or Addison's disease. you should suspect celiac disease in the patients if they are having the GI symptoms. So celiac disease occurs in the environmentally in the genetically predisposed persons. Some of the environmental factors, they leads to immune dysregulation, and there is destruction of the small intestinal villi, and they are damaged. So the absorption problem is there in the duodenal part. So villi projections are damaged, and there will be vitamins, minerals, and the GI symptoms will be there. Vitamin deficiency may be there, mineral deficiency, ultimately leading to many problems, and child growth is hampered. This is the schematic diagram which we learn in our MBBS times, that how the genetically predisposed persons, some of the environmental factors, in this case, it may be the viruses or any other external factors leading to immune dysregulation and disruption of the villi. So, sorry. The characteristics of type 1 diabetes, we all know that it occurs before the age of usually 30 years, requires exogenous insulin. If you don't give, they may end up into coma and death. And the symptoms include weight loss, polyuria, and polydipsia. So in some patients, they may have common symptoms as celiac disease because of the poor nutrition, because of the absorption problem. The celiac disease patient may also have the symptoms of weight loss. So you may get confused. So this is the genetically predisposed HLA, DQ, D8 variants. And infant feeding, if you are not giving proper breastfeeding, and if you are giving the child before 6 months of breastfeeding the wheat products, they may have the more chances of developing the celiac disease because of the autoimmunity. So breastfeeding exclusive for 6 months is very important. Genetic factors, like environmental factors like virus, gluten, probiotics in type 1 diabetes, the leaky gut, intestinal mucosal leakiness may be seen in celiac disease. What are the classical symptoms or presentation of celiac disease? The classical are diarrhea, bloating, and weight loss, growth failure in children. So you may get confused, he is having weight loss. So these symptoms along with GI symptoms, you should suspect the celiac disease in type 1 diabetes coming to your clinic. The non-classical symptoms are constipation, heartburn, neuropathy, ataxia, and osteopenia or osteoporosis may be seen, and anemia. The clinical manifestation may vary. Under 2 years of age, mainly vomiting and diarrhea is there, swollen belly, failure to thrive, and in older children, diarrhea, constipation, weight loss, short stature, delayed puberty, and neurological symptoms. What are the associated immune disorders which you should look in the patients coming to your clinic with type 1 diabetes and you are suspecting celiac disease? They may have associated Sjogren, Addison's, cardiomyopathy, alopecia areata, rheumatoid arthritis, and down we have already discussed. And dermatitis herpetiformis, thyroid disease they may have, or SLE or liver disease. So diagnostic evaluation is very easy. Go for the first you detect clinically that they may have celiac disease. If the patient is type 1 diabetic coming to your clinic with GI symptoms, as we have discussed, the bloating or diarrhea, and if you are suspecting, go for the full blood count, electrolytes, because the absorption is disturbed through the villi, the calcium, B12, folic acid, prothrombin time. The basic test which nowadays we are doing is TTG, the tissue transglutaminase antibody, or against the endomycin or against the reticulin. HL genetic testing may be done, or biopsy, which is the gold standard. So you can see that TTG is having very good sensitivity and specificity, and mostly this test is recommended for screening. Gold standard is duodenal biopsy. You will see the flattening of the villi and should be performed if clinically suspicion is very high, regardless of the serology. You should assess the electrolytes, calcium, protein, kidney function, and there may be deficiencies of iron, folate, fat soluble vitamins, and the inflammation due to the autoimmunity, the ESR, CRP may be raised. Screen for osteoporosis because there is calcium and vitamin absorption is hampered, and monitor the growth and development in children. What is the management? Very simple. Like, what is the dialogue in the movie serials? What is the main thing? They say entertainment, entertainment, and entertainment. Here, only gluten-free diet will change the life of the celiac patient. So gluten-free diet, and gluten-free diet. Total avoidance of wheat, rye and barley in the diet. So mineral vitamin supplements, enzyme therapy, folate supplements, iron supplement are very important. The non-pharmacological treatment, that is lifestyle modification, gluten-free diet, type 1 diabetes and celiac disease, if they are in the same patient, already we are very much puzzled in managing the type 1 diabetic patients with insulin, and he develops celiac disease. His life will become haywire. So double diet is challenging because don't has to take gluten and we are avoiding the other carbs also. So the label reading for gluten and carbohydrate free foods are higher in carbohydrates. So the gluten-free diet, if we are giving to type 1 diabetics, they are having more carbohydrate in all the diets which are gluten-free, most of the gluten-free diets. We will see the chart. The initiation of gluten-free diet, it reduces the hypoglycemic episodes. Must treat hypoglycemia with gluten-free foods also. So gluten is a cohesive elastic protein commonly found in products that contain cereal grains, and the toxic proteins in celiac disease. This was the most common question in our PG exams, that gliadin, anti-gliadin antibodies, the wheat, the rye is having secalin and the barley is having hordein. So foods with gluten, you remember this, you can take picture of this: canned soup, ice cream, candy bars, instant coffee, pasta, pastries, yogurt, and wheat, rye, and barley. Gluten-free diet is corn, rice, beans, potato, lettuce, but you see here they are having more carbohydrate. So they will hamper the blood glucose control. Tomato, spinach, cheese, nuts, seeds, almond, avocado, and peas. You see here the wheat flour is having carbohydrate per gram is 95. And if you give the gluten-free flour, it is 130 carbohydrate. Topiaco is 128. Potato flour 134. Garbanzo 200. Quinoa is 116. So like this, you are in the condition in which you are stuck, that you are controlling type 1 diabetes with low carb diet, but now your patient develops celiac disease, and you are saying give the gluten-free diet. But gluten-free diet is having more carb contents. So you are now having more problem with the control of glucose. So food labeling is very important. This statement is very important. Not all wheat-free items are gluten-free. However, all gluten-free foods are wheat-free. So wheat-free is gluten-free. This is important. The gluten-free is being defined by for voluntary use. So barrier to adherence to gluten-free diet is very costly. That is also another problem. So high cost, poor availability in India also, inadequate labeling, and diet is also not focused on these diets. So prevention is very important. Avoid the infections or take treatment immediately. Breastfeed the baby. Avoid gluten-containing foods. Very important therapy will be insulin therapy in these patients. So the takeaway message is, in the type 1 diabetes and celiac disease, they are autoimmune disease with considerable clinical and pathogenic overlap, as we have seen. There is a clear common risk factor. Additional genetic environmental factors play an important role in disease initiation. Given the increased prevalence of having both conditions and frequent lack of classical intestinal symptoms, the CD screening is currently recommended in patients who are having type 1 diabetes with GI symptoms. The sensitive and specific serology tests should be performed, that is TTG, anti-TTG antibody, IgA. The GFT may be challenging for some patients, that is gluten-free diet, and those who are already on the diet restriction for type 1 diabetes. So, how we can manage these patients? We require a team, not only for only glucose control, but the challenging disorder can be successfully managed with education, utilization of available technology and resources, consultation with a skilled dietitian, because we are not focusing on the gluten-free diet. Education about the disease, long life adherence to gluten-free diet is very cumbersome, and identification and treatment of nutritional deficiencies, as it is very common in celiac disease patients with type 1 diabetes. Access to adequacy group, continuous long-term follow-up. So the group counseling, the proper dietitian should be giving proper uh, diet with these patients who are having type 1 with celiac disease. So it is a teamwork. It is not only possible with the only the doctor who is taking care of diabetes, but you should have the skilled dietitian and the educational team. Thanks a lot for patient hearing. Thank you.
Thank you, Ashish Degra, sir. The now house is open for questions. If any.
It was a very nice talk, Ashish. A very relevant topic that you covered and really needed. One point, we had a paper on this, celiac follow-up and the type 1 diabetes. So one thing is that once it is done and it is negative, it does not mean it will be negative. So we followed them up, and in follow, we found good number of patients type 1 developed. So this is, I think, important message.
The antibody may be negative in some of the patients.
And second thing is, those who are having type 1, they are basically autoimmune disease. They are more prone to have other autoimmune. So additions many times is missed. So that one has to keep in the mind, that if the blood sugar is unusually controlled or unusual hypos are there, so I think that should be taken care of.
Thank you.
Ashish, just wanted to know whether oat can be used in celiac disease.
Oat.
Because oat, there are so many biscuits and all those things available.
Yeah. So basically, they are making the multigrain biscuits nowadays. So you have to see the label. If they are having any little amount of wheat, barley, or rye in that, you should avoid it. Otherwise, oats can be taken.
Very good talk. Thank you so much. And I just wanted to share, it's not as uncommon as we think, and it's different in rest of the country, different from different parts of the country. We recently screened 500 children in our clinic, and we had 48 who were positive. And we are following up. And so we realized this is a very low resource setting. And we realized that initially we used to just pick up children who had symptoms, because we did not have resources. So the symptoms that you mentioned, but then we realized it's important to pick many of them, because 10 of them were without any kinds of symptoms or growth. We could not have picked it up. Maybe it would have come next year when we would have done it. So now we are taking that time out to find money to do this for every child at least once a year. So I think it's a good investment to do.
One message also I want to give, because while reading the theory for making this presentation, we are confusing with the pancreatitis, post-pancreatitis patient, because many young patients are coming with the insulin-dependent patients are coming to our clinic from some another doctor, and they are taking insulin, and they are very at the age of 18 or 19, and we are thinking that they are having secondary diabetes, and we are treating them with the enzymes like Rion, but they may have celiac disease. So we should have a very good suspicion or very high suspicion in the patients who are coming with insulin therapy, and if they are diagnosed with either post-pancreatitis, if you have not confirmed, go for the celiac disease testing also. So you should screen, like Madam told, that the prevalence is high. So we should screen these patients with type 1 diabetes and GI symptoms.
Ashish, it's good lecture. We have to do IgA antibody also.
IgA.
And this antibody is only a presumptive test. 4-quadrant duodenal biopsy gives the final answer. This is one of the cause of subtle short stature. Others are juvenile hypothyroidism and RTA. There is a role of steroids, but steroid will damage the blood sugars. Some patients do require steroid for a long period of time. And celiac disease is not a disease of children. It can occur in middle age, it can occur in old age also.
Thank you.
Thank you, Dr. Ashish Dengra. Thanks, sir.
Thanks, Dr. I request our captain to felicitate our pilot.
And I would like to thank all the captains and the pilots for landing the flight safely. And here we are to move to the next flight. Let's take off. So yeah, for the next flight is the in-flight aroma. And for the first session, I would like to call upon Dr. Abhishek Pandey, sir, who is a consultant physician, diabetologist, intensivist, an assistant professor at LMH Nagpur, and Dr. Vinod Nagrale, sir, who is a general physician at the Nagrale Heart Care Center, Chandrapur. We welcome you, sir.
Hello. A very good morning to everyone. So since last 3 days, we have been onboarding and disembarking a variety of academic flights. So to drive our next flight, that is flight number 50 of benefits of Dapagliflozin in KRMA prevention, I invite our pilot ma'am, Dr. Chanasada madam. So she is a consultant diabetologist, MD medicine, founder of Udan, a non-profit organization for children with type 1 diabetes in underserved areas. She also co-founder of TIE-UP, that is a national conclave for type 1 diabetes, and RSSDI Women Physician of the Year 2021, also Sweet Registry Global BIP Award at ISPAD 23, organizing secretary of International Diabetes Experts Consortium, IDEC, co-author of ISPAD Guidelines 2022 for type 1 diabetes care in low resource settings, and also a chair in Diabetes India Pediatric Diabetes Interest Group. So over to you, ma'am.
Good morning, everyone. Thank you, Dr. Gupta, for having me here. It's always a pleasure. Last 10 years being here in Nagpur gives us a reason to come to the Orange City. This session is now we are on this entire session. Next 4 talks are going to be on DAPA and various aspects of DAPA. And I'm going to talk about benefit of DAPA in the Care Me prevention. First disclosure, this is a sponsored talk by AstraZeneca, so that is very important. We're going to talk about how hyperglycemia in type 2 diabetes, it is a cardiovascular and a renal disease, because we have been always talking about initially, of course, when I graduated, it was only about diabetes. We were very, very glucocentric. Over time, when we saw the Omnius octet, we saw all the various pathogenesis, and we actually had drugs to address it because knowing was not enough. We were not talking about it because we did not know what to do with it. And as and more information came in from our basic glucose sensitivity, diabetes care became a metabolic care. Now, from metabolic care, we have gone one step further and we are talking about cardiovascular and renal care because both of them are closely interlinked with type 2 diabetes. So, we're looking at whether it is an acute or chronic disorder of one, it can induce dysfunction in the other. And from that point of view, it's very important that we see them together. And why are we talking about it? We are talking about it. Look at the large number of patients with type 2 diabetes who are at a very high risk of complications for cardiovascular disease, heart failure, and CKD. I will not go into the numbers that are given here, but in our own practice, if we follow them long enough, or if you are at a tertiary center and you get referrals from wherever they have been treated, over time we find that there's such a big overlap when it comes to all 3 aspects of cardiorenal care as well as diabetes together. Now, what is very interesting is in a clinic, it is often we talk about myocardial infarction or stroke because that is what comes dramatically. That is what is talked about in trying to convince patients. That's what all the talks are about. But what we are often seeing is now is heart failure and CKD are the first manifestations of the cardiorenal disease in a person with type 2 diabetes. And why is it? I mean, we all know it, but do we emphasize upon it enough? Does it translate into an aggressive approach in trying not to let that happen in our clinical practice is what we are talking about. The data is there. Does it translate into the way we prescribe, the way we think about our patient? And recently I was thinking about, what would make me think in the right way, because somebody said this is a biased way of thinking. There was a very interesting conversation in one of the conferences that this is a bias, these fancy new things. But I thought, what would I take? What would I give my husband or mother or father? And at that moment, it made me think about every single drug. And would I start with the age-old method of medical nutrition therapy, then wait then give metformin, then wait, and then give another drug. So it really made me think clinically that is that a path I would take for myself or my family? And that gave me insights to know today I would definitely want to think on a very bigger scale, a big metabolic and cardiorenal protection would be a very strong factor in the way I choose what I want to do. So, cardiorenal disease is associated with high mortality in people with type 2 diabetes. I think this is something it is understood, but also all the studies and data say the same thing. So, just to rethink, why are we talking about this? Because we, as a step one, definitely want to control glucose. So, when we have a drug, our focus is definitely a good control of diabetes. But then we also, at the same time, today are thinking beyond glucose. And now, beyond glucose used to be metabolism. We were thinking of weight, we were thinking of all the metabolic benefits. Other than that, now we are also thinking of acting early. And because we are now thinking that we have drugs which can actually prevent or postpone complications, not just control and give metabolic benefits. So we're going to talk about DAPA first in glucose reduction because that is our first step. And it goes without saying, I think all of us in this hall have had enough experience to know how it works as far as glycemic efficacy is concerned. So definitely, and what is my point for this slide is to tell you that it's across the spectrum. We all know that there is good drop when we talk about a higher HbA1c. The higher the HbA1c, we get bigger a drop. But to get a drop at 7.92 is something very difficult. And that is something we are seeing with DAPA also. Today, we don't talk about just control. We also talk about the durability of the control. And this is, again, a very important factor because I see it. I work in a semi-urban rural areas also. And when my patients need to be up-titrated each time, and if they can't have that many visits, then they would be out of control. And I am seeing over the years that their control duration has become much better with the use of SGLT2, DPP4 that we have, because earlier we just didn't have these molecules. Especially after the prices have come down, we have been able to use it more, and the durability is great. So once we have a good control and we have a durable control, then we are talking about CKD that we were talking about. So in our own setups, and especially if you're not talking about a tertiary center, there is a high prevalence and there is a delayed diagnosis. So actually, as you can see, stage 1 prevalence is highest, but the diagnosis in stage 1 is the minimum. So it's almost an inversely proportional pyramid. So maybe it is stage 3 where most people would present most and be detected most. So if we have 2 lakh patients today on dialysis and 5,000 dialysis centers across India. So there is a great window of opportunity at the stage 3, which is where most people would be picked up, where at primary care, we can prevent, postpone CKD. And from that perspective, I think it's very important we think about what to do. And that's why we're talking about starting early. If we see early intervention, if you can see in this graph, the yellow line is what would be the time to kidney failure. And if those years were, say, 7 from 4, if that is where it's set in, but then it with our conventional treatment of giving a very tight control, some kind of nutritional care, some intervention, but delayed, would enhance it and push it away to 9 years. But if we had an early intervention, this is just a pictorial depiction saying it could go to 11 years. So if we could intervene early, we could have significant delays in CKD, and that is the purpose of what we are talking about. So if we could pick it early enough, so the whole thought is, I think, while we are talking about a molecule, it is also to sensitize us that can we pick it early enough. So if we are talking at a EGFR and UACR level, and if we have a logarithm, and I'm very fond of saying this, and I do that in my clinic too, that each clinic, because you know best what is for your patient, no matter what a guideline says, what I say in this PPT. So if you can create an algorithm that works for you in your area, which is pocket friendly, which is clinically relevant, but in a way which you can protect and prevent to your patient. And that is what would matter. So if we look at this and we find the right space where we can intervene, and that is a time we would like to use to protect. So DECLARE study is something that everyone knows about, and it's very much talked about. But what is interesting in this DECLARE study as compared to CANVAS and PowerVertis, all the other studies, was that it has a large number of predominantly preserved renal function. So knowing that you will prevent damage or help a person who already has onset of CKD versus a person who has normal renal function and yet it gives good outcomes is something we need to think about, because then our choice becomes at a basic level earlier, and we are trying to prevent even before it has set in. So this was the reduced renal disease progression which was seen in people, which was very significant in predominantly preserved renal function. Now, this was demonstrated across all clinical important components, including ESKD and renal death. So whether it is just reduction in the progress of eGFR, deterioration was slowed down, to whether it was pushing ESKD further or renal death further. So across the spectrum, results were seen irrespective of where they were at the starting point in the CKD spectrum. And at that, I'm saying that even normal. So improvement in the UACR from the baseline, which is well established, but also the slowing of the deterioration, the delay in the deterioration, and that was also very significant. So very quickly, I'll be going into prevention of heart failure. So we have talked about CKD, how early and even with normal renal function, there was protection and prevention. Similarly, we'll see prevention of heart failure. So while glucose control is fundamental to management, and for macrovascular, that is what we focus upon. We want a very glycemic control. But for heart failure events, there have been studies and follow-up, and just tight control has not been able to protect from the risk of heart failure events. And as a result, in DECLARE, when the studies were enrolled in the entire continuum of diabetes disease as well as cardiovascular. So it had lots of people who did not have established ASCVD. And when the spectrum, as you can see here, 41% are without patients with ASCVD, and it is 59 with risk factors, and many who did not have established. So with this spectrum also, there was seen that DAPA, which was used, was a reduced risk for heart hospitalization due to heart failure, and even with multiple cardiovascular risk factor. So the point here to drive home is that whatever spectrum they were on, whether they had established disease or not, glucose control was not adequate to prevent heart failure. With the best of control, this DAPA did show a significant reduction in the hospitalization due to heart failure. So want of time, I will just go through it very quickly. And yes, so DAPA showing cardiorenal benefits in patients in early renal disease, and how early, as you can see, this is DECLARE where it is 17,000 patients, and whether we are talking about UACR in all these three ranges, but all three, whether it's less than 30, 30 to 300, above 300, you can see a very significant renal specific outcome as well as a composite CV death outcome due to hospitalization due to heart failure. So this is my last slide, and what we are talking about is DECLARE, and the study has shown a large number. This is 17,000 people, and as I said, you've all read the study, so I'm not going to talk about that, but showing outcomes in people who currently do not show deranged markers and yet showing protection is something which makes us think that would we like to start early, whether it is in heart failure with preserved ejection fraction, which we have started seeing now very, very significantly after all the studies came up, or whether it is in CKD. So to conclude, I would like to say that when we are choosing a drug, we want glucose control, yes. We want to have good metabolic effects, which we see with DAPA. We all know about it, from blood pressure to low hypoglycemia to weight loss. In addition, now we are talking about cardiorenal benefit, and we are talking about starting very early, because that has shown great differences even before the disease process has set in. Thank you so much.
Thank you, ma'am, for such a wonderful talk on DAPA early initiation in management and of cardiovascular and renal outcome of the patient. One more important thing, Madam had highlighted, key to early detection sign is heart failure and CKD rather than to look for MI and stroke. So we're looking for the ECGs and we may see. So for that, for rather than to do this, we early look for the signs of symptoms of heart failure and initiate the DAPA at the earliest so that we can prevent from either cardiovascular outcomes in the type 2 diabetes mellitus. Thank you, ma'am. Any questions from the audience?
Thank you so much, the pilots and the captains. I would like to request the captains to kindly felicitate Archana Sadama at the felicitation terminal. And meanwhile, we would like to move to the next session. And for that, I would like to call Dr. Rahul Chaubey, sir, who is a consultant physician and diabetologist at Nagpur. And I would also like to call upon Dr. Rajesh Chauhan, sir, who is an integrated medicine specialist at Pusat. We welcome you, sir.
I'd like to call upon our pilot, Dr. Tejas Shah, sir, who is a diabetologist and director at IVA Diabetes Care, Mumbai. He is the honorary diabetologist at SL Raheja Fortis Hospital, Diabetes Care Centers Malad and Andheri. And he's also the visiting teaching faculty for the Fellowship Diabetology at Dr. D.Y. Patil Medical College, Navi Mumbai. He is also the founder and president of United Diabetes Forum, and also the organizer, scientific committee and faculty of CID 2014, 15, 16, 17, 18, and 19, 21, and 23. And he's been practicing diabetology for 25 years. Sir, please.
Thank you very much. A big thank you to the entire organizing team and Dr. Sunil Gupta for having me here. It's always a pleasure to be here every year at Nagpur. Thank you, Esther, for the session. So as Dr. Archana has already set the ball rolling and spoken about the cardio-renal-metabolic approach with Dapagliflozin and how important it has become in today's times, we are going to go ahead further in this session, and going on, my role is to talk about how we are able to save lives now with, particularly with this drug called Dapagliflozin and SGLT2 inhibitors. So why CKD is a big challenge, as we all know. Diabetes, the prevalence of diabetes is on the rise. We know how many number of people of diabetics are increasing day in, day out. With this increasing number, we are also seeing an increase in prevalence of a disease like chronic kidney disease. The mortality rate associated with chronic kidney disease particularly is also on the rise. If you just see the figures which are there in way past in 2000, from 1990 to now, there's almost been a 29 to 31% increase in mortality rate in terms of chronic kidney disease. And why this is important is if you look at all other chronic kidney diseases, the mortality rates, be it of cardiovascular disease, etc., are going down. But it is the chronic kidney disease where the numbers are still increasing, and therefore it is important for us to understand why we need to do something to halt the progress. The global prevalence of CKD is as high as more than 840 million. And if you again look at the cost which is associated with it, the burden of chronic kidney disease, a patient going to the stage of end-stage renal disease, dialysis, and the burden it puts on the family of a patient is huge. With the increasing number of chronic kidney disease, we are seeing a huge surge in terms of kidney replacement therapy being on the rise. This is the data which showed that almost there is going to be a 25% increase by the end of 2026 if you compare it to 2021. So in a matter of 5 years, there is an increase by almost 25% when it comes to kidney replacement therapy. And therefore, again, we need to understand an approach which is something which is very necessary. The mortality rates and CV risk are also elevated irrespective of the etiology of chronic kidney disease. We know that the primary cause of chronic kidney disease is diabetes, hypertension, and something called an IgA nephropathy, which is more severe form. So hypertensive nephropathy is associated almost 3 times with an increased risk of mortality. Diabetic nephropathy, almost 6 times increased rate of nephropathy, and IgA nephropathy, which is the more severe form, also increased by almost 50%. So the rates of mortality are also irrespective depending on whether the patient is diabetic or non-diabetic. But the decreasing eGFR and albuminuria per se have a direct role to the mortality is what the data has shown. That means if you compare a patient with diabetes versus non-diabetic, if the patient has a deteriorating GFR and an increasing albuminuria, the mortality rates would still be high in both the cases. So chronic kidney disease or diabetic kidney disease is defined clinically by a persistently high urine albumin to creatinine ratio, as well as a falling GFR of less than 60. Number of factors which we need to keep in mind, particularly when we are diagnosing diabetic kidney disease, and we need to rule out other causes of of nephropathy when we are looking at this kind of patient, like an absence of retinopathy and other factors which could be more, which would point more towards other causes of nephropathy. So what can we do to retard the progression of kidney disease? Now we know that there are primarily 3 areas: the inflammation, which is one of the risk factor or which is one of the pathogenesis for kidney disease, the hemodynamic dysregulation, and the hypoglycemia, which per se is responsible for progression of kidney disease. And now luckily we have drugs which work on various factors of these. We have the ACE and ARBs which are working on multiple areas. And we have the SGLT2 inhibitors, which are mainly working on all the aspects, by particularly reducing hyperglycemia, reducing inflammation, as well as reducing the intraglomerular pressure, thereby causing changes in hemodynamic regulation. So intensive blood glucose control, intense good blood sugar control, blood pressure control, tight lipid management, diet and lifestyle modifications, and particularly managing comorbidities are something which would help us in reducing the progression of kidney disease. Since the time trials particularly came like the Credence, DAPA CKD and EMPA kidney trials, now the guidelines, the 2022 KDIGO guidelines have recommended for a patient with diabetes, particularly diet and lifestyle modification is still the first step. Metformin becomes the first drug of choice again if the GFR is more than 30. SGLT2 inhibitors are considered to be the first drug of choice again for this subset of patients along with metformin here. And if the eGFR, you can start the patient also if the GFR is more than 30, and you can continue the drug even if the GFR is up to 20. The subsequent comorbidities that the patient has would then define or help us to choose the subsequent drugs that we want to add along with metformin and SGLT2, be it the GLP-1 agonist or a DPP-4 or other drugs. The ADA standard of care again puts SGLT2 inhibitors as the first drug of choice along with metformin. If the patient has CKD and albuminuria, again, based on the data that we have, SGLT2 inhibitors are the first drug of choice, and then subsequently you add the other drugs. If the eGFR is less than 60 even without albuminuria, then you can choose a SGLT2 inhibitor or a GLP-1 agonist, again depending on the primary evidence is available. So when the SGLT2 inhibitors came in, they were initially considered to be drugs only for blood glucose reduction. Slowly with the effect being seen, with the weight loss seen, and then we got the trials like Declare, EMPA, Reg, and Canvas, we came to know that they have an pleiotropic effects or they have beneficial effects on the heart failure reduction and kidney disease. However, nobody expected them to have such a pronounced effect on progression of kidney disease as well as heart failure, and therefore the secondary endpoints were always considered the kidney renal endpoints. However, the mechanism of action has now taught us that there are various effects of SGLT2 inhibitors. They cause reduction in glomerular filtration pressure, they have direct natriuresis effect, the reduction of glucose, and all of these factors help in kidney protection. So special trials were then designed, like we have the Credence, and then we had the DAPA CKD, and we have the EMPA kidneys, which came out and which particularly enrolled patients with chronic kidney disease or established kidney disease, where renal endpoints were the primary outcome, and thereby they have shown beneficial effects over a period of time. This is the data from the Declare trial again, where it showed a reduction in or progression from normoalbuminuria to macroalbuminuria considerable by almost 50%, and also regression from macroalbuminuria to normoalbuminuria, which was clinically significant and more than 45 to 50%. Till now, the trials were only enrolled patients earlier with diabetes. However, there was not enough data to see whether SGLT2 inhibitors are beneficial equally in patients without diabetes also. So DAPA-CKD was the first actually trial which enrolled patients with diabetes as well as without diabetes with established chronic kidney diseases. So this was a trial which had around 4,000 patients. They were randomized to 10 milligrams of dapagliflozin versus placebo. The eGFR for patients, mean GFR was between 25 to 75 here, and the albumin creatinine ratio was somewhere between 200 to 500, almost 1,000. The patients were enrolled here had all different causes of diabetic kidney disease, where diabetic kidney disease was prominent, more than 58%. 32% of the patients here were without diabetes. The primary outcome for composite outcome, which was mainly looking at reduction of eGFR decline by more than 50%, or progression to end-stage renal disease was reduced by almost 39%. There was a 39% relative risk reduction seen. The all-cause mortality was reduced by almost 31%, and the composite of CV death or heart failure hospitalization came down by almost 29%. Sub-analysis of DAPA-CKD, where it looked at certain populations specifically and looking at their effect of dapagliflozin on progression of kidney disease. Here again, with the patients with diabetes, there was almost a 36% relative risk reduction in the primary outcome and almost a 50% relative risk reduction in those patients who are without diabetes. The secondary renal specific outcomes, which were again looking at sustained reduction by more than 50% of eGFR decline, irrespective of the diabetic status, again showed beneficial effects in both the groups. Patient with type 2 diabetes showed a 43% relative risk reduction, and those without diabetes showed almost a 49% relative risk reduction. The all-cause mortality again was assessed here in sub-analysis. Patients with diabetes showing a 28% reduction, and patients without diabetes showing almost a 48% relative risk reduction. Important analysis which came out from DAPA-HF as well as DAPA-CKD was in terms of prevention of progression of diabetes. Both these studies had patients who were without diabetes or with impaired glucose tolerance also. And there was almost a 33% risk reduction in patients from progression from impaired glucose tolerance to diabetes, or patients came down from impaired glucose tolerance to a normal glycemic status also. Furthermore, again, these cardiorenal benefits were beneficial or achieved irrespective of, again, the glycemic status. That means those with normal glucose tolerance, where the A1C of less than 5.7 showed a reduction of almost 38% in the primary outcome and a 24% reduction in all-cause mortality. The pre-diabetic patients also showed a significant reduction of 63%, and patients with diabetes, where the A1C was 6.5, showed a 36% relative risk reduction. So dapagliflozin overall showed a robust clinical benefits versus placebo even in patients with IgA nephropathy. Remember, IgA nephropathy is the most severe form where even the ACE and ARBs have failed to show the clinical benefit as much as possible in patients without this. Here again, there was a 71% relative risk reduction in primary outcome and a 38% risk reduction again seen here in the FS65. So these benefits were also consistent again across all stages of CKD. If you see here, a 42% risk reduction in the primary outcome, again in patients whether in stage CKD 2 or 3, and the all-cause mortality was also achieved in these patients in stage 2, 3 as well as in stage 4. Safety measures were more or less similar, slight increased rate of genital tract infections and UTI, but apart from that, no major adverse events seen in this data. Now, whether the last question, the last two slides here, which comes to us is whether again in the approach of this, whether all SGLT2 inhibitors are same. More or less, yes. If you see the major outcomes, the renal benefits and the heart failure hospitalization benefits are more or less seen to be same across in all the trials. If you see subtle small endpoints in comparing dapagliflozin and empagliflozin in certain studies, the glycemic parameters more or less both are same. The new onset diabetes data is there with dapagliflozin, which was not seen with EMPA here. The all-cause mortality in DAPA CKD showed a relative risk reduction of 38 to 31%, and if you compare it with EMPA kidney, it did not show, it showed a 14% reduction, which was not clinically significant. And when they looked at the heart failure hospitalization data, again in DAPA HF versus Emperor HF, there was a 35% risk reduction with DAPA, which was not clinically significant as much in the Emperor. So overall, the relative risk reduction in CV death was better with EMPA in the EMPA-REC because the patients were with established cardiovascular disease, while in DAPA HF, the heart failure hospitalization was found to be superior, as well as in DAPA CKD, it was found to be superior. So to summarize, CKD, as we know, is a major health problem. We need to target these patients early with these kind of drugs where we know the clinical benefits are there to see. The risk of mortality and CV events need to be curtailed by targeting our patients early, exposing them to these kind of drugs. And we know that these are the drugs which would halt the progression of kidney disease over a period of time. It is a growing health concern, and drugs like SGLT2 inhibitors are now established and should be used as the first line therapy for all our patients with diabetes and chronic kidney disease. Thank you very much.
Hello. Thank you, Dr. Tejas, for such an enlightening talk. And we are really convinced that dapagliflozin, in spite of the fact that patient has diabetes, is a patient non-diabetic, patient hypertensive, and within that, those norms of GFR is really helpful in your clinical practice. And that is one of the boons that we have in our hands. So thank you for that enlightening talk. If there are any questions, we can have 1 or 2 questions, please.
I'm Dr. Shankar Khobragade. Excellent talk. Role of Finrinon here, in addition to the Dapagliflozin for prevention of CKD at what stage, considering the potassium level?
Yeah, so finerenone has again shown clinical additional, it is an additional benefit for patients because the 2 trials which were done with finerenone also had patients in a similar group with established CKD and they were on ASN ARBs. So it has shown an additional benefit in terms of progression. Potassium is the only parameter that we need to again monitor and be careful about before starting finerenone particularly. For those with less than 4.5, it is safe to start, but above that, we need to reduce the dose, or if it is above 5.5, we stop finerenone.
Dr. Shah, I want to know, in your studies, you showed that in type 2 diabetes and non-diabetics also, there are some renal benefits of dapagliflozin. I'm just thinking that in patients of type 1 who have albuminuria and reduced eGFR, can we extend these benefits to those patients? Are there any data regarding that?
Type 1 diabetics, it has not been studied yet. No data we do not have out yet for patients usage of SGLT2 inhibitors, particularly in patients with CKD. And the main risk with type 1 diabetic patients that we are worried about is again ketosis and dehydration sometimes that can happen. So that's the only issue when we are talking about patients with type 1 diabetes, and we do not have a large scale clinical trial done to use this drug.
Well, this is a comment rather than a question. That it's very well established that in diabetic kidney disease, SGLT2 inhibitors, almost all of them have a class effect in protecting kidneys. But then in non-diabetic kidney disease, also it has a great potential and a great potential to protect the kidneys, has been very ably demonstrated in DAPA CKD trial and EMPA kidney trial as well. And as the data which you have shown, that perhaps those patients who had a non-diabetic kidney disease, perhaps they were more benefited as compared to diabetic kidney disease. Despite that, there is a reluctance by the nephrologists, most of the nephrologists, not to use it in non-diabetic kidney disease. And it has, fortunately, it has been even added in the guidelines of KDIGO 2022 that it is one of the drugs to be used in patients who have a non-diabetic kidney disease. The only exception is that patients who have immunological glomerulopathies, they have not been adequately studied, and polycystic kidney disease, they have not been included in these trials. But otherwise, all non-diabetic kidney diseases, they are benefited by this. So it is high time that we take this drug for these kinds of patients.
Absolutely.
Last question, sir.
This is in response to type 1 diabetes and dapagliflozin. Now, this has been has been used. And there are clear studies which show that it does benefit, but there is increased risk of diabetic ketoacidosis. And strangely enough, it was licensed for use in ninth guideline till 2 years back when the license has been withdrawn. So at this point of time, please be careful. There is no guideline for use of dapagliflozin in type 1 diabetes. And if you do so, please inform the patient and do so at your own risk.
Thank you, sir. Let's give him a big hand. There are not a lot of questions.
Thank you so much for such an informative talk, sir. We would like to kindly request the chairpersons and the panelists to move towards the felicitation terminal. And meanwhile, I would like to start the next session. And for that, I would like to call Dr. Deepak Jeswani, sir, who is a consultant physician and intensivist at the Critical Care Nagpur. We welcome you, sir. And we would like to invite Dr. S.N. Deshmukh, sir, who is a very renowned physician at Nagpur and has a high repute and a very good academician, sir. We welcome you, sir.
Good morning, all. We all know that diabetes has increased incidence of CKD and heart failure, and these are very common comorbidities which are present in patients which can increase morbidity and mortality. To discuss the management of the triad, we have with us Dr. Rajiv Chawla, who is Diabetic and Endocrinology Center of Western New York, Senior Diabetologist and Director, North Delhi Diabetes Center at New Delhi. He is Honorary Professor, Jaipur National University, and Visiting Professor at JLN Medical College and KLE Academy of Higher Education and Research, Belgavi, Karnataka. He is a DNB teacher and guide for 25 years, and he has got many papers to his credit, awarded AACE Travel Grant twice for masterclass paper, and he has authored many books in diabetes. Over to you, sir. Thank you.
Thank you very much. Good morning, everyone. Thanks, Dr. Sunil and his entire team for having me on board. It's always a pleasure to be part of this very prestigious conference. Task assigned to me is deadly trio, diabetes, heart failure, and renal dysfunction. So, yeah. So flow of my talk will be first to discuss cardiovascular disease, heart failure, and kidney complication in type 2 diabetes, the magnitude, the pathogenesis, can we reduce this risk of trio, and how guidelines in type 2 diabetes patient have prioritized these deadly trio while we are managing type 2 diabetes. So we know that there is a dynamic and a significant relationship which exists between systemic metabolism, heart and kidneys. Heart is most metabolically demanding organ. Dil mange more because it is susceptible to changes in volume as well as in metabolism. So any amount of change in metabolism by liver, pancreas and fat, it is going to be extremely important not only for maintenance of heart as well as kidneys. Kidneys play a very important role in glucose and volume homeostasis and blood pressure regulation. So there is an interrelationship of systemic metabolism, the heart and kidneys, which is very well supported by huge amount of evidence. Any acute or chronic dysfunction in the heart, kidneys or into the metabolism is going to induce dysfunction of the other organ. So each dysfunctional organ perpetuates dysfunctionality in the other organs because these are very, very strongly and dynamically interrelated. And unfortunately, type 2 diabetes is usually having clustering of all these risk factors with cardiovascular disease and kidney disease already in incipient. So any metabolic dysfunction will add to cardiac as well as to kidney dysfunction or will increase the morbidity. So metabolic abnormalities like systematic metabolism dysregulation or hypoglycemia, dyslipidemia, increase in insulin resistance or change in hormonal milieu is going to not only bring out changes into the kidney, but also into the heart in the form of increased fibrosis in the kidney, endothelial dysfunction, declining kidney dysfunction, microalbuminuria, and then going into macroalbuminuria. It is also going to lead on to cardiac fibrosis, endothelial dysfunction, heart failure, and rampant atherosclerosis. Similarly, if you have a cardiac dysfunction, it is going to worsen kidney as well as metabolic, and any amount of cardiac abnormality in the form of either a neurohormonal activation, hypoperfusion, volume overload, preload or afterload, arterial resistance is going to increase not only the free fatty acid level, going to worsen dyslipidemia and going to worsen insulin resistance, but also into the kidneys, it will increase intraglomerular hypertension, microalbuminuria, going towards macroalbuminuria, and will lead on to further declining of the renal function. Similarly, any degree of kidney dysfunction will further worsen cardiac and metabolic changes. So kidney abnormalities like activation of the RAS or SNS, sodium and fluid retention, hypertension, arterial calcification or oxidative stress will further increase glomerular hyperfiltration, and that will worsen insulin resistance, and into the heart also it will increase ventricular hypertrophy, predisposition to heart failure, and endothelial dysfunction and rampant atherosclerosis. Unfortunately, in patients with type 2 diabetes, even at an early stage, these patients are at a much greater risk for development of these complications, because there is always a clustering of risk factor. Like most of these patients are overweight or obese, they have hypertension, dyslipidemia, many of them might be smoker, and there is always a degree of alpha as well as beta cell dysfunction, huge amount of insulin resistance, which then sets in the stage for not only cardiovascular diseases, but also for diabetic nephropathy and also for rampant atherosclerosis, leading on to a much higher cardiovascular risk. And believe me, a large proportion of patients with type 2 diabetes, they have cardiovascular disease. Almost one third of them, they have an established cardiovascular disease, and there is going to be an increased risk moment you have presence of a cardiovascular disease, increased risk of MI, stroke, heart failure, and further worsening of CKD is going to happen. And that is why most of the patients with type 2 diabetes, they have a higher mortality because of cardiovascular disease, not alone because of diabetic nephropathy. But CKD and heart failure are one of the most frequent first cardiorenal disease manifestation in patient with type 2 diabetes, seen in almost one third of these patients over the follow-up. Similarly, heart failure, which is again a very early but very high prevalent and often undiagnosed or missed complication of diabetes in these patients. Almost 25 to 40% of patients might have heart failure, either reduced ejection fraction or preserved ejection fraction. In one of these studies, it was found that if you follow these patients for 5 years, 68% patient might have a asymptomatic left ventricle dysfunction. And in one of the cardiac screening program, it was seen that 28% of the patient with type 2 diabetes, those who were aged more than 60, they already had established heart failure, either as a reduced or a preserved ejection fraction. Even kidney disease is also very early and very highly prevalent complication in patient with type 2 diabetes. Almost 50% of the patient will end up with end stage renal disease, starting from microalbuminuria, macroalbuminuria, and further reduction in EGFR as you follow these patients over 10 to 15 years. So there is a very strong coexistence of type 2 diabetes and kidney disease, which together bring about very high mortality as compared to someone who has only diabetes, someone who only has albuminuria. But moment you have albuminuria, reduction in EGFR, obviously there is going to be a further worsening of overall cardiovascular risk and mortality. Similarly, heart failure and kidney dysfunction, once these are there and there is a further decline, because these are very, very interconnected complication, they are going to again worsen each other. So heart failure probably will be associated with significantly higher risk of incipient CKD and mortality. Similarly, incident rates of heart failure are much higher if you have already presence of CKD in these patients. So let's see whether we can reduce this risk of cardiovascular disease, heart failure, and kidney? And can we check the progression of this deadly trio? Unfortunately, most of the studies, whether you talk about Accord, Advanced UKPDS, and VEDIT trial, they have not really shown benefits in terms of overall cardiovascular risk or macrovascular complication. Even in the UKPDS trial, it was seen that the benefits which were seen in the intensive group in the initial phase, 20 years, were not p-value wise significant, but subsequent follow-up over next 10 years has shown that these patients had definite reduction in myocardial infarction by almost 15% as compared to the conventional group. Even 3-point MACE, when you talk about of late, since the launch of drugs like SGLT2 inhibitor or GLP-1 receptor agonist, we have seen that there are 3-point MACE benefits when you are using drugs like SGLT2 inhibitor, with significant reduction in 3-point MACE in EMPA-REG by almost 14%. Similar benefits were seen even in Canvas trial, although declared TIMI initially has shown only 7% reduction, which was not p-value wise significant, but subsequent subset analysis has shown that a composite reduction in CV death as well as hospitalization with heart failure, and a very good trend has been seen in patients, those who are on GLP-1 receptor agonist, starting from leader trial where there is a reduction in 3-point MACE by 13%. Sustain has shown 26% with injectable semaglutide, and even Pioneer has shown a good trend by 21% reduction in 3-point MACE, although p-value wise it was not very significant. Similarly, CV death outcome have also been reduced in patient those who are on SGLT2 inhibitor or GLP-1 receptor agonist versus the control group. Of course, the best data was in EMPA-REG trial where there was a 38% reduction in CV death, which of course has not been replicated in any other trial. But GLP-1 receptor agonists have also shown reduction in CV death in the leader trial as well as in the Pioneer trial by almost 22%. But definitely hospitalization with heart failure outcomes have significantly improved in patients those who are on SGLT2 irrespective of the drug. It is more like a class effect, although reduction in hospitalization with heart failure on GLP-1 receptor agonist has not been very significant. But composite renal outcomes, whether you are on SGLT2 inhibitors or on GLP-1 receptor agonists, have shown a consistent reduction by almost 30 to 40% in the different trial because of heterogeneity of the population which these trials have enrolled. So when it comes to SGLT2 inhibitor, the metabolic benefits, CV and kidney benefits are very apparent, and these are possibly because of the fact there is going to be a diuresis, glucose excretion through the kidney increase, and the natriuresis, which has certain immediate effects like reduction in intraglomerular pressure. So LV wall stress and mass goes down, inflammation gets reduced, preload and afterload also comes down. So not only there is a reduction in CV events, kidney disease, blood pressure, body weight, but also significant HbA1c reduction has also been seen. Similarly, when you talk about GLP-1 receptor agonist, mechanism may be little different because they improve insulin secretion. There is going to be a suppression of glucagon, natriuresis and diuresis is going to be there, and their appetite suppression is going to be there. So there is again going to be an improvement in CV outcomes, albuminuria, blood pressure reduction, body weight, and HbA1c. So today, when we are talking about a composite reduction in CV outcome, 3-point MACE, hospitalization, heart failure, or heart failure with diabetic nephropathy, or overall renal composite endpoints, whether you talk about ACE guideline, ADA guidelines, or our own RSSDA guideline, after the lifestyle modification and diabetes education, not only it is the glycemic management which is important, but much more important is to control your blood pressure. Lipid management is equally important, and it is important to have drugs which can reduce not only CV death, overall composite endpoint, renal, as well as 3-point MACE could come down. So all the guidelines today highlight the importance of HbA1c reduction, blood pressure, cholesterol, drugs. It is important, just finishing, last slide, to improve heart failure and renal composite endpoints. And of course, once these are combined together, overall spectrum towards death or CV mortality is going to be checked. So to sum it up, there is a very dynamic and interconnection between when you talk about systemic metabolism, heart and kidneys, type 2 diabetes, CV disease, heart failure, and CKD are very well interconnected and interrelated. And all the guidelines through various societies, they highlight the importance of drugs which can reduce renal as well as CV death or 3-point MACE reduction in management of type 2 diabetes. Thank you very much for your patience listening. If you have any questions, I'll be more than happy to answer that.
Well, thank you, Dr. Chawla, for an excellent lecture on this. There is a cross connect between diabetes and heart disease, renal disease, that has been very properly elucidated by Dr. Manoria's lecture yesterday. If you add NAFLD, or non-alcoholic fatty liver disease, and obesity, perhaps that completes the morbidity which occurs in the patients. And perhaps the savers in these patients are SGLT2 inhibitors, which have come up in a very big way. And now the GLP-RAs, which have also come up they are also coming up. And as you have very nicely showed that they are protectors of kidneys as well in patients. So essentially, they have come up as the anti-diabetic agents, but then they have started protecting the kidneys. Looking at the literature, where do you place SGLT2 higher or GLP-1 RA higher in protecting the kidneys and the heart?
I think we all agree that metformin has to be the first line option. Our
True, it
own
is.
guidelines I'll refer to. Until unless there are contraindications to metformin therapy, after that it is a profile-based management based on the risk factors. Someone who is obese, someone who has an incipient reduction in ejection fraction, or maybe diabetic nephropathy, incipient or manifest, will be the best candidate for SGLT2 therapy. When you are talking about clustering of CV risk factors and 3-point MACE reduction based on atherosclerotic mechanism, GLP-1 receptor agonist will score over any other drug. And after that, you can choose, if patient is already on GLP-1 receptor agonist, you may add SGLT2 inhibitor. Patient is already on SGLT2 inhibitor with metformin, you may add GLP-1 receptor agonist for synergistic action. So it is all profile-based management which we need to adopt. It has to be a holistic approach towards management of type 2 diabetes.
Yes, please.
Now we classify diabetic kidney disease into albuminuric and non-albuminuric. So what do you think that SGLT2 inhibitors are more beneficial in albuminuric group, or they are also beneficial in non-albuminuric?
I think SGLT2 inhibitor as such have shown reduction in renal composite endpoint by 35 to 40%. Once it comes to albuminuria, greater reduction has been seen with GLP-1 receptor agonist over SGLT2 inhibitor, but renal composite endpoints primarily up to 40% reduction has been seen in all patients, those who are type 2 diabetes. And even in non-diabetic, now we have DAPA CKD and AMPA kidney data also. Even in non-diabetic patient, if you have albuminuria, by either mechanism, you are going to benefit with SGLT2 inhibitor.
See, what happens is that when you have albuminuria, this is predominantly glomerular disease, and all patients who are non-albuminuric eGFR reduction, they have interstitial or the
Interstitial, agreed.
Okay. So whether SGLT2 are more beneficial?
Definitely more for intraglomerular pressure reduction, and if you have albuminuria, benefits are more. Higher is the albuminuria and lower is the ejection fraction, more are going to be the benefits with SGLT2 inhibitor.
Just to add to what he has said, there is a very few people with non-albuminuric kidney in diabetes. So one of the studies showed 10 to 15% are non-albuminuric. But if you look at the non-diabetic kidney disease, they're likely to be more non-albuminuric.
More, yeah.
So if you look at what Rajiv has said, that most of the patients have included in the trials have two criteria. One is albuminuria, the other is low GFR. And hence there are likely to be inclusion of patients who don't have microalbuminuria or macroproteinuria in these trials. So they're a mixed trial. But if you ask me, there is a separate trial for non-albuminuric kidney disease by SGLT2? No, there is none.
I think it has to be an overlap of reduction in EGFR with albumin 1, 2 or something.
See, the CDC trials have shown that in diabetes, 40% patients are who have kidney disease, they are non-albuminic, number one. And the subset analysis also shows that in albuminuric group, there is better beneficial effect, whether it's CV or nephro.
That I agree, but very early, I think 15 years ago, there was one publication in Diabetes Care that 28% of patients whom we label it as non-albuminuric, they are also having diabetic nephropathy and they are going to benefit.
Show me a single Indian trial where 40% are non-albinuric. Show me a single kidney trial.
It is always an overlap. Maybe our estimation criteria may be different, but it is always an overlap of albuminuria with reduction in EGFR.
In EMPA kidney trial, where SGLT2 inhibitor Dapagliflozin was used, there were at least 20% patients who had non-albuminuric CKD, diabetic kidney disease.
Yeah, 28% was one Diabetes Care publication, but they said if you perform a renal biopsy in them, more than 2/3 are diabetic nephropathy. So it is very, very difficult to pick up a group which is non-albuminuric and doesn't have diabetic nephropathy and still reduction in EGFR. That is going to be a very, very small group. I don't think that has been identified or has been addressed to in any of these renal trials.
But then there are diabetic patients in clinical practice, which we see.
There are, I agree.
Who satisfy the criteria of CKD and who do not have proteinuria.
Agreed.
If you look at their ACR,
There are
their
patients
ACR could be
who may
below
not have
30.
albuminuria and no fundal changes, but they still have diabetic kidney disease because we are not performing kidney biopsies on that. So it is very, very difficult to say. 2/3 of them, I am sure, will be still diabetic nephropathy, although they are still negative with albuminuria.
Well, thank you very much. We come to the
Thank
end
you.
of this
Thank
discussion
you.
because of lack of time. Thank you very much.
Oh, thank you so much. Thank you so much. That was a really, really great academic fiesta. So I would kindly request the captains and the pilots to move towards the Felicitation terminal. And meanwhile, I would like to kindly call upon Dr. Samir Shahane, sir, who is a consultant and general physician at the Relief the Healthcare Clinic, Nagpur. And I would also like to call upon Dr. Swapnil Bhatt, sir, who is a consultant diabetologist at Diabetes Care Clinic, Akola. We welcome you, sir.
Good morning, everybody. This has been a wonderful session of 3 days of Hello Diabetes Academia, as usual. And presenting Dr. N. Kannan, who is a diabetologist from Chennai, and UG from SMC, PG from MMC, diabetology from Annamalai University, completed Jocelyn Diabetes course, and active task force member of RSDI, Fellowship Diabetes India 2023. Is a member of ADA, AACE, ESI, ATS, SCCP, and ICS. And he was a clinical investigator in various clinical trials. Over to you, sir.
Thank you, chairpersons, for the kind words. And also like to thank Dr. Sunil Gupta, sir, and Kavita, madam, for giving me this great opportunity. Dear friend, this topic is very important. It's highly pertinent to our clinical practice. Diabetes in elderly. Why we want to take care, the extra effort for the elderly patient in our clinical practice. She is Marjorie Warren, and she is a British surgeon. And she fought hard to establish the geriatric department in United Kingdom. And she has been considered as the mother of the modern geriatric medicines. These are the roadmap. So it's so fascinating that with the advent of modern medications and technological usage and proper education, there is longevity of the rise in India. If you see the life expectancy from the old, it was 42 years in 1961, and it jumps to around 76 years. So it is seen that Indians' elderly population is growing by 3/4 of the entire populations. So if you see the global burden,
From the year of 2019, it was around 136 millions of elderly were suffering from diabetes. And in 2030, it is expected to jump to 195 million. The sad part of the story is almost 50% of the elderly populations of more than 65 years are having the impact and burden of the diabetes is very, very alarming also. If you see the global consensus or the global burden, out of the listed 5 countries, the India stands 3 in prevalence of the diabetes among the older adults. So 11.0 million, almost 17% of the whole chunk have been involved in the diabetes prevalent in Indian population. These are the data given by Banerjee, the National Sample Survey. So if you see the prevalence of the diabetes among the elderly population aged more than 65, they divide into 3 classes. One is between this one, younger old and old and oldest to old. If you see, so the prevalence of diabetes among the urban population is somewhere around 30 to 35%, and overall, it comes around 28%, is very, very important, alarming message in India. Why it is important to consider the elderly as a separate group? Because that is pathophysiological link. The link is integrated totally. The aging contributes to the pathogenesis of type 2 diabetes, decrease the beta cell function, and thereby decrease the insulin secretion, increase the insulin resistance. The aging on the one side with the risk factors of sarcopenia and the skeletal muscle dysfunction, frailty, and so forth, so on, and obesity, which involves insulin resistance, central obesity, is totally bidirectional, and it will provoke and pave the way for increased insulin resistance and decreased insulin secretion, and thereby going for the frank prevalence of diabetes and complication, including the macrovascular and microvascular complications. Fascinating. So see, almost among the 60% of the elderly population, they have one sort of comorbidities. They have cognitive decline, polypharmacy, disability, and depression. Depression may be due to the partner loss, and more than 40% they have. Yesterday we had a good discussion on autonomic bladder neuropathy. So this one, urinary incontinence, hearing, visual impairment, falls and fractures, one of because sarcopenia has been implemented among the elderly population, cardiovascular disorders. So if you see the diagnosis and clinical presentations and assessment is somewhat different in comparing with the adult population. Diagnosis is 2 hours plasma glucose with the OGT are more reliable than the fasting sugar in diagnosing diabetes in elderly. If you see the clinical presentation, osmotic symptoms are less prominent because of the increased renal threshold for glucose, reducing the intensity of polyuria, and therefore missing the finding if they're presenting with any polyuria or polypsia because it is masked. In assessment also, we want to not only to roll out the microscope, macroscope, but we want to see the vascular outcome, and also we want to see the physical neuropathic factors and mental and cognitive disorders. Evaluation is very, very important among the elderly population. Alan Sinclair totally amalgamated these 3 problems as one segment as a triad: vascular, physical, and mental. Complication integrated and produces the complications, mental dysfunction involving the dementia, depression, behavioral, this one, anxiety disorders, and physical and neuropathic complication, including sarcopenia, frailty, which is contributing for the vascular diseases. So these 3 amalgamated and integrated going for the complication, including visual loss, immobility, and frailty, and go on and so forth. What are the challenges in the management of diabetes in the elderly population? So these are the challenges. So among the elderly population with diabetes, if you see the comorbidities like delirium and progressive cognitive decline, and also the frailty other than the decreased mobility, depression. The more depression is more common among the elderly patient because this one feeling alone, the partner loss. These are the impact among the elderly population, skin infection. So if you see the consequences about these challenges, they will go for the irregular meal intake and refuse the glucose monitoring, refuse of the medications, and therefore we want to counsel the patient, education the patient, support the patient, care the patient, and thereby we have to go for simplified medical regimen, optimize activity and nutrition therapy and physical social activities and increase glucose monitoring and diabetes medication. Appropriate care, appropriate support is one of the key among the elderly population, the diabetic population. Even though multiple times we have seen this slide, Wikipedia emphasize the intensive glycemic control of the diabetic patient, but in the elderly population with the frail and this one, the predominant for old and frail, they go for sarcopenia, go for fractures, and so forth. Intensive glycemic control will have the impact and burden of the hypoglycemia awareness. So this will lead to the increase the hypoglycemic episodes and impact the quality of life and outcome. So the tight glycemic control with an aim to provide the microscopic benefits can be harmful for the old frail population, especially if it is achieved. So select the molecules, prefer the molecule, and entitle the molecules for the elderly population. Sarcopenia is one of the important impact among the elderly population. So this is the triad linking between the old age and sarcopenia as a type 2 diabetes. See, over the aging population, almost 3.5% of the aging population going for the sarcopenia. And on the other side, the diabetes also will provoke for sarcopenia. So this integration within the triad go for sarcopenia contributes to the functional impairment and the increased risk of mortality in elderly type 2 diabetic patients. And elderly patients with type 2s are more predominant, 2 times are more vulnerable for the complications. So de-intensification is important aspect of the elderly populations. We are giving, because there are a lot of comorbidities. We are giving more and more polypharmacy in single prescription. So de-intensification means, de-intensification type 2 diabetes can include the de-prescribing of the medication, because we want to delete the unwanted medication, including statins also. So over the age of 80, the statins will not be helpful for the patient. So where you will de-intensify short life expectancy, low cognitive function, a low function status, and so on and so forth. So de-prescribing antibiotics and reduce the monitoring, switching to other drug with a low risk of hypoglycemia is very, very important cornerstone in the management of diabetes among the older population. Once again, in the female patients, those who are attained the postmenopausal, in the postmenopausal, they have the decreased BMR, and decreased BMR will contribute for the visceral adiposity, and there will be a surge in the adipokines. On the other side, they will go endothelial dysfunction. So on the other hand, they will have depression also, with a vasomotor involvement, sleep disturbance. These will contribute both for cardiovascular and as well as cerebrovascular problem, including the MI and stroke. So we want to implicate the appropriate lifestyle modification, good glycemic control, and the management of hypertension, lipid management, as well as the antiplatelet therapy. Once again, inpatient management of the elderly population is very, very important, both for hyperglycemia as well as hypoglycemia. Hyperglycemia also contributes for the cardiovascular problem, and hypoglycemia also, because this hypoglycemia, one single episode of hypoglycemia will provoke the underlying impact of the cardiac autonomic neuropathy. They will land up in some sort of this one arrhythmia, or including the dead in bed syndrome among the elderly population, that we want to keep in mind. So individualize the treatment and insulin therapy regardless of patient age, and depot inhibitors may be or may not be helpful among the elderly population. What is this is the important part of our clinical approach, our pharmacological approach for diabetes in elderly population. So multiple guidelines have been attributed to ADA, American Geriatric Association, AS, as well as the ACP. So if the patient are non-dependent, can have the HbA1c between 7 to 7.5. But if the patient old and frail, dependent means relax the HbA1c between 8 and 8. That is the message I want to give my dear friends here. Don't be tight, control the HbA1c. Relax the HbA1c somewhere between 7.5 or 8, or including 8.5 also. So the management targets and goals. The patient independent, no problem. Adequate exercise, adequate nutrition, no problem. You can relax the glycemic load between 7 to 7.5, and goals also may be that. And partially dependent, once again, you have to take care. And if the patient is dependent, please be kind enough to relax the HbA1c between 8 to 8.5. That is the message I want to tell my dear friends. ADA emphasize the clinician across the globe. You follow these regimens properly. Elderly population, those who are aged more than 70 or 75, 80, increase of hyperglycemia more common, so be careful. Over-treatment of diabetes, be careful. De-intensification, one of the cornerstone, and also cost factors, because most of the elderly population, they feel alone. They have to spend the money from the own packet, and therefore it is very, very important message. It is a picture of all available thing for the elderly population for the management of type 2 diabetes, and SUs should be kept in mind. SUs is wonder drug, but it produces hypoglycemia. Prefer the SUs. Maybe glycoside slowly for me helpful, and insulin also prefer the long-acting basal insulin. Once again, insulin regimens also plays an important role in elderly population. If the patient already undergone this one, simplified the insulin regimen has been found to reduce the risk of hypoglycemia without compromising the glycemic control in elderly type 2 diabetic population. So basal insulin, so changing the time from bedtime to morning time, mealtime insulin, cut down the insulin dosage from 10 units. That is very, very important. If the patient already under less than 10 units, means stop the insulin and go for non-insulin glycemic agents. So this is very important message. Insulin regimen can be altered according to the patient need, if the patient age is more than 70 or more than 80. So metformin, once again, is a good molecule, but there are challenges over the GI tract disturbances. Vitamin D12 does not have hypoglycemia. But if the patient has the CKD stage 3 and 4, it's alarming. If the patient EGFR less than 30, means stop the molecule, no metformin. But if you know metformin is the first line, it has a lot of controversies on the respiratory acidosis, hypoxia, congestive cardiac failure, and so on and so forth. So selecting the metformin among the elderly population, those aged more than 80, should be always keep in mind to give the individualization of the approach. Once again, it's a predominant molecule. Last session, we had a good discussion, the Dapagliflozin. It's a good molecule on CV benefit, kidney benefit, one of the hallmark. But in this elderly population, the volume depletion, one of the main problem, genotomyocardic infarction, we have to keep in mind. If the EGFR less than 45 or EGFR less than 30, be alarming for the elderly population because they may be go for some other problem regarding acute kidney injuries. So may be useful for CVD also. Once again, SUs, one of the good molecule, you can prefer the SUs as glycolysis 12 form, but if you go for the this one conventional form, that is weight gain and hypoglycemia, this one trigger this one underlying cardiovascular problem. Titazose is a good molecule, but in elderly population, which more than 70 is one of the main commonest burden. Increase of fractures and this one congestive cardiac failure, edema, retention of fluids is an important burden among the both these glycolysis as well as the SUs. DP inhibitor is a good molecule because this molecule can be considered even in all class of ages of the patient, right from 60 to 85, because this doesn't have impairment on the sarcopenia and has good glucose control. But selecting the glycolysis is gliptin is very important, so it will not interfere with the GGFR because linagliptin and teneligliptin may be helpful because at any part of EGFR you can prescribe this lina and teneligliptin. Other gliptins you have to reduce the dosage and have to keep in mind. So CKD presentations, according to CKD level, you have to cut down the dosage both via Sita, Vilda and other gliptins. So dear friends, it's a great message from one of our doctors here. A physician once said, the best medicine for the humans is love. Yesterday we had a good talk for love less than hormone, but this is different for the elderly subject. Someone asked, what if it doesn't work? He smiled and said, increase the dose of love. This means not only the education, along with the education, we have to give the extra care and extra love and extra support for the elderly population to get rid from all the complications so that we can under the good quality of life. We have our own mother and father. We have to think before that and we have to help the support the patient to get rid of all the complications. Thank you very much for the great opportunity. Thank you very much.
Thank you, sir, for such a nice presentation. As you rightly said, most of our patients, we are treating them very well, but they just have to tell you something. And the best thing you can do is to listen for 3-4 minutes and say, okay, everything will be fine, and now you can go home.
That is very important.
If there are any questions.
It will be very interesting to find out, would like to ask you that at what age you consider all these strategies. They're very nicely told by you in an elderly diabetic. So what is that age at which you start adopting, considering that he's an elderly diabetic and he should be subjected to these strategies of management of diabetes? Because there could be someone who is 70 and he's not bad enough. I
mentioned 3 categories. One is younger world and old world and oldest world. So those patient comes in the category of the old world between the age 70 to 75 or the age between more than 75 to 80 or more than 85, that we want to consider the elderly population. So that's very important. Yes, more than 75. Yes, sir.
Any more questions?
Excellent talk.
Thank you, sir.
In one of your slides, you said 50% of these patients are asymptomatic. So,
no, 50% are suffering from diabetes prevalence.
But there you said asymptomatic. I have read
maybe some error, I think.
I think it should be over.
Thank you very much, sir.
It was an excellent presentation, sir. And I think dehydration and hypoglycemia should be specifically looked for all diabetic elderly patients. That's it.
Thank you.
I feel we have the best comment, best question, such awards there, and we have such beautiful flower which is to be given to them. So I feel we should encourage that. So
yes. I think the
if
best.
you all permit, I feel the best question award
goes to Dr. Deshmukh, sir.
And the best comment goes to Dr. Shankar Khobragade.
Yes, sir.
Is it okay to you?
Yes, sir. Yes, sir. Definitely.
Chairperson,
Yeah,
please.
yes.
Yeah. So it's and Shankar Khobragade, sir. Let us encourage this thing so that people have more question, more discussion. सर एक ये जो आपको दिख रहा है on the screen, can you just focus this? Yeah, this is made up of cow dung, and इसमें seeds हैं. There are seeds of tulsi and genda, and you just put it in the flower vase और जो आपका गमला में डाल देंगे तो वहाँ पर You'll have a flower, either tulsi or the, what is that? Jo begin. Right. So I feel and this has been prepared by some handicap group of some handicaps. So it's a support to them. So that's what we have. An organization from Sausar, a small village from Nagpur, around 100 kilometers, Sausar. So they prepare it. We have procured it around 100 pieces for 100 lectures. So you are all requested to ask questions, discuss the things, and it's an indirect kind of support to the organization, to the cause and the humanity. Thank you.
Oh, thank you so much, sir, for this excellent talk. And with this, we would like to land this flight with so much turbulence and so much of academic talks, and it was really great. So now we would like to take off for the next flight, which everyone awaits, which is the Hello Diabetes Academia Hippocrates Oration 2024. And for that, I would like to kindly invite Honorable Dr. Anup Mishra, Sir, Padma Shri. Anup Mishra, sir, is the President of Diabetes Foundation India, Director of National Diabetes, Obesity and Cholesterol Foundation, Executive Chairman of Fortis, CDoc Hospital for Diabetes and Allied Sciences, New Delhi. We welcome you, sir. And none other than Dr. Sunil Gupta, sir, who needs no introduction, and who is the National Treasurer of SSDI and National President of DIPSI and Chairman of Sunil's Diabetes Care Network.
So are you all ready with it? Yeah, just get the chair there. Quick. So we have this a very prestigious oration of Hello Diabetes Academia. We had 4 orations. The first oration this time was on gestational diabetes, which has been given to Dr. Uday Thanawala from Mumbai. And we have another oration is Shushruta oration, which was bestowed on Dr. P.C. Manoria, a very senior physician from Bhopal. Then we have an oration for type 1 diabetes awareness and public awareness as a whole, which was given to Dr. Sanjay Agarwal. And today is the Hippocrates oration, and this is now given to Dr. Nihal Thomas. May I have the video of the previous Hippocrates oration? We have the video, Kunal. Yeah. These are the previous recipients of Hippocrates oration. Can we have the music on? Can we have the music on? Now, may I invite Dr. Nihal Thomas, sir, to please come on the stage.
Can we have a huge round of applause for him?
May I invite Dr. S.N. Deshmukh, sir, the Oration Chair of Hello Diabetes Academia, to join me, and Dr. Rajiv Chawla, who is a very senior faculty of Hello Diabetes Academia and our mentor and my elder brother. Please join us. Sir, please have your seat. Please. May I request, sir, to... No, first is the medal. Sir, can. Sir, please. Please be seated. Little discomfort to you.
Sir.
It's okay. Heavy. It's little heavy. Yeah. Heavy. Fit nahi हुई. So citation is. May I request Dr. S. N. Deshmukh sir to please read the citation?
It's a great privilege to read this citation, which has been offered to Dr. Nihal Thomas. Hello, Diabetes. Diabetes Care Foundation of India, Nagpur, and Sunil's Diabetes Care and Research Center Private Limited, Nagpur, is privileged to award Hello Diabetes Academia Hippocrates Oration 2024 to Dr. Nihal Thomas, Senior Professor in Endocrinology, Department of Endocrinology, Diabetes and Metabolism, Christian Medical College Hospital, Vellore. For the yeoman service in the field of medicine and an exemplary delivery of an oration on pathogenesis of diabetes in lean South Asia, dreams and dimensions, DCFI Nagpur and DCRC acceds to your benevolent services to the people with diabetes and your academic accomplishments. You invigorate others by your impeccable virtues and humility of your towering repute. It is a most profound honor to present you with this prestigious Hello Diabetes Academia Hippocrates Oration 2024 during the 10th Hello Diabetes Academia 2024 International Conclave on Sunday, 9th June 2024 at Nagpur, India, signed by Dr. A.K. Das, Program Chair, Dr. Sunil Gupta, Organizing Chairman, Dr. S. N. Deshmukh, myself, Chairman, Oration Committee, and Dr. Kavita Gupta, Organizing Secretary.
May I request Dr. Anup Mishra sir to please offer him. We'll hold this. We'll hold this. Too many things we have. Thank you. Thank you. I'll remove this. Take this.
Yes.
Yeah, please.
Yes, sir.
Thank you, Dr. Sunil Gupta. Thank you, organizers. Such a proud privilege to be over here, right in the center of India, and what is a probably highly central diabetes meeting, which Sunil has been doing over many years. It's also a real privilege to have Dr. Anup Mishra over here, who's obviously been one of my idols over the years when talking about body composition and NMR spectroscopy, some of the first studies done in the country, which certainly inspired me also in many ways. Thanks once again for the privilege for me giving this talk. I'll talk a little bit about a little journey which I've had over the last 20, 25 years, and talk about our relationship with lean diabetes, what has inspired the research. The Velo birth cohort was started almost 54 years back in Velo. It was the first birth cohort which was done in India prospectively, and it's of course the oldest prospective birth cohort in India, started by a very visionary biostatistician, in fact the father of biostatistics in India, Dr. Sundar Rao. And I got involved with this cohort with the retirement of Dr. Raghupati, a pediatric endocrinologist who was involved with it in the year 2006. Over that period of time, we have done a number of studies as a group. It's a consortium and a group which has actually done these studies. We have looked at patterns of glucose in terms of their relationship to lean body mass. We have also looked at the epidemiology of diabetes. In fact, this is a true incidence study of body composition, obesity, and diabetes, if you look at it. And these are some of the studies which have looked at this and showed the alarming statistics in terms of Vellore, which is a tier 2 town, not anywhere in comparison to Madras or Bangalore in terms of its population, maybe 1/10 or less a population of either of these cities. When showing this amazing rise in prevalence, this is the 2014 data looking at the rural prevalence of diabetes starting to overtake the urban prevalence of diabetes. The overall lifestyle changes in rural Tamil Nadu have changed so much that it's indistinguishable, even though the population density is low in these areas. With that, we also started doing studies looking at this large birth cohort, 2,500 individuals, and looking at single nucleotide polymorphisms and the impact on beta cell function as well as obesity. And we found that certain differences existed between the European groups and the Indian groups when it came to the single nucleotide polymorphisms, the ADCY, which was associated with hypoglycemia, impaired fasting glycemia, and low birth weight in the European cohorts, but not in the Indian groups. So also the association with the FTO, which has been shown in many parts of the world and in India, and its association with obesity traits. The MC4R single nucleotide polymorphism is associated with a big frame rather than true central obesity in the Indian population. But these were collaborative studies where the ideas weren't truly our own and were more comparative with the European groups. And it really didn't answer any questions in terms of the pathogenesis of diabetes in the young and the lean as well. And so we started looking at our own epidemiological data. So this is the SPADE study, which was done about 15 or 16 years ago. And the amazing thing is that between 14 to 17 years age in school, boys had a 20% prevalence of impaired fasting glycemia in the year 2008. Another study done 6 years later, published in Journal of Diabetes, showed that if there was maternal or paternal metabolic syndrome in combination, the risk of the child having a metabolic syndrome was almost 6 times more, indicating that learned habits from the parents were probably the most important reason. Well, not probably always. Maybe there was a single nucleotide polymorphism or a genetic addition to this. The FTO was associated with an increased waist hip ratio in the same children in school as well. We also got involved with a network of charitable hospitals across the country with a World Diabetes Foundation grant and started training them. And then we started collaborating with them from a research perspective. We did epidemiological studies in Tripura and Arunachal Pradesh, and probably the Tripura study was the first Northeast epidemiological study we did in a rural part of Tripura. And we found an amazing prevalence of around 9% in this part of rural Tripura, associated with an overweight status which is much more. This was present in both the Tripura tribals as well as the immigrant Bengalis in that population. Arunachal Pradesh, about 5 years later, showed a 5% prevalence of diabetes, and this is truly a very lean population as well. More recently, with my colleague Dr. Felix, we have done work with the ICMR and looked at the Meghalaya population, and similarly, very lean people who have diabetes, and a proportion of them having BMIs less than 20 kg per meter squared. This is from our own rural group, along with my community health department and my colleague Nitin Kapoor. We have found that BMIs less than 18.5, and this is fairly recent, comprise about 0.3% of patients in urban areas and about 0.6% in rural areas. So when we talk about low BMI diabetes, we should be crystal clear as to what we are talking about. Certainly, type 1 slowly evolving immune-mediated diabetes is important, the important cause for young diabetes below the age of 20, autoimmune diabetes. But then we need to think about a number of other conditions which should come into the differential diagnosis. Their frequency varies, but they're extremely important. And increasingly, we are aware, but as general physicians, screening for many of these disorders is not being done. For example, fibrocalcium pancreatic diabetes is a neglected disorder wherein many people don't do a simple ultrasound abdomen to even look for it in lean people who are autoimmune negative when it comes to diabetes. So I'm going to talk a little bit about this. This is our protocol when we have a lean person. What do we do with them? And when I say young by definition, less than 30 years is truly young. I'm also young, but I perhaps I'm not less than 30 years. So when we talk about the important thing about drawing a good pedigree chart makes one big difference to look at autosomal dominant, autosomal recessive inheritance pattern. C-peptides can be done. And the good news is that fasting, postprandial, even random C-peptides, according to recent studies from a clinical perspective, not maybe research, but clinical perspective, are actually pretty good. The GAD antibodies is very important for picking up slowly evolving immune-mediated diabetes, imaging of the abdomen for fibrocalcic pancreatic diabetes, and a CT is always better than an ultrasound, and then body composition studies, which will tell you various aspects of diabetes. Now, we were the first place in India to actually do next generation sequencing in a medical college in the year 2013. And we do our genetics in-house entirely, the sequencing, the bioinformatics, and the interpretation. We use it for young diabetes as well as a number of other endocrine conditions in addition. So I'll first talk about fibrocalcic pancreatic diabetes, a typical patient with abdominal pain, but did not have steatorrhea. And mind you, 20% do not have steatorrhea because they have learned behavior and therefore they stop taking fat in their diet and steatorrhea disappears. And this is a typical patient who's lean. The abdomen shows dilated ducts, calcification, and a shrunken pancreas on a plain CT scan. Stool elastase is low. This is the convenient marker. Normal value is more than 120. This is very, very low, indicating severe fat malabsorption. So this condition should not be forgotten. And ever since it was reported way back in the 1960s in Kerala, the prevalence has decreased in Kerala, but is still very much present, I know, very much in Tamil Nadu and many other parts of the eastern belt of the country. 70% are male. There are no signs of insulin resistance. Their C-peptides will be low eventually. And it's always better to do a CT scan, a venous phase, doing a CT scan, looking at the splenic vein, which looks, artificially enlarged, and a shrunken pancreas at the same time is the best easy study to do. 40% risk malignancy. If you cross the age of 50, there's a 40% chance of getting a pancreatic. So they need annual screening for that. This study was done by Ish Bhatia, and we did genetic work for this study published in the IJMR, showing that 15% of young people with diabetes had FCPD, and that's a big number. Maybe a reference bias for STPGA, but certainly a significant number, and no abdominal symptoms in 60%. So imaging of the abdomen is critical in people who have low C-peptides and who are autoimmune, GAD antibody negative, and if you can do the other battery of tests, that's also a good idea. These patients with FCPD also have low bone density. This was done, a study done about 12 years back, and shows you that they have low bone, they are prone for osteoporosis, and they may be targeted for bisphosphonates at an early age, even the male patients over here with FCPD. It's not associated with vitamin D deficiency. It is probably related to the fat malabsorption, which reduces the bone stroma. We did resting energy expenditure studies using indirect calorimetry in these patients, and we found a paradoxically high energy expenditure in these patients, disproportionately high, which is adding to the weight loss, not just poorly treated diabetes or malabsorption, but also energy. So you need high calorie diets in excess of 2,500 or even 3,000 calories. Give them adequate insulin, give them enzyme supplements at the same time. But why is this happening? Now, we actually found the answer to that a little later, and I'll come to that. This also shows that they have a very high prevalence of cardiac autonomic neuropathy, disproportionate to the diabetes control, probably due to micronutrient issues. There are a number of micronutrient deficiencies in these patients, but we have to be careful now that we're using stool elastase and not 72-hour fat measurements. You can get false positive stool elastase levels even in patients with the duration of diabetes as short as 7 or 8 years. So be careful over there. So this is a study which we did primarily to look at hypoglycemia, unawareness in patients with fibrocalcium. Very, very common, a big problem, appeared to be disproportionate to the autonomic dysfunction that they had. So we did autonomic dysfunction testing, we did malabsorption assessment, and in addition to that, we put them on an FGMS and looked at their 24-hour glucose monitoring over a period of 2 weeks. So we measured the glucagon levels. We found that the glucagon levels were high in a subset of patients with FCPD. Do you expect this in a fibrous pancreas? you do not. Why is it happening? And those who had hypoglycemia unawareness had much lower glucagon levels. This also explains the reason as to why patients have increased energy expenditure. Remember, glucagon in excessive quantities drives mitochondrial function, and this is leading to increased energy expenditure. That answers the first mystery that we had about energy expenditure being high in these patients. So we also asked the question as to why is this happening? Why are these patients having increased glucagon levels? Where is it coming from if it's a fibrous pancreas? So we looked at the incretin axis. As expected, the C-peptides were low, pancreatic polypeptide was low, but even the K-cell function, GIP, was also low. But what was happening along with the glucagon and almost rising parallel to the glucagon increase when we did both IVGTTs as well as OGTTs, and the OGTTs measure incretin output, you can see the GLP-1 and the oxyntomodulin rise almost parallel to the glucagon. So this glucagon is probably coming from the intestine, not from the, I'm sorry, is coming from the intestine and not from the pancreas. It's an extra pancreatic glucagon, and it has been shown in total pancreatectomized dogs that this can happen over here. So it can happen in dogs. And so basically there's a switch, what's happening in the pro-glucagon genome, and the intestine starts producing glucagon along with the incretins when challenged with the mixed meal challenged test. So these are the important things about FCPD which we have found. Very important to do routine imaging in C-peptide negative, GAD negative individuals. To pick up this condition more commonly, osteoporosis is common, energy expenditure is high, you need to give an extra high calorie diet. Glucagon levels are increased along with the incretins at the same time indicating extra pancreatic production, and pancreatic enzyme supplementation is important. Energy expenditure is related to glucagon excess. The next thing was monogenic beta cell dysfunction. We all know the work initially done in the first decade of the millennium, wherein Mohan had looked at Sanger sequencing for looking at MODY. So nowadays that we have next generation sequencing, you can do massive parallel sequencing and do multiple genes at the same time. We have a good scientist, and I think that's the main bonus that I have a fantastic scientist who's really good at various aspects of genetic research. He was my first PhD student many years ago, and he had set up the monogenic screening processes, looking first at MODY, and now has extended to a 62 gene panel for looking at beta cell dysfunction related diabetes. So you can do at one set all the genes based initially on grants, and now it's a regular service in our lab, besides many other endocrine genetic testing that we do. We found that the forms of MODY in our population were different. There was a lot more MODY 4, PDX1, a lot more MODY 12, and MODY 6. And of course, MODY 2 was uncommon in the Indian population, unlike European and American and Western populations. We also asked the question as to why lean women who have BMIs less than 21 or 22, why should they get pre-gestational or gestational diabetes? And a proportion of them, almost 14 to 16%, had a genetic reason for this. This may be a referral bias to a large institution like ours, but insulin requiring patients with who were lean, 18% of them had a MODY mutation association. And this is important because after delivery and had their second child or number of children that they want, rather than giving metformin long term, some of them may be actually candidates for sulfonylureas because they may respond better in those situations. So both our data as well as Mohan's, and we have also done collaborative studies with Kerala, other parts of the country, and also with Sri Lanka. We have shown that the forms of monogenic diabetes are quite different, and it's important, therefore, to understand this. Therefore, the precision therapy of monogenic diabetes can be very specific. 16-year-old girl with diagnosed to have diabetes on routine testing, on thrice daily insulin, came with chronic renal failure as her main problem. She had her usual workup for diabetes. There wasn't anything very remarkable about the family history, and she had a BMI which was low normal. She was also amenorrheic. So the FSH and LH were in the normal range. How do you explain this? This patient did not have Turner syndrome or a pituitary problem, So we did imaging and subsequently followed up with an MRI which showed a bicornuate uterus, the MRI showing an atrophic pancreas as well. And this indicates that she has MODY 5, and we did the genetic testing in-house and proved the diagnosis over here. So it's young onset diabetes with renal disease at the same time, MODY 5. They can be de novo mutations. In about 5 to 6% of monogenic beta cell dysfunction, you can get de novo mutations. Because I don't know if some uncle of hers had an absent vas difference or something else which we don't know, which we may not pick up in the family history. 16-year-old boy came with osmotic symptoms with classical what looked like type 1 diabetes. And he was started on basically was extremely emaciated. His GAD antibodies, IA2 antibodies were negative, and the C peptides also low. But he had a borderline low stool elastase as well. So because of this, we went further and we did genetic testing, and we found that he too had MODY 5. So MODY 5 can have a number of phenotypic presentations. It can look like type 1, can look like hypocalcic pancreatic diabetes with malabsorption, can look like a classical MODY with oral anti-diabetic response. Different phenotypic presentations of MODY 5 can actually occur. 29-year-old lady diagnosed to have diabetes in pregnancy, had oily stools, abdominal pain, and elsewhere was diagnosed to have, was also ultrasound which showed chronic calcium pancreatitis. Stool elastase levels were low. So you can see over here the prominent splenic vein and a grossly atrophic pancreas with fat replacement, and she had what is called a CL mutation causing a genetic cause for monogenic cause for diabetes with malabsorption at the same time. 43-year-old nurse with lean diabetes for 15 years. She came with acute pancreatitis about 16 or 17 years ago, and this is the acute phase. You can show necrotic pancreatitis, acute pancreatitis. All the other metabolic causes for pancreatitis were negative. So she settled in 2 years, and she was my patient, and she was found to have fibrocalcific pancreatic diabetes eventually. That was my diagnosis, and we treated her. She was doing reasonably well, and she's still currently well. Now her daughter came with extreme fatigue and difficulty on getting up from the squat for 3 years, and came with recurrent migraines. The lactic acidosis was high. So this is a diagnosis of MELAS syndrome, mitochondrial encephalopathy with lactic acidosis, who the daughter has, and she basically has a genetic cause. So we then went back. Pediatric neurologist contacted me and said, this is what is happening. We did the genetic testing. The heteroplasmy, or the severity of genetic disease, was more in the daughter. So coming with a more severe earlier presentation, it's a mitochondrial disorder, and the mother comes much later in life. So this is mitochondrial disorders which are classically thought to be maternally inherited. There is a proportion about 20% who may not be maternally inherited, but this is another cause for inherited young diabetes. Can mimic fibrocalcific. Mitochondrial disorders can be very differential in their diabetes. They can look like type 1 in some, type 2 in the others, and even a pancreatic presentation very rarely as well. So here you have the issue of precision medicine, because you can give mitochondrial cocktail to these patients, which can actually prevent the progression of neurological. This lady now she's around 50, she started to develop a hunch and some muscle weakness as well. So I put her on mitochondrial cocktail, which might delay the neurological progression in her. 21-year-old male with recurrent respiratory infections in childhood, steatorrhea, and had stool elastase levels are low. You can see over here that the pancreas is atrophied, and we did an extendation sequencing, and the patient has cystic fibrosis. So not thought to be common in India before, but pediatricians are now picking this up. We need to be aware of this, and adult presentations of cystic fibrosis, milder versions, may occasionally present and mimic fibrocalcific pancreatic diabetes. So this is our pancreatic gene screening. Of the 62 gene panel, we have a sub panel to look for pancreatic causes for young onset diabetes with or without malabsorption, with or without various syndromes, and each of them has a typical phenotype which may present. This is in press, where we have started, we've gone for publication on this work, comparing classical fibrocalcific pancreas and those with shrunken pancreas, non-calcific or dorsal agenesis, and a number of genes, particularly the SPINK1 mutation for fibrocalcific pancreatic diabetes, the classical mutation, The PDX mutation, which is actually a cause for a form of MODY, can also mimic pancreatic diabetes in some, and a whole lot of other mutations. And this is the algorithm that we use over here. And this, of course, could be a separate lecture by itself. Lipodystrophy, the next cause for young diabetes, which we should be thinking about over here. 38-year-old lady came with diabetes at the age of 19 years, hypoosmolar symptoms, diagnosed to have type 1. But she was actually defaulting from treatment on and off, stopped her insulin, 4 days, 5 days, sugars go up to 400, 500, no diabetic ketoacidosis. So we did her assessment and we found that her C-peptide levels were elevated. Her triglycerides were also extremely high. She had this thinned out skin, markedly reduced subcutaneous fat, and she had these veins which are very prominent. These phlebomegaly was also present. We did a body composition which showed this is extremely low. Someone like me will probably have around 25% to 30% of body fat. A woman would probably have a little bit more than. If you have type 2, it goes up to as high as 45 to 50% in a woman and maybe 35 to 40%. It's very low percentage body fat, and the head has an increase over here. It's like a pseudo Cushingoid appearance. The head has more. You can't see it, but the DEXA will actually pick this up. So high C-peptides, severe insulin resistance, lean individual is lipodystrophy. Much less common than MODY or monogenic beta cell dysfunction, but these are insulin resistant mutations. It's called a partial lipodystrophy in this patient. And this is a complete lipodystrophy, another mutation which can present with stunting of growth, premature onset of liver disease. You can see absolutely no visceral fat, but they can develop severe hepatic steatosis and get cirrhosis by the age of 15 or 20 years. So this is the lipodystrophic screening genetic panel that we do. Patients who are lean, very high C-peptide levels, and reduced body fat, which may be differential in parts of the body. The important thing is that partial lipodystrophy responds very well to pioglitazone. So you can actually stop the insulin. If they're getting 100 to 150 units, you put on 30 mg of pioglitazone, a bit of DAPA, some metformin, you can actually stop an insulin and the complete lipodystrophy has a worse prognosis. You may have to continue insulin and give OADs in addition. They all have fatty liver. In type 1 diabetes, fatty liver is actually uncommon. GAT positive type 1 diabetes, they may have grade 1 fatty liver. They don't usually have fatty liver. By and large, type 2, of course, and you see a lot of it. But these patients have excessive fatty liver and are prone for cirrhosis. Another condition which we should be thinking about, this is a 20-year-old gentleman who comes with classic osmotic symptoms on basal bolus insulin. But in addition to that, he started developing early onset of dribbling of urine and bedwetting. And we diagnosed an autonomic bladder dysfunction. The sugars were poorly controlled, and this is the baseline. What we picked up is this high sodium level. When you have high sugars, high glucose levels, you can get pseudo hyponatremia. Now here the sodium is actually high. It's inappropriately elevated. Patient has negative antibodies. It's a little late, about 7 or 8 years, and when he should have had his antibodies, they could have been negative even in type 1 diabetes. But the C-peptides were low, yes, and the urine osmolality level is also low. So this patient has hypoglycemia, but the urine is dilute. This patient has diabetes mellitus and diabetes insipidus. The sister came with a much more rapid progression with optic atrophy, what looked like type 1 again. Then she started developing neurological symptoms, deafness, seizures, and she died at the age of 26 years. So this is Wolfram's-like syndrome. Our genetic panel proves the diagnosis. Patients with Wolfram's-like syndrome can be much milder. Though Wolfram's is autosomal recessive, those with Wolfram's-like syndrome can actually have it come as heterozygotes. And they can come with much later presentations after the age of 10 or 20 and a very slow progression. And it's important to make this diagnosis. This is a series published in the JCM looking at Wolfram's and Wolfram's-like syndrome. The Wolfram's-like occasionally respond even to oral antidiabetic agents. That's very unusual. And more recently, we have compiled our data and started following them up. The important thing is many of them may be misdiagnosed as type 1 diabetes because their first symptom is diabetes. The optic atrophy, the orange ones come much later, and the deafness comes even later. So we need to screen these patients. We prove a genetic diagnosis, C-peptide negative patients without ketoacidosis, without pancreatic disease. Think about Wolfram syndrome or Wolfram's-like syndrome, and the genetic panel can pick this up as well. Why is it important? Because if you stabilize the apoptosis of the endoplasmic reticulum with simple medications like valproate, you can delay the neurological progression. I don't know about the diabetes, whether you can delay the progression, but the other things which will really impair the quality of life and have a neurodegenerative disorder can be delayed over here. And there are randomized controlled trials now showing the efficacy of valproate. Ibidinone is another medication which is being used for patients who have primary optic atrophy, has also been tried in this particular disorder. Finally, I'll come to this very contentious, controversial, much debated condition, protein deficient malnutrition modulated diabetes, reported way back in the 1960s and 70s by Tripathi and Samal. What was called severe diabetes, onset of diabetes before the age of 30 years, very lean, BMI is less than 18, no ketoacidosis, generally no family history, and they seem to require high doses of insulin these days. They have rural origin and they have duct dilatation. They do not have any pancreatic morphological problems. It was removed from the WHO classification because most of the West thought that there's no physiological reason. This is just poorly controlled type 2 who have lost a lot of weight, undiagnosed type 1 or something else, which is just, found in a country which is socioeconomically not too great in those days. So the thing is, with my colleagues who have been working in rural charitable hospitals across the country, it's not an urban phenomenon. We have picked up a number of patients. Their glycemic control is reasonably good, but they are extremely lean. And these are studies published from Jamaica, Ethiopia, Uganda. The last study is actually a collaborative bit of work between me and the Ugandan group. And that have shown that this condition still exists. But the countries which have a lot of it don't have the resources to do research on it at all. So over a period of years, I collaborated with my American collaborator who does a lot of physiological studies. We looked at type 1, type 2 patients who are lean, normal, obese normal, and patients who had this particular condition. Did extensive investigations. It took a long time. It took almost 7 to 8 years to do this study. Imaged the abdomens, did their genetic testing, and then we did a lot of physiological studies. These are called hyperinsulinic euglycemic clamp studies, which are the gold standard for insulin resistance, indirect calorimetry, and NMR spectroscopy as well. And we found that their C-peptide levels are low, beta cell function is low, but not as low as type 1 diabetes. We also found that the hepatic glucogenesis is not as elevated as type 2 diabetes as well. So this is definitely a different condition. It's not type 2, it's not type 1. And their body composition analysis show percentages of body fat, which may be in the range of around the 20% range, but not in the ranges of what we see in type 2 diabetes. And even when their glycemic control was good for a year or two, they continued to be lean. So 50% of these patients respond to oral antidiabetic agents, and that is the good news. 50% don't need insulin. Why does this happen? Because we have not found a genetic cause where maybe additional single nucleotide polymorphisms or epigenetic changes occurring due to malnutrition. Their protein intake is habitually low. So this condition is phenotypically different, and we need to do a lot more work. We've also done NMR spectroscopy studies, which I'm not going to be talking about. It's all related to an aspect of global inequity, and there is a proportion of undernutrition in this country. It's not something which we would like to talk about despite the great progress of our country, but in rural areas it is there. We still have high proportions of low birth weight, and a combination of low birth weight or antenatal malnutrition with postnatal malnutrition can actually probably leads to this condition, but that is hypothesis. Low birth weight studies done years before by our group looking clamps, calorimetry, and NMR spectroscopy have shown that if you're born low birth weight, you have reduced muscle mass, which is prominent, and increased total body fat. and regional fat maldistribution in low birth weight individuals compared to normal birth weight, and they are shorter as well. And this, as they accrue more fat, can get more of an early type 2 phenotype. But if they are malnourished after that, continued malnutrition, they are probably more prone for what we are calling the inverted commas malnutrition modulated. I'm not saying it's due to malnutrition, but it's a different disorder. If you make these people exercise, they actually respond to exercise. The low birth weight individuals have an improvement in their insulin sensitivity and they respond to exercise, and their body fat comes down and their muscle mass increases. So this is just a table showing how you can use C-peptides in your population, which is to differentiate the different kinds of diabetes. Very empirical. There can be always overlaps. For example, Modi can have C-peptide levels which may even overlap with type 2 diabetes. So it's not always, absolutely discriminatory as far as that is concerned. And body composition studies, and this is a classical type 2, a young type 2 showing the increased percentage body fat. And the body fat distribution is the opposite of lipodystrophy. There's increased fat all over here, but the head fat is actually less than the rest of the body. So this is how you can use DEXA scans, look at your fat composition. So let me conclude and say, in patients who have lean diabetes, please think of these other conditions as practicing clinicians. There's a lot more research that we need to do. I haven't talked about our HIV lipodystrophy work, but interestingly, these conditions, patients have lipodystrophy, but the progression to diabetes in our Indian patients, which we have a cohort now, which we are following up, is not that great. I might actually take it off the differential diagnosis list in due course. I'd like to thank a number of funding agencies which have helped, innumerable collaborators, many consultants, registrars, etc. in our department who have helped. These are just a few photographs and a few names, but there's a lot more who have helped down the years. Thank you for your patient listening. It's been an absolute privilege.
That was a great
I'd
lecture.
like to invite all of you for a meeting which we're having in Vellore in January on 10th and 11th, and you're most welcome to come. Accessibility to Nagpur and Vellore is kind of similar if you talk about it, but certainly it's during winter, and global warming will not have its influence at that time. Thank you so much.
You will, if you start counting the researchers in India as far as diabetes is concerned, you will not go beyond 2 fingers. That's all. 2 to 3 people who are doing top level research. And Dr. Thomas is one of them. Number of research studies that you have seen. Great researcher. And whenever you are doing research, one must keep in mind that it should have a practical implication. And Dr. Thomas' research has clearly identified subgroup of type 2 diabetes who are lean and who have multiple etiologies so that you can characterize them better and treat them better. This is what India's research means to us, because Western research has no meaning as far as this subset is concerned, because they don't even see such patients. So great research. Thank you for that oration.
I request our captains to felicitate our pilot at the Felicitation terminal.
Thank you. Thank you so much for such a wonderful oration, sir. We would now like to move on to the flight number 52, which is the pearls from the Padma Shri's Oration. So for that, I would kindly request Dr. Shankar Vashisth, sir. Dr. Shankar Vashisth, sir, is a senior general physician at Kailash Clinic, Nagpur. And I would also like to invite Dr. Rajiv Chawla, sir, who is a senior diabetologist and director at the North Delhi Diabetes Center, New Delhi. And he has more than 110 papers related to his work on micro and macrovascular complications. We welcome you, sir.
Good morning once again. It's a great pleasure to be chairing a session for Professor Anup Mishra, a top-class clinician and a researcher of par excellence. He has been the one who has been inspiring all of us in the field of diabetology. He's an executive chair, Fortis CDoc Hospital for Diabetes and Allied Sciences, director, National Diabetes, Obesity and Cholesterol Foundation, president, Diabetes Foundation India, former professor, All India Institute of Medical Sciences, New Delhi, former faculty, human nutrition and endocrinology, and has major achievements in the form of 350 published research papers in one of the best peer-reviewed journals, lot of citation, very high index, and he's editor-in-chief, Diabetes and Metabolic Syndrome, Clinical Research and Review, which has an impact factor of 10. So over to you, Professor Mishra.
Thank you, sir. I thank the organizers for excellent organization. And Sunil, Kavita, the team is so well set in organizing such symposia. I have not seen such organizations as well. So kudos to all of you. Please give them a big hand. My lecture is very simple and very practical. I will give you some practical advice. And I have put edible nuts as a research topic because that's where we have done a lot of research. I will not discuss all the aspects because of limited time. This is my research field for this research and various other kinds of research that we are seeing. Nut intake is considered to be heat producing and causing weight gain. This is the prevalent situation as far as the Indian population is concerned, that garmi paida karti hai or weight gain karti. This is the usual situation. Over last 2 decades, it has become clearer that macro and micronutrients in the nut are beneficial. And role of nuts in prevention or management of diabetes continues to be researched. Now, what are the nutrients in the nut? Now, fats are very high. One would say fats are high, so it will be bad. No, good fats are there. MUFA, high amount of MUFA and polyunsaturated fatty acids, which are good for body. Low amount of carbohydrate, most of them is fiber and vegetable protein in variable amount depending on the nuts that you're using. And number of beneficial components like magnesium, selenium, polyphenols, beta carotene, vitamin E, and zinc. Just 1 or 2 slides on experimental studies so as to give you an idea what nuts can do in experimental models. The experiments have been done using extracts of nuts or whole nuts and mice and rats. Now, if you look at the peanuts have high amount of folic acid. Now, this is the spectrum of the various fatty acids in peanuts. And these are 3 types of peanut this researcher has used. And if you look at this, very high amount of folic acid, which is a monounsaturated fatty acid. Now, if you look at the mice experiment, increased insulin production by rat pancreatic cell line, INS1 treated with folic acid. And increasing amount of folic acid lead to increasing amount of insulin production. If you look at the human being, then in type 2 diabetes, robust reduction in the blood glucose levels. Look at this type 2 diabetes here. This is the blood glucose level, and this is the with the peanut oil. It is decreased, but not in type 1 diabetes. So this is one experimental study. The second experimental study is equally important. That's done with walnuts. Now, walnuts. This is the control. This is the mice who are fed with high fat diet. So they have a lot of liver fat. And this is high fat diet with walnut. Look at the liver triglycerides. They decrease after walnut intake. And if you look at the enzymes, they also decrease. And if you look at the inflammation in these mice, inflammation decrease. And look at the histology, control, high fat diet mice, high fat diet with walnut. Look at this fat here, which has decreased with walnut, inflammation, the marked inflammation is decreased with. And at the same time, their oral glucose tolerance test show that those who have given walnut have decreased glucose as compared to the high side. So these are two experimental studies clearly demonstrating there's something in the nut which works well as far as the metabolism is concerned. Now let's go further. Short-term human intervention study. Almond, pistachio, and other nuts have been studied. And overall, the most benefit is on postprandial hyperglycemia. Now, this is one of the best studies in 2011 by Kendall. Excellent study. I will explain to you. And look at this. Not many people are required for such great studies. 10 people, only 10 people. Now, look at this. The white bread, this is the oral glucose tolerance at 39, 60, 90, and 120. White bread, look at the blood glucose profile with white bread. And if you look at the pistachio nut, 28 grams, 56 grams, 84 grams, flat glucose profile. No excursion whatsoever. And if you look at the combination, so white bread is right here, and then you combine bread with 28 gram, 56 gram, 84 gram, consistently lower profile of blood glucose when you combine bread with pistachio. And if you look at the various other components, white bread we have already shown you, but rice decreased. Pasta along with nuts decreased. Mashed potato along with nuts decreased. So look at beautiful study with 10 people demonstrating benefits of nuts. Now, if we go further, the longer term, 3 to 6 months human intervention study. And I just pick up one such study from one of my friends from Canada who have, this is 2014 study, who additionally looked at GLP-1 level and gene expression. And if you look at this, 4-month crossover study in 54 people, decrease in fasting blood glucose, insulin resistance, fibrinogen levels also decreased. Cellular glucose intake increased. And GLP-1 levels also increased. Look at the cellular glucose level. With the pistachio diet, look at it. And also, the number of genes which pertain to either inflammation or insulin pathway. Insulin IL-6 gene, resistance gene, and SCL24A all have become better. Decrease or increase, showing that glucose pathway may become better. And also, they affect telomere. Telomere are something which have to do with our lifespan. The shorter the telomere, the shorter the lifespan. So anything which increases telomere, their metabolism becomes better, so that telomere increase in length, increases our lifespan, and this study shows that oxidation of telomere becomes better with the pistachio nut. Now, our studies. So I'll show you some previous studies and some recent studies. So why should we do studies? And I was telling when Dr. Thomas, the lecture was going on, because we are different. And unless we do study in our population, the Western population will not do study for us. We have to do ourselves. Asian Indians develop markedly this metabolic state from the early life. Diabetes occurs early and takes aggressive course, and pre-diabetes to diabetes conversion is accelerated. We know that. And nuts are traditionally considered to be healthy, but fatty in India. This is the background. And if you look at some of our previous studies, this was a study done almost a decade back. A randomized controlled trial, nuts and equal calorie diet. One group was given nuts plus diet, and equal calories were given in the other group. This is a 24-week randomized trial. And if you look at the data, there is no difference as far as the glycemia is concerned, but the inflammation is decreased and adiponectin is decreased, and subcutaneous fat using MRI, we did MRI, in these people subcutaneous fat, which is perhaps the most important fat markers in Indian population, decreased. So we saw it early, a decade back. And once we use this as a snack in people with diabetes, this is a 24-week study, 0 to 24 weeks, you use snacks, and otherwise the calories remain restricted according to the diet plan. And we look at the hemoglobin A1C, which decreased along with waist circumference, waist height ratio, lipid, and FLD also decreased, HSCRP and pulse wave velocity. So number of benefits we saw in this particular study. Then we wanted to do something else. Give nuts in different manner. Give nuts before the meal, a preloading of nuts. Now these are 3 preloading studies. Now preloading is particularly important. All of you can do it. This is something which is of practical importance to every diabetic patient. OGTD based crossover study, 3 days CGMS based study, and 3 months randomized controlled trial, establishing preload as a viable method to decrease postprandial hyperglycemia in Indian population. These are the group, the people 18 to 16 years of age with pre-diabetes. And almond preload load was 20 grams of almond, which is 15 to 17, 18 almond before the meal. These are the design of OGTT and CGMS based study of phase 1. This is a crossover study. Crossover is the best design. I will not go into deep design of this, but period one group was given only glucose and other group was given glucose, but before that almond. And similarly, the CGMS based study, 3 days CGMS, where one group was given almond before each meal and then other group was not given. Here it was equivalent. Both groups were equivalent. Each group was tested twice. So it was a crossover. This is published in European Journal of Clinical Nutrition. And if you look at the data is so beautiful, impressive data. Load of almond followed by glucose here. And look at once glucose only is given, then this is the graph. When load was given along with glucose, this is the graph. So before glucose, almond is given, glucose levels fall. And insulin levels similarly, and C-peptide levels similarly, and also DPP4, which is the plasma DPP4, is a problematic substance, also decreased. GLP-1, there was no difference, so I'm not showing it. Then CGMS based study, 3 days CGMS based study. And look at the beautiful graph which has come. Isocaloric diet and pre-meal load of almond over 3 meals. Look at the decrease in the graph. Post-meal, pre-meal, everything decreased over 3 days. But this was a short-term study. Whether this will hold in the longer term was not known till we did the 3-month study. Before that, these are the glycemic variability and glycemic control parameters on CGMS which improved. 3-month study was published in Clinical Nutrition. And if you look at this is the various parameters studied in one arm which was not given almond and the other arm preload. And if you look at this weight, BMI, waist circumference, hip circumference, all decrease. Some skin folds, the thickness of subcutaneous fat decrease. The strength in fact increase, meaning thereby the muscle strength increase. And PP glucose, PP insulin, HOMA, HbA1c, all decrease. Also lipid level. So it is working well over 3 months in the free living people. Having said that, last part of my lecture is other studies, meta-analysis also. Now, if you look at the meta-analysis of 2020, of various studies, hemoglobin A1C and fasting blood glucose level, systemic review of study 3 months or less in duration in 2020, 15 trials, 667 subjects, they showed that there is decrease in the fasting blood glucose and A1C level, but it is not significant. So there are some studies which show significance and other studies which did not show significance. Now, if you look at the effect of tree nuts and peanuts on incidence and prevalence of diabetes, whether if you take today, you're not diabetic, decrease the diabetic at all, or prevalence of diabetes decrease. So, if you look at this cross-sectional four studies, prospective studies, I've taken only the important meta-analysis, and if you look at this, no effect on prevalence, no effect on incidence, and low certainty of label of evidence. So, not very good studies, but still, this is what it is. And if you look at the mortality, on the left side is mortality in general, non-diabetic people, left side. Per 28 gram per day increase in nut intake, decrease mortality in this people subset analysis due to diabetes. So overall decrease mortality and subset people decrease mortality. But if you take people with diabetes alone, these are two studies. This is nurses health study, health professional study, and if you look at this, the participants who consume 5 or more servings of total nuts per week, one serving is 28 grams, compared to those who consume less than one serving per month, the total CVD incidence, CHD incidence, except stroke, CVD mortality all decrease, and cancer mortality also decrease, all cause mortality also. These are the meta-analysis. So, summary, this is our paper. Several of these are papers where our group has been involved. This is the international multidisciplinary group where we summarize nuts in prevention and management of type 2 diabetes, written a couple of months back. And if you look at the clinical trial evidence in people, acute trial evidence in participant free of type 2 diabetes, and participant with type 2 diabetes, postprandial hyperglycemia is the most important, which decreased. But insulin did not decrease. Longer term trial evidence in participant free of diabetes, participant with type 2 diabetes, fasting glucose also decreased in postprandial hemoglobin MSC also. And the epidemiological studies show multiple things which have improved, including fasting plasma glucose, insulin, HOMA, OGDT, but except diabetes incidence and prevalence, CVD and diabetes mortality. So I summarize my presentation. Nut intake has beneficial effect on glucose insulin metabolism and decreased hepatic fat in experimental level. I showed you that. In short-term human intervention studies, prandial intake of nuts decreased postprandial hyperglycemia. In studies of 4 to 6 months duration, intake of nuts decreased blood glucose level, triglyceride inflammatory markers, and increased GLP-1 levels in severely affected genes. Pre-meal load of nuts we have clearly established. Not that we are the first one to establish, but we clearly established in the Indian population that it is an effective way to reduce postprandial hyperglycemia, and you could try in your patients with a great level of certainty. This can be also tried in type 1 patients and gestational time. So those where pharmacological therapies are limited, you can try. There is no association with nut intake and incidence and prevalence of diabetes. Nuts decrease incidence mortality due to cardiovascular disease, and this is very firmly entrenched down in mortality due to cancer. Overall, despite above encouraging studies, more definitive evidence is required to assess impact of nut consumption on prevention and management of diabetes. So thank you for giving me this opportunity. Thank you, sir.
Thank you very much, Dr. Mishra. It was an excellent presentation and a very innovative phase of research. And we really congratulate you on a fantastic journey that you have taken on such a thing like edible nuts and diabetes. If there are any questions, we have few minutes, so we can go ahead with the question. What are the nuts have you tried except almonds? What other nuts have you tried except or any other nut? Only
I have if you see our studies, the first one was with pistachio, and second one was with almonds, and third and fourth and fifth one are with almonds. Theoretically, any nut will work, and you have we've seen that the peanuts are shown new experimental studies and walnuts are shown new experimental studies. There are a number of human trials with these nut powder.
So you recommend only single particular nut or a mixture of nuts? You recommend only particular nut or a mixture of nuts?
All I can tell you is what we have done in the Indian population. So both pistachios are good, pistachio and almond both combined together also should be good. So what I tell my patient is that to have a handful of nuts. It's a very practical type of advice. Handful of nuts, you can mix pistachio, almond, and walnut, all three which are very easily available. Take a half as a snack in the mid morning and half of the snack at the bedtime, and that should do for you.
Thank you, sir.
Thank you, sir. With the permission of the chairperson, Dr. Shankar Vasist, I would like to ask a question. It was a very excellent deliberation by Dr. Anup Mishra. Last year also he has given. The question is, peanuts, actually, they are poor man's cashew nut. We are eating a lot of peanuts. And the question is, what is the incidence of oxalate nephropathy? And second question is, peanuts are having aflatoxins and incidence of cancers. So in your study, I would like to.
Yeah, aflatoxin I will not be able to answer because yes, the most of the peanuts which are available in a quality store will probably not have any aflatoxin. Yeah, but peanuts, I think there's not many other studies from India in nuts, but one study which has been done with the peanut by Mohan has shown similar results. But it was not preload study. It was incorporated in the diet. So you must be clear. Nuts incorporated in the diet, snack or otherwise, versus preload. These are two different things. Incorporated into that also helps. And our first study, where pistachio was showed decrease in the inflammation, decrease in subsequent fat, was incorporated in the diet. And the recent three studies are with preload. A preload, why is it important? Because Indian population have marked postprandial hyperglycemia for whatever reason. You may take more rice, whatever it is. It is there. And postprandial hyperglycemia is remarkably resistant to treatment sometimes. And you have to try a whole lot of postprandial regulators, this and that. Sometimes use a small short acting insulin and things like that. On the other hand, there is one study which shows that preload of nuts can work as good as a carbo. Almost equivalent decrease in the blood sugar as a carbo. So look at the power of this particular approach as far as that is concerned.
Yeah.
Thank you for that wonderful talk, Dr. Mishra. One of the salient features of your study, you have showed a fantastic impact in terms of insulin sensitivity, insulin resistance reducing. You've also shown changes in body composition, which have actually been very positive. For the volume of what you're actually giving, the response is amazing. And I was wondering whether there is a missing link in terms of the physiology over here, whether nuts have a direct effect on mitochondrial function and whether there's an impact on oxidative phosphorylation. Has anyone actually done human energy expenditure studies with indirect calorimetry on people consuming nuts? In fact, since you're so into this, I was just wondering whether you should be actually looking at that perspective.
Sir,
Could you hear me? Sorry.
Sir, can I add something about aflatoxins? Aflatoxin nuts look always diseased. Nuts with aflatoxin, ground nuts. And when you are taking handpicked selected nuts, there is no aflatoxin.
Changes in apoptosis with nuts. Apoptosis.
No, aflatoxin.
So that first there is certain reference to body composition analysis with nuts. Now remember, when we are doing the studies of the nut, we are careful not to exceed the calorie in the arm where nuts have been given. So don't think that you are taking whatever diet you have and over which you will take nuts and you will be fine. No, you are not going to be fine. You will probably gain weight at that time. But If you decrease the rest of the components in the diet and have a dietitian do that for you, one almond is 7 calories, 7 calories. So 10 almonds is 70 calories. And here we gave plenty of almond, but decreased rest of the macronutrient. Keeping in mind that macronutrient composition is almost similar to the other parallel diet which we were testing. It is not easy. It's not easy because fat becomes much more once we are using the nut. So you have to incorporate nuts within the permissible dietary calories that is assigned to you. Do not overdo that. That is number one. Number two, as far as body composition is concerned, we showed that not only nuts overall decrease the waist circumference BMI, but also the subcutaneous fat using MRI. But we did not do MRI in the preloading study. We did MRI in the pistachio study. Now, I have no answer to as far as the mitochondrial effect of nuts on mitochondrial function is concerned, but it has multiple effects. It has effect on satiety, it has effect on GLP-1 levels, it has on NPY, ghrelin levels, it has effect on MUFA, multiple inflammatory parameters, and gut micro. So, whether directly there is effect on mitochondria needs to be tested, but I showed you some other things like the telomere, and there is a good, at least salutary effect on telomere. So it is probably working in multiple other ways also. I also showed you inflammatory genes which are upregulated, downregulated with this use of nuts. So multiple ways it is working. That remains to be tested. And what was the last one? The apoptosis. Aflatoxin.
Aflatoxins in peanut.
Peanuts, nephrotoxins. Nephrotoxicity with peanuts.
Oh, nephrotoxin. There is no nephrotoxicity as such in Dr. Mohan's study, and there is none as far as our studies are concerned. There is no, we be careful. Once they are improving all the parameters of inflammation and decreasing the blood glucose levels, decreasing weight, the kidney will only improve, liver will only improve. So there is none whatsoever, at least in short term, 3 to 6 month studies that we have done.
During the COVID period, there was one military man, and during that period, it was advised that you take more high-calorie diets. So what he has done for 4 months, he has consumed a lot of peanuts and almonds and pistachios, all that daily. And after some days, he was having edema feet and anuria and all that, and it was investigated. And his kidney biopsy was done, and it was found to be a case of oxalate nephropathy because peanuts contain a lot of oxalic acid and a lot of potassium. So I would like to ask, are there in such case report? There was so many case reports in the literature also. Oxalate acid nephropathy.
See, individual cases are different from research which is being done on a larger scale. And when you have the research which has been with the ethics committee based meetings, the research module will give you an ultimate take home message. So what is the take home message for the entire clinicians who are sitting here today? That one, nuts are very important for the Indian population, and the pre-meal nut dose, if it is incorporated in the diet, is very beneficial. That should be the ultimate take home message.
The message is anything in excess is a poison actually.
Of course, we are not sure in that particular case study how much was the intake of peanuts and whether that led to oxalate nephropathy. I think that is difficult to prove. I think it was an excellent deliberation by Professor Mishra, and what I see most of his studies are. These were like quality studies, and it is more like quality research, pilot studies lasting for close to 6 months. What he said on incidence and prevalence of diabetes probably could be because of the fact, and what Dr. Nihal also rightly said, effect on BMI and maybe visceral fat, may be more apparent if you go for a long-term RCTs versus placebo or versus an active control, because these were usually 24 weeks data. So maybe change in incidence and prevalence, or maybe a true reduction in CV death or overall mortality may not be very apparent in these.
As far as the kidney is concerned, none of the trials have shown any signal. None whatsoever. Leave aside my trial. None of the trials which have gone on or epidemiological studies have shown any signal. And keep this in mind that the nuts composition have high MUFA, not high protein. If you think that protein may be causing this, it's not protein. Protein. Protein is limited. It's still. The MUFA is not. MUFA is the most important component. And so there is none. You can be very rest assured. Moreover, this is not just my recommendation today, but Government of India's recommendation today. Because 15 days, 20 days back, Government of India released the dietary guidelines for India, and the first thing, that first sentence they say, nuts and seeds should be incorporated in everybody's diet. That is the importance of nuts and seeds today.
Sir, how many minutes before we have to
30
take?
minutes.
That is the main practical.
But very good question here. There are two questions here which are often asked. And second question has not been asked. First, you have asked the first question about the timing. So we have chosen 30 minutes because many people have chosen 30 minutes early in the previous study. So shorter studies, smaller studies, and so on. But people have also given 15 minutes before or just before also. For example, the Japanese study, Japanese eat a lot of rice. That they have put not nuts, vegetable before rice, vegetable. And similar studies as we have done. Similar. We have the slide of that for short of time as it's not today. Clearly show same in CGM study, on OGTP study, and the moment study. The moment it eat vegetable, of course, it is not practically possible once we are eating the vegetable, पहले खा लो और बाद में rice खा लो, ऐसा मुश्किल पड़ेगा. But this is the study. And not only vegetable, but also there are several other things which have been tried. For example, protein powder has been tried. And the whey protein has been tried as one of the preloading substances.
So I feel this is one of the another measure we can be taking care of postprandial hyperglycemia. We have a lot of strategies. We have splitting of the meal. You have order of the meal. Now you have nuts half an hour before the meal. But have you done in people with diabetes also, sir? It's only normal population.
This was our studies are mostly pre-diabetic.
Pre-diabetics.
The thing with the problem we thought about diabetes, but the problem with diabetes is that there's so many other variables come in, including the drugs and so on.
The duration, the drugs, the severity of hyperglycemia, and a lot of other things might be interfering. So.
But pre-diabetes is pure. There's no drug involved, and you can study very well. Yes. And that's what we have done. Incidentally, in this study, which I have not shown, in the 3-month study, there is reversal of pre-diabetes. Reversal of pre-diabetes in 30% of the cases using the nuts. Same manner. So reversal of diabetes using equal calorie diet, not a low calorie diet.
Yes,
it's possible if you do this.
In 6 months'
This is the
time?
beauty of this.
6 months' time?
3 months.
3 months' time? That is encouraging. I think to Sunil, to you, and to me, we are in practice of GDM. What he made a clue is that maybe it could be used as a drug for postprandial glycemia in patients with GDM, those who are actually pre-diabetes outside
The
pregnancy.
quantum you said is 50 grams, right? 50 grams. The quantum
Quantum
is 50
28 grams, you said minimum pistachio. Quantum
How much gram?
amount of
Wait, I showed you.
28, 56.
20 grams of nuts, almond, with half an hour before meal, 3 times a day, in 3 months study. 3 times a day in CGMS study, and only once in the OGTT study, because OGTT is on.
It's okay. Yeah.
20 grams is 15 to 17 ounces.
Okay.
15 to 17 ounces. It's not, some people say it's not easy to take. Surely, it is not easy to take.
Sir, 20 gram will not be 15 to.
No,
15
he said 20 gram, 2
times
to
a
3
day.
times a day.
3 times a day.
So
One
that
almond
comes
will
out
be
to be
around-
almost 50-60 gram of almonds.
Yeah.
Pistachio he has shown earlier also 28 grams and 56 gram.
So
28 grams is one fist.
Yeah, around 8 to 10.
Yeah, roughly.
Simplify it by saying that it is one
Around
case.
8 10 लेके करेंगे.
Thank
Thank
you.
you.
So
Actually,
I
very
think-
encouraging session. Let's give a standing ovation
Yeah.
to sir. Wonderful original data coming
Thank you.
only from India. So for us, for our own patients, and very clinical kind of approach we learn from you, sir. Thank you very much.
Thank you, Professor Mishra, and over to you.
I request the chairpersons and the speaker to decide the best question or the best comment. I request the chairpersons to felicitate the speaker.
Thank you so much, sir. For the next slide, we would like to kindly invite Dr. S. Chandrasekhar, sir, the head of department and professor of Stanley Medical College and Hospital. And I would also like to kindly invite Dr. Shankar Kobragade, sir, who is the senior physician and diabetologist at Nagpur. We welcome you, sir.
Good afternoon, ladies and gentlemen. I think in the era of gliptin and gliflozin, like we often see many of our patients, they will be requiring a lot of insulin. Definitely, we need to have a comprehensive strategy to tackle this problem. Though we do have some of the rarer conditions with insulin-resistant drugs, endocrine conditions, facetious, inadequate techniques, all these things can contribute to a person to develop a condition where they require a lot of insulin. To talk on the managing a patient with requiring unusually high dose of insulin, it's my pleasure to invite Dr. Sushil Jindal, who is a famous eminent endocrinologist from People's College of Medical Sciences, Bhopal. He has done his DM endocrinology in PGH Chandigarh and written and contributed academically in various textbooks and 30 publications to his credit. Over to Dr. Sushil Jindal.
Thank you, Dr. Sunil, for inviting me. It was really a wonderful program, and I learned something from this program. So my job is to talk about managing patient requiring very high dose of insulin. So this is the outline. What is the unusually high dose of insulin? The physiology of normal insulin. What are the etiologies, types of syndromes, which are slightly rare, but we must know something about it and how to manage them. We know that approximately a healthy person produces 0.2 to 0.5 units of insulin per kg per day. That turns out to be around 18 to 40 units of insulin produced per day. Half of this insulin is secreted in the basal fashion, but remaining half comes in the form of sharp peaks, short-lasting peaks, which is to cover the postprandial glucose. All this insulin is secreted in portal system and goes to liver, where it is mostly required. And so when we give insulin by subcutaneous or IV route, probably this is not the physiological way. Very small portion goes to liver. And type 2 diabetes as well as obesity are known to produce insulin resistance. So naturally in these conditions, we will require higher dose than the naturally required. And the stress, the physiological stress, the surgical stress, the infections and high circulating counter-regulatory hormones can further accentuate the demand for insulin. What is unusually high dose? Now, when a person requires a dose of more than 1 unit per kg body weight per day of insulin to control the glucose, then this can be considered as unusually high dose of insulin. But there are certain conditions which are known where very, very high doses of insulin are required, and these are known as syndromes of severe insulin resistance. And these are defined as when you require more than 2 units per kg body weight per day of insulin, or more than 200 units of total dose of insulin per day, then these are categorized into severe insulin resistance syndromes. Now, this is the normal pattern of insulin secretion. You can see that this dark line which shows that there is basal insulin secretion which goes off when sugars fall below 80 milligram per deciliter. But there are also very sharp insulin peaks which come. The most important thing to remember is that if our regimen of giving insulin is such that there is unnecessary intermeal hyperinsulinemia, this is going to produce defensive snacking, weight gain, and this will further worsen the insulin resistance. And so remember the dictum that weight gain despite poor glycemic control is a clear indication of over insulinization. That is, you are unnecessarily giving insulin when it is not required. Now, these are various etiologies for very unusually high dose. Glucocorticoids, atypical antipsychotic drugs, we'll talk about them. Many drugs like protease inhibitors, which we use for retroviral infections, oral contraceptives, and then endocrine conditions like acromegaly. Glucogonemia is very rare, but thyrotoxicosis is fairly common. Cushing syndrome, we as endocrinologists keep seeing, and pheochromocytoma, also a rare condition, but they also requires high doses of insulin. And then pathophysiological conditions where pathology requires physiologically high doses of insulin, severe stress, trauma, sepsis, surgery. Ketoacidosis, when patient is in ketoacidosis, usually require higher doses of insulin, and once ketoacidosis settles, usually the dose is almost 50% of that. Pregnancy and puberty are also physiological conditions where you need higher doses of insulin. Now, these are some syndromes which are associated with very severe insulin resistance. Type 1 syndrome is where there is genetic mutation in the insulin receptor. Type B is when there are antibodies against insulin receptor, and type C, we do not know the reason. And also we discussed in the morning that when there are anti-insulin antibodies present, they can mop up the insulin and then insulin requirement may go up. HIV associated lipodystrophy and other lipodystrophic conditions, we listened something about it from Dr. Thomas also. Now, syndromes of severe insulin resistance, they are rare disorders. They are not commonly seen, and they are characterized by profound insulin resistance, metabolic abnormalities, and clinical consequences. And they may be hereditary or they may be acquired also. Exogenous insulin requirement is more than 2 units per kg body weight per day or more than 200 units per day. Large doses of insulin can create their own problem because volume is more, and also the pharmacokinetic and pharmacodynamic also changes of the insulin activity. Fasting insulin levels are usually more than 30, and when glucose challenge, this may go up to 350 also in these conditions. Now, coming to type A, here we have genetic problem and the insulin receptor is defective, and this is leading to various problems like very severe acanthosis nigricans, extreme insulin resistance, and in females hyperandrogenemia. And this is usually seen in lean patients, and they are young patients. Now, the insulin receptor mutation affects the insulin receptor, and onset is usually in adolescent, and female frequently show PCO-like morphology, oligomenorrhea, infertility, and they are often misdiagnosed as lean PCOS. Patients have normal or low fasting triglyceride levels. Now remember, whenever the insulin resistance is high in other condition, triglycerides go up, but here triglyceride is low. Absence of insulin autoantibodies and absence of insulin receptor antibodies. And then for confirmation, you need genetic studies which are not usually available to us. Treatment is lifestyle modification, metformin, pioglitazone, because all the receptors are not affected by mutation. There are some receptors which are still working, and this is how you can put the patient on pioglitazone, SGLT2 inhibitor. And U500 insulin has been recommended. And there are also some studies suggesting that IGF-1 analogs can be used. Now remember that IGF-1 also interact with insulin receptors. Now, type B type of the insulin, severe insulin resistance, there are actually antibodies. So this is also associated with autoimmune diseases, particularly SLE. And this usually affects middle-aged people, and as compared to the previous one, which is younger people, and mostly it affects the females. And then again, the patient again presents like polycystic ovarian syndrome, hyperglycemia, oligomenorrhea, and infertility. And sometimes these patients can also present with hypoglycemia also. Again, here the triglyceride levels are normal or less, but adiponectin levels are high. And these conditions are usually treated with immunosuppression, and these are one of the rare times when you need corticosteroids for treatment of diabetes. And rituximab is also being used, and this has been very effective. And it has been shown that after the patient improves, you have to give the maintenance therapy with the immunosuppression. Spontaneous remissions are known after years also, and when patient goes into spontaneous remission, they may get present with the hypoglycemias also. Now these are pictures. You can see this is type B type of very severe acanthosis nigricans, and after immunotherapy, almost complete reversal of the acanthosis nigricans, both in the neck as well as. And this is type C, which we'll be discussing next. This is a female with the hirsutism, and you can see the perioral acanthosis nigricans also. So type C is also known as Hare-An syndrome, that is acanthosis nigricans, hyperandrogenism, insulin resistance, and acanthosis nigricans syndrome. Severe insulin resistance is present, and cause we do not know. Probably there is post-receptor defect in these patients. Usually young patient, obese, and they also have PCOS-like morphology and oligomenorrhea and infertility. But here triglyceride levels are unusually high. Lifestyle modification, metformin, pioglitazone, and SGLT2 inhibitors can be tried. And hyperglycemia, when sets in, is very, very insulin resistant. Now coming to lipodystrophy, now these are conditions which may be acquired, these may be familial, these may be also genetic, and again they may be generalized or they may be partial also. So there is bilaterally symmetrical loss of fat from the subcutaneous tissue and deposition of this fat in other parts of the body. This may be in the upper segment, lower segment. The veins and muscles, they appear very prominent, and fat is redistributed, and subcutaneous fat is more distributed in liver, in the visceral fat, and also the breasts are usually spared. So these patients, they have very high triglyceride, and these triglyceride can lead to hepatic steatosis, cirrhosis, and also pancreatitis. And they can be treated with lifestyle modification, pioglitazone, fibrates, and now certain types of lipodystrophies, the leptin analogs now have been FDA approved for the use. Now these are various, you can see that which part is getting fat loss and where it gets deposited. And this is a picture of our patient in whom we could not control the glucose with very high doses, and later on we found that patient is HIV positive and taking retroviral therapy. And now he had lost fat in the lower half of the body, and there was accumulation of fat around the neck. Now severe insulin resistance because of insulin antibodies can also happen. Now circulating antibodies can mop up the insulin, and then it can produce severe degree of insulin resistance. And these patients, sometimes what happens is that all of a sudden these antibodies release the insulin and patient goes into. Same thing was discussed by Dr. Ambulkar in the lecture, in the previous lecture. And this can produce severe hypoglycemia. The antibodies are triggered by certain drugs. I had a patient in whom the carbamazepine was initiated, and patient developed severe episodes of hypoglycemia and also hyperglycemia, which was insulin resistant. And these hypoglycemic episodes in these patients, they were first described by Hirata. So this is also known as Hirata syndrome. And usually these patients require U500 insulin. But only good thing is these are short lasting. You remove the offending drug, give short time corticosteroids or some immunosuppression. And most of these patients within weeks and within months can recover from this disease. Now coming to endocrine diseases, Cushing's, both exogenous and endogenous. And exogenous is fairly common. Our patients for periarthritis, shoulder, frozen shoulder, go to orthopedician. He injects Canacort injection into capsule. Then for osteoarthritis knee, also corticosteroids. And remember, corticosteroids given injectable in long-term fashion may require months to appear in Cushing syndrome clinically, and patient will worsen his glucose immediately. Acromegaly also, I remember a case which was hospitalized in some other unit. They were using 100 unit of insulin without any control. We were asked to see the patient, and when we saw patient was clearly having acromegaly, Patient was operated and tumor was removed, and patient is now doing well with oral hypoglycemic drug. Occult infection and now antipsychotic drugs. Again, remember these second generation atypical antipsychotic drugs are known to produce very severe insulin resistance. And many a times patients may not come up with the history of taking antipsychotic drugs because of the social taboo. Occult infection and also psychology. Now we know that many of our type 1 patients, when they approach the annual examination, their insulin requirements go haywire. Now coming to pseudo insulin resistance, now this is not actually insulin resistance. This is because of poor administration techniques or injection at the hypertrophy site or mismatched insulin concentration in device. So this may be, actually this is a pseudo condition. Incorrect storage of insulin. Sometimes this insulin when sold is also not kept in not kept in refrigerator. Bad regimen. We talked that whenever we give insulin when it is not required, the insulin concentration, then patient overeats and produces more insulin resistance. Poor diet compliance. I'll remember a case with my mentor, Dr. Dash. When on round, he saw a very fat lady who was that time we only had syringes to give insulin. So we used to give 40 units twice to make it 80, and she was still not very well controlled. Dr. Dash came on the round and saw that Punjabi lady was taking 5 parathas with lot of butter on it, and then he shouted at her, if you eat like this, we will not be able to treat her. And then he said that iska sab band kar do, isko sirf lime water pe rakho. And after 6 days, unbelievably, the insulin requirement came down to 30. Now we know that after starvation, liver fat disappears after 2 days, start reducing 2 days, and 5-6 days when liver fat goes down, the insulin resistance comes down. And so this may be the reason. The malingering and secondary gain, sometimes type 1 patients, they malinger that we are not getting control and they actually not taking. And there is a very short insulin tolerance test which you can do. You can give ultra fast acting insulin 0.05 to 1.1 unit per kg body weight according to ambient glucose in OPD, and measure glucose on glucometer every half an hour for 4 hours. If there is no appropriate fall in glucose, you can say that there is real insulin resistance. Otherwise, when patient shows, you can immediately say that it is a patient of pseudo resistance. Now, how to manage? You take a good history and physical examination, rule out pseudo resistance. Lab investigations are needed. Fasting glucose, C-peptide, lipids, to rule out all the endocrinopathies, androgen levels because they are usually high. Insulin tolerance test and insulin antibodies, and genetic testing will be required in when you are dealing with insulin receptor mutations. Immunosuppressive drugs, whenever there is the immune conditions are involved, lifestyle modification, they are always needed. Now for unit to unit, it is seen that U500 insulin is more effective in treating these patients. Metformin, pioglitazone, SGLT2, because there are always some receptor which are responding. And pseudo resistance is very clear. I'll give you a bonus that whenever you come across a patient requiring very high dose, first thing you can do is reduce the dose to 50%, give the basal bolus in the analog insulins, ultra fast and the basal, good basal insulin, and you will find that majority of your patients will be controlled when you retitrate with the half the dose. Thank you very much.
Hello. Thank you, Dr. Sushil, for covering this very important topic. How many patients they require high doses of insulin, more than 2 units. There are various conditions like acromegaly or Cushing or some endocrinal or secondary diabetes or some tumors. So basic is we have to find the exact cause why they require high doses of insulin. But suppose you use very high doses of insulin, there are fear of this Somag effect and early morning hyperglycemia or dying phenomena. So in your clinical practice, how you manage and how you observe such phenomenon by using high doses of insulin?
I think first thing is to rule out that you are not unnecessarily giving high doses of insulin. When I said that bad regimen can be one important cause. And second is pseudo resistance. That is, these are two important causes. They are most common causes. That is, patient is not taking it properly, or the device and the insulin. I know patients who buy U40 vial take out insulin from that and then take the cartridge, U100 cartridge and push it, because this is available much cheaper rate. And then they say that the same insulin is being working in this also. So this is sort of this and then many patients develop hypertrophy, and that hypertrophy patch of the, because this is very convenient to inject in the same place, that gets fibrosed and the insulin does not enter the body from that patch. So these are very important first to be ruled out and then go for very rare conditions.
Can we take some couple of questions from the floor? Yeah, what is your experience, particularly in patients who are undergoing CABG kind of thing? Many times they will be requiring a huge amount of insulin. Like it's a big challenge for any clinician for that matter. What is your
When
comment on that?
patient is put on extracorporeal circulation when undergoing a CABG surgery, the amount of insulin required is usually 10 to 20 unit per hour. So very high doses of insulin are required when patients are put on extracorporeal circulation. And even when you go in a very routine surgery, as soon as an incision is put on the skin, even though patient is under GA, the demand for insulin shoots up very early.
So I think there are no questions. So big round of applause for our speaker. Thank you, Dr. Sushil, for a very excellent talk. Thank you. Over to organize.
Thank you so. Thank you so much, Dr. Sunil, sir. I request our chairpersons to kindly felicitate the speaker at this felicitation terminal. Now I request Dr. Arjun Deshmukh sir and Dr. Shilpa Devke ma'am to kindly raise the dice as a chairperson and invite the speaker.
Hello. Good afternoon, everybody. Good afternoon, rapporteurs and delegates. So now we have a very eminent speaker, Dr. Sunil Jain sir. He's a very senior endocrinologist from Indore. He also owns the Total Institute, which is conducting diabetes education programs from many years. So over to Dr. Sunil Jain sir.
Thanks, chairpersons. And I'm thankful for this.
patients where the data was promising. We understand there is some hemoglobin whereby some different kind of everything below the hemoglobin of 30-35. There will be a variation because though our magic plasma is calculation called based on the fundamental that plasma is a larger glucose versus because RBCs will have the component memories will have an impact and 90 plasma is increased. While 73%, 71% area where RBC and the rest of this formula is multiply the blood by and that's how we create that's how the glucometer is. Now think of saying that's what the first image. We are measuring the glucose as the plasma and that's how the celebration happens. Now some patient will be situated with the hemoglobin 6.5 or 7, 3, 4. You can multiply by the same number and that's how some policy is to have. Opposite also the same electrons generated by and this is COVID. There are many patients are and the glutamate reach will come high to the non-diabetic and this will be true for freestyle hypertension can cause because of getting right. You can say it very high. Also can donate electrons in the diabetes by trying to correct it. Coming to the HbA1c, we know that the catalyst can be created from glucose jungle population and then it gets of this protein. Subsequently, the tables were created can influence the binding of glucose from the anemia to how the glycation goes on, the color of the arteries. So in the individual, what is important for it always vision. And those people who have all these kind of disorders, not just him, they will see they are going to develop. Apparently, patients are looking very well controlled. In the situation they are very different. While very common in India, the years cause of high age, cause of diabetes. Another Indian is that's how the average was calculated. That's what we think. But if you look at age study, say 126, 7, we say 154, 8, we say 183, is this correct? Two simplest understanding of age. See, now see there is a range. It's fine. Suppose the patient's average glucose is 150. It means not 126, 150. That is the 7 is 123, 181. 8 is 147, considerable. Somebody with an average of 150 can have a 6, can have 7, can have 8, can have 1. That's what is a Australia, so many factors. So, we will see when is the gold standard for drug approval by FDA. So that's how Esther is the institution will never expose to that approach which is that there may be some difference which is logical.
And because of that, we have a right, which was settled by the arrow. That's what we call it here and if somebody is around person trying to do this, that that's why we should ask every patient at least one or twice to visit who's interested and administrative condition like fasting. That is a fairly good recommendation that you can trust. Earlier, the calibration system there was no issue. But now, it's actually calibration system, and there is important, and again, there are interfering substances. CGM also, country, very score because it's high vitamin C. Don't use this, but the latest benefit from by agreeing. But again, patients also very rigid also usually also one more important area which is over a period of time that this year removes of the hospital that is that is average group created by EGM group. Now, understand what we know. The HbA1c traditionally understood for glucose numbers versus the real glucose. What coming from this picture look a continuous data. That's what I talked earlier. Gradually understanding the people in whom the glycation rate can be higher. The rate levels will be higher for management indicated. That's how the middle term is GMI and HbA1c. On this side, this is developed with other that is a single HbA1c of less than 7 for everybody. For a period of time. Concept formulation, there is a need of person mind. They are based on CGM data, looking at HbA1c, certain formulas are developed where we can understand which is glycator, which is high glycator, which is normal glycator, and that's how we can HbA1c. All guidelines talk about creatinine, HEPA, PCR, and that's how diagnose PD. We are aware of, and we have gradually shifted from the gold standard medical probably considering convenience. That's how organization. Involved or recommendation is that all the 24 hours specimen widely yes, number if we want yeah, one area is morning system, and secondly, every individual there can be level of need. For example, somebody living a high creatinine with what will happen? We're going to miss the diagnosis. Because in the SCR will come down. Can measuring albumin excretion per gram of creatinine in urine. And that's how these are few limitations which we have to understand over a period of time, and maybe some change in ACR interpretation can happen in future. That's what I try to present you quickly these common tests which we use in diabetes practice and their limitations. Thank you very much.
Thank you very much, sir. It was an excellent talk, and we got to see many limitations of the common tests. The house is open for any questions. Yeah.
Sunil, very good talk. Just want to know how many of us are low glycator and how many, is it very rare thing or it's very common thing?
So the data which we have, it says one third, one third, one third. Only one third you are going to, and that's how the data right from the beginning is a broad range. Unfortunately, your talk always of the mean, not the range.
Sir, one question from me. Sir, what is your take on fructosamine acid test? Is it done quite frequently in your practice?
How long duration? Coming is the type of hospital. And they are looking the half-life of that you are going now, over a period of time, rather from averaging, we are moving towards the actual. And that's how from averaging to pricing variability. Rather than glucosamine for it to be that improvement in CPM technology and those averages are going to be better.
With that, I think we come to an end. Thank you, sir. Thank you very much.
Thank you so much, Dr. Sunil, sir. I also extend my sincere thanks to both the chairmen. Now I request the chairmen to kindly felicitate our speaker at the felicitation terminal.
Thank. I would request Dr. Sachin to start the proceedings, start his election.
Thank you, chairpersons, and good morning to all. Well, it's good afternoon. My topic is vaccination in diabetes. So I'll briefly give guideline why it is necessary to vaccinate the adult diabetes and why it is important and what are the consequences if the diabetes is not get vaccinated. So what is diabetes? Diabetes is a global emergency. The idea diabetes atlas 2021 provides the largest, latest figure, information and projection on the diabetes worldwide. What it says, 537 million people working age 20 to 64 year with diagnosed or undiagnosed diabetes in 2021. And if current trend continues, then 783.2 million adults will have diabetes by 2045. So this is the trend. We are in number 2, just lagging behind the China. So diabetes and infection, just we will go why the vaccination is necessary, of course, to prevent infection in diabetics. So increased risk of developing and dying from infectious disease. One of the important complication of diabetes is infection. Longer duration of diabetes, poor glycemic control causes a almost up to 75% increase in the relative risk of infection. Hyperglycemia and susceptibility to infection, we all know why it is. And then hyperglycemia and the susceptibility. According to American Diabetes Association, infection are an important issue for individuals with diabetes due to the immune system failure to fight off invading pathogens. Because why? Suppression of cytokine production, defects in phagocytosis, dysfunction of immune cells, failure to kill microbials. So this is a flow chart. So pathogenesis of infection in diabetes and hyperglycemia. What innate immunity it affects. Early phase of innate immune response is inflammatory. Vasoactive components of complement system, mast cells, secretion and kinin bradykinin system which induce local vasodilation and increase vascular permeability and blood flow. In diabetes, dysregulation of nitric oxide production and blunted nitric Oxide response to bradykinin leads to vasoconstriction instead of vasodilation. This could potentially attenuate the ability of phagocyte to reach their target. It also affects chemotaxis and phagocytosis and adaptive immunity, that is cell-mediated and humoral immunity. Patients with poorly controlled diabetes have impaired T cell lymphocyte function, and glycation of IgG has been shown to occur proportionate to the level of glycosylated hemoglobin. So pathophysiology of infection-associated diabetes, this all shown as decreased T lymphocyte response, decreased neutrophil function, then of course neuropathy, angiopathy, large number of medical intervention also lead to a decreased immunity. And these are the other factors. Of course, glycosuria also major factor in causing infection in diabetes. So what is immunization in diabetes? There are many guidelines, well-defined guidelines for vaccination of diabetes. American Diabetes Association, Center for Disease Control and Prevention of USA, World Health Organization, Advisory Committee on Immunization Practices, and also the UK guidelines. Type of vaccination in diabetes, there are pneumococcal vaccination, pneumococcal polysaccharide vaccine, pneumococcal conjugate vaccine, influenza vaccination, and hepatitis B vaccination. So vaccine recommendation for patient with diabetes. American Diabetic Association, all diabetes subject more than 2 years of age, they should get vaccinated. What ACIP said, all person at the age 65 years and adult 19 to 64 years with chronic medical condition like chronic heart disease, chronic lung disease, diabetes mellitus, asthma. What Australian guidelines is, above 65 years, everyone should get vaccinated. And people aged more than 10 years who have underlying chronic illness, predisposing them to including acute nephrotic syndrome, chronic cardiac and renal or pulmonary disease, and diabetes. Canadian guidelines says children more than 5 years should get vaccinated. And UK guidelines says all adults over the age of 65, children under the age of 5 who have previously had invasive pneumococcal disease should get polysaccharide vaccine. So recommended adult immunization schedule. What is the what guidelines followed in United Nations? United States 2019. The polysaccharide pneumococcal vaccine, 1 or 2 doses. Influenza, 1 dose annually. Then tetanus, diphtheria, and pertussis. First give Tdap, then boost with tetanus and diphtheria every 10 years. Not just tetanus, but tetanus and diphtheria every 10 years. Then MMR, 1 or 2 doses, 4 weekly interval, and varicella 2 doses at least 4 weeks apart. Zoster 1 dose, more than 60 years in diabetes. Hepatitis B 3 doses, and then boosted according to the immunity level. Human papilloma in females 3 doses through age 26 years. The second dose should be administered 1 to 2 months after the first dose. The third dose should be administered 6 months after the first dose, at least 24 weeks after the first dose. HPV vaccine in male, 3 doses through the age 21 years. Vaccine recommendation for patient with diabetes. Influenza vaccination should be done every year to reduce the risk of complication in people with diabetes. Pneumococcal vaccine, that is PSV 23, should be applied to all people with diabetes between 19 to 64 years of age. Over 5 years of age, a dose of PCV 13 and a year after dose of polysaccharide 23, PSV 23 should be performed. What we followed in children guideline. First we give PSV 13, then after 5 years, PSV 23. In the first vaccination, if the first vaccination is PSV 23, PSV 23 is recommended to be administered 1 more dose after the 5 years because all the variant of this pneumococcal phenotype should be covered. Diabetes vaccination in India, suggested criteria for vaccination, all adult diabetes subjects should be educated about administering pneumococcal and influenza vaccine, and those above the age of 60 years should be strongly advised to be vaccinated. Children with diabetes more than 2 years of age can be given pneumococcal polysaccharide vaccine, and children above 6 months of age, influenza vaccine. Other vaccine may be administered in diabetes subject to based on the need and indication. Patient with renal failure in any age group can be immunized. People with diabetes and immunocompromised state due to concomitant in condition can be immunized irrespective of the age. Patient with diabetes and chronic lung disease like chronic obstructive pulmonary disease, bronchial asthma may be immunized irrespective of their age. People of any age with diabetes who smoke may be immunized. The recent ADA guidelines, that is 2024, which is published in January 2024, comprehensively talk about medical evaluation, including initial and follow-up evaluation, assessment of complication, psychosocial assessment, management of comorbid condition, and engagement of patient throughout the process. So what are the recommendations? Recent recommendation by ADA? Vaccination for children and adults with diabetes according to age. Appropriate recommendation, we have already gone through that. Subsequent slide, there is a chart, we can go through that. People with diabetes are at higher risk of hepatitis B infection, complication from influenza and pneumococcal disease. CDC Advisory Committee on Immunization Practice, influenza, pneumococcal and hepatitis B vaccination, specifically for people with diabetes. Vaccination against tetanus, diphtheria, pertussis, measles, mumps, rubella, HP and shingles must be done according to need. So recommendation by ADA, highly recommended immunization for adult with diabetes, hepatitis B, less than 60 years of age and more than 60 years of age, discuss with healthcare professional. If they are not vaccinated, we have to revaccinate 2 or 3 doses series. HPV, less than 26 years of age, then 27 to 45 years of age may also be vaccinated against HPV after discussion with the healthcare professional. One should give 3 doses over the 6 months. Influenza vaccine, all people with diabetes advised not to receive live attenuated influenza vaccine. And the vaccine course should be annual. It should be given annual. Few suggest the high risk patient, it should give biannually. Then PSV 23, 19 to 64 years of age, vaccinate with Pneumovax. 1 dose is recommended for those that previously received PCV 13. If PCV 13 is used, follow with PPSV 23 more than 1 year later. PPSV 23 is not indicated after PCV 20. Adults who received only PPSV 23 may receive PCV 15 or PCV 20 more than 1 year after their last dose to cover the whole spectrum of pneumococcal bacteria. Then more than 65 years of age, 1 dose is recommended for those that previously received PCV 13. If PCV 15 was used, follow with the PPSV 23 more than 1 year later. PPSV 23 is not indicated after PCV 20. Adults with received only PPSV 23 may receive PCV 15 or PCV 20 more than 1 year after their last dose. Same criteria. PCV 20 or PCV 15, these are the pneumococcal variant which are included, 20, 15 and 13. Adults 19 to 64 years of age with immunocompromised condition, that is chronic renal failure, the patient cochlear implant, we are getting many patients with cochlear implant, and cerebrospinal fluid leak. 1 dose of PCV 15 or PCV 20 is recommended by the Center for Disease Control. 19 to 64 years of age, immunocompetent. For those who have never received any pneumococcal vaccine, the CDC recommend 1 dose of PCV 15 or PCV 20. More than 65 years of age, immunocompetent have shared decision-making discussion with the healthcare professional. If they are at risk, we should vaccinate them. 1 dose of PCV 15 or PCV 20. And then PPSV 23 may be given more than 8 weeks after the PCV 15. PPSV 23 is not indicated after PCV 20. Tetanus, diphtheria, pertussis, all adult pregnant individuals should have an extra dose booster every 10 years of tetanus and diphtheria. Zoster more than 50 years of age, 2 dose Shingrix even if previously vaccinated. So why vaccines are important? Diabetes, even if well managed, can make it harder for your immune system to fight infections. So you may be at risk for more serious complications from an illness compared to people without diabetes. Some illness like influenza can raise your blood glucose to dangerously high level. People with diabetes have higher rates of hepatitis B than the rest of population. Outbreaks of hepatitis B associated with blood glucose monitoring procedure have happened among with people with diabetes. People with diabetes at increased risk for death from pneumonia, bacteremia, and meningitis. Immunization provides the best protection against vaccine preventable disease, and they are cheap. Vaccines are one of the safest ways for you to protect your health, even if you are taking prescription medicine. Summary: along with other diabetic complications, infection due to influenza and pneumococcal should be regarded as having significant public health importance. We know pneumococcal pneumonia and other things, which once the patient get admitted, hospitalization cost is very high. So if the patient is vaccinated, we can prevent that. Record of vaccination should be kept in all clinics. Efficacy of the vaccination should be assessed in relation to occurrence of fever, pneumonia, or hospitalization. Vaccination strategies in diabetes should evolve as part of routine care, and central registry need to be maintained. It is important to educate both patients and healthcare workers about immunization of diabetes patients to prevent infectious disease causing serious morbidity, mortality, and health-related expenditure. Thank you.
Thank you. Thank you, Dr. Sachin. A topic which definitely needs some guidelines from our Indian point of view also. Something which is not very practiced very easily in our clinics about adult immunization and diabetes. Welcome any questions from the audience.
Excellent talk. Are there some medical legal aspects? Suppose we don't vaccinate the patient of diabetes and they develop like pneumonia or very catastrophic diseases. Can patient go to the court of law?
In India, I don't think, but there are no guidelines. So medical legally means one can't go to court. But maybe America there are guidelines, so that need to be followed. That there are international travel regulations also. But as far as India, no case actually. I have not come across any case.
Should we should we give COVID vaccination?
There are a lot of controversy, but the recommendation is still there that we diabetes should be vaccinated.
Diabetes should receive COVID vaccination.
Now it is more not scientific. Now it is more socio-political reason. So
yes, but
the guideline says that one should get COVID.
Yes, you should give COVID vaccination. Anyway, thank you. Any questions?
Thank you.
So thank you very much for informative lecture.
Chair.
Thank you so much.
Thank you so much for this is our
Hello. I call upon today's now the topic is diabetes and infertility, emerging concept. I call Dr. S. Chandrasekhar sir for the lecture. Dr. S. Chandrasekhar sir, he is MD, FICP, FISCM, FIMSA. He is head of the Department of Professor of Medicine, Stanley Medical College and Hospital. He is executive member, Chennai chapter API and Tamil Nadu RSSDI. He has a lot of publications, papers in the national and international journals. So over to Dr. S. Chandrasekhar sir.
Good afternoon, ladies and gentlemen. At the outset, I would like to thank Dr. Sunil Gupta and Kavita ji for having me here. This is a quite vast topic, but anyhow, I try to give you a glimpse of what is this diabetes and infertility is about in 12 minutes. So we all know that like the reproduction is the essence of all the species. In fact, like the fertility is almost synonymous with the reproduction. If somebody is not able to conceive during the reproductive age, despite the the regular unprotected intercourse. Intercourse means regular means like 2 to 3 times in a week, like after 12 months, like we call it as infertility. So we all know that. Like the problem is like we do see a lot of patients, more younger patients, they are getting diabetes, and we do see more and more the infertility cases in among these young people. Of course, it's not the domain of the male reproductive health. Of course, females are also equally affected, and we need to think beyond the erectile dysfunction. And in fact, like the WHO says that like almost the 15% of the people who get married, like they are likely to get infertility. So, as a result of these booming the infertility cases, in fact, since 1990, the infertility cases have gone up by almost to the tune of 25%. We do have a lot of the literature, the internet, the articles. Of course, we do have a lot of ARTs also, like the Assisted Reproductive Technology Center. In fact, from the National ART and Surrogacy Registry, like we do have 406 registered ART center, but in fact, we have many unregulated, dysregulated the ART centers in almost all the cities, particularly in the metros. So I come to the prevalence of these, the infertility. Most of them were contributed by the females, almost to the tune of 40%, and many of them were due to the endocrine causes, in particular the diabetes and thyroid diseases and pituitary and hypothalamic diseases, and tubal and uterine factors, they contribute significantly, the local causes. Of course, the male factor contribute for 17 to 28% of the cases. Combined together, again, 40% of the cases were accountable for the infertility among the married couple. But the thing is, the WHO says that like almost every 1/6 of the married couple, they may have some kind of uncertainty with regard to the cause. And this is the Indian literature says that like 8 to 28% of them, they may not have a proper explanation for the fertility. So I'll start with the male infertility. Of course, like there are certain things which are hormone unrelated, like erectile dysfunction, the spermatogenesis and retrograde ejaculation. All these things are hormone unrelated, and we have the hypogonadism, which is hormone regulated. We know that like diabetes is a disease with which has got multiple pathophysiological factors and multiple end factors also. So as diabetes, particularly when it is associated with overweight and obesity, we do have some of the endocrine problems in the form of reduced testosterone, LH, FSH. As a result, like we do get reduced sperm motility and morphology. On the other hand, like we do have AGE, which is more expressed as an outproduct of the hyperglycemia, like which could also can result in increased reactive oxygen species, which can damage the Leydig cell, which produces testosterone, and it can cause, in fact, the atrophy or empty seminiferous tubules, which can lead on to male infertility. On the other hand, again, oxidative stress as a result of uncontrolled hyperglycemia again can cause various morphological and the genetic changes also in the sperm. So as a complication of diabetes, both micro and macrovascular complication both can contribute to the development of infertility in males in the form of the endoplasmic reticulum stress, and it can result in mitochondrial dysfunction. And as a micro as well as the macrovascular complication, it can result in the infertility. This is a newer one. Like we do have the one of the we know that like ominous octet, and one of the recently emerging the hormone is the osteocalcin. So osteocalcin is a newer one which not only causes some the dedifferentiation and proliferation of the insulin in the beta cell, but it does have some action on the gonads also in the form of increasing the testosterone production and fertility also, which is less expressed in patients with diabetes. So this is a very the old thing, like we all learned during our physiology, like how the hypothalamus, pituitary, how it, particularly the anterior and posterior pituitary. In the anterior pituitary, we get release of the FSH and LH. How does it act on the Leydig cell and Sertoli cells, resulting in the production of the testosterone and the negative feedback? We all know that. This gets disrupted in patients because of various factors, including the insulin resistant in the brain, which sends some sense signaling to the hypothalamus and pituitary, which obviously resulted in decreased kisspeptin signaling. So kisspeptin, we know that like it's a maturity, puberty hormone, like we all know that, eventually resulting again in decrease in the pulsatile secretion of the GnRH, and again the FSH and LSH goes down, resulting in the male contributes to the male infertility. This is again a newer concept, like where the test is, we know that like the glucose is the obligate metabolic fuel for all our patients, all our tissues. So when there is uncontrolled hyperglycemia, when the glucose enters through the GLUT1 and GLUT4, it can result in the formation of glucose 6-phosphatase pyruvate, and eventually it goes into the lactate pathway, which creates a unfamiliar environment, which can affect the production of Sertoli cells to produce testosterone as well. So as a result, like you get abnormal morphology and abnormal the shape, and the mitochondrial dysfunction happens, and the sperm nuclear damage happens, and sperm count goes down, and motility also goes down. How do we know that like somebody is having a low testosterone? So the fatigability, the asthenia is the most important thing, which we all of us know. Of course, it can result in erectile dysfunction and reduced early morning erections, and reduced libido. That is more important. And this is another thing, like the decrease in the motivation and energy, which call it as red dust syndrome, relative energy deficient state. It occurs both in male and female nowadays. So this is also one of the things which can happen in patients with low testosterone levels. What is the guideline says? The reason ADA guideline says that we should screen for men with symptomatic hypogonadism for we need to do the hormonal profile, and of course we do have some of the questionnaires to find out whether they have the hypogonadism or not. And this is the WHO specifications for the normal. This is one of the most often ordered. The investigation is the semen analysis. The semen volume should be of more than 1.4, and count should be of minimum 16 millions, with total sperm per ejaculate should be more than 39 millions, with the motility of 42, and normal morphology up to 54, and a viability of 4%. This is a very important thing. Of course, unfortunately, it differs from lab to lab also, but this is the WHO specification for the normal semen, the parameters, which we all of us should know before evaluation. So we need to do the stepwise approach. And of course, before we go on to the stepwise approach, please rule out certain factors. Say, for example, the pre-testicular thing, like the obesity, thyroid dysfunction, the erectile dysfunction, all these things can cause, and the testicular factors like alcohol and smoking. The alcohol can cause decrease in particularly the binge drinking can cause decrease in the sperm count and viability, and the smoking can cause damage to the sperm DNA, and fragmentation index can go up. The radiation also nowadays, like we do have a lot of issues with regard to the radiation. Many of us are exposed to the radiation. Say, for example, we are all exposed to the mobile phone radiation, computer, television, and so on. So this radiation, this non-ionizing radiation also can have an impact on the faster developing, the faster proliferating cells like oocytes and sperms. Of course, the infections like TB and gonorrhea also has to be taken care. So there are certain drugs, like the commonly used drugs like doxycycline. We have been using doxycycline right and left during the COVID time. Please remember that this doxycycline also can cause this decrease in the sperm count and the viability, even up to 54 dose after a single dose of doxycycline. Of course, many of the drugs which we all of us know, beta blocker, thiazides, spironolactone, all these things can have the impact on the sperm viability and other things. So we need to do the clinical and laboratory evaluation. Of course, we need to do some of the hormonal profile, including FSH, free T4, prolactin, LH, and free total testosterone, SHBG, semen analysis in a male. So coming to the principles of diagnosis, like we need to correct the blood sugar and we need to correct the underlying pathology. And we do have a guideline that is called the IDEA guidelines, that is the Integrated Diabetes and Endocrine Academy guidelines, which advocates the usage of the testosterone, particularly in patients who are having the erectile dysfunction, early morning erections, or with low loss of libido, all this with asthenia, reduced muscle mass, where it advocates the usage of these testosterone. Coming to in women, like we always think about the PCOS, but apart from the PCOS, like it can cause several alteration. It can cause alteration in the length of the menstrual cycle, and it can result in the disturbance in the pulsatile secretion of the GnRH, and it can cause anorexia. Nowadays, we do have more cases of not anorexia, but orthorexia nervosa. That's what we do see among the young people, and the age of onset of menopause prematurely it comes from less than 40 years. So low libido, and they do have some autoimmune problems also. So these are all some of the things which we see in females. Of course, they also require detailed evaluation and control of the blood sugar along with the hormonal panel. So the treatment part of it is like the lifestyle measures. Of course, the weight loss is the important parameter, and obesity and overweight are the mother of all non-communicable diseases, including the fertility. So we need to have a thorough history, and particularly in eliciting the history in females is quite challenging for any clinician for that matter. I'll finish you in 1 minute. And clinical examination and appropriate screening and proper investigation with the hormonal profiles are the mandatory things. Of course, it gives us a lot of problem, not only to the couples, but also for the society. Ladies and gentlemen, the fertility rate of in India in 2024 is almost 2.139. It is expected to go down by 2025 by 1.9. It comes less than 2. And in 2050, it is going to be 1.3. Please remember, the fertility rate globally it comes down, particularly in India also it comes down. It's a problem of the society, and we need to have a holistic approach to these patients, and we need to have an interdisciplinary approach. We need to seek the help of physicians, psychologists, psychiatrists, nutrition, physical trainer, urologist, and so on. Of course, the hope is the only thing that is stronger than fear. That's what Robert Ludlum says. And I bring warm greetings from World Hypertension Congress. We are going to have it in the month of February 2021-23 at Chennai. I invite all the faculties and postgraduates to take part and utilize this opportunity. Thank you for the opportunity. Thank you.
Thank you, sir, for the excellent talk. And are there any questions? Yeah.
Sir, your take on effect of metformin on spermatogenesis or sperm quality, because a lot of, as the age of by which people are getting married is increasing, a lot of type 2 diabetics are also, they come for premarital, pre-pregnancy counseling, and many of them are metformin. I'm talking of the male partner.
Yeah, so the thing is like the metformin has got multiple benefits, like whether it is where the patient is having a pre-diabetes, in females PCOS, or in males, like it does have a very good role, particularly in patients who are having a abnormal glucose intolerance. Like so, we do have guidelines with regard to the usage of these metformin. Very few drugs, like they have got very good effect on in promoting the reproductive health also. Like so metformin is one drug like where we can use. Particularly, it does have like improves the mitochondrial function part of it. So that's what they say. Like somebody is having increased fragmentation index of sperms, like wherein like they can be given even when they are having a normoglycemia, they can be given metformin.
Thank you.
Thank you.
Any other questions? One question from my side, that nowadays I am having my infertility center also in Jabalpur. So male factors are coming up, the causes of infertility. Azoospermia is very common nowadays, which is one of the cause of infertility. Why it is increasing in male?
Yeah, so I'm not skeptical about that, like, but I need to accept the fact that like the patients do come with azoospermia, oligospermia, oligoasthenospermia is definitely on the rise. So one thing which I attribute is, maybe some of you may differ with me, like so after the COVID, like we do see such scenario. But please remember that, like we all know that, like the receptor, so the angiotensin converting enzyme receptor, we all know that, like it was expressed in lung and people had ARDS and it was manifested in the form of lung problems. But remember that, like the ACE receptors are maximally concentrated in the testes. It was silently affecting the ACE receptors. We do not know how many of the people, our people had asymptomatic involvement of the testicles also. So that is one of the things. Of course, the lifestyles and the pollution, the exposure to the non-ionizing radiations. So these are all some of the things, like definitely will have a impact on the fertility in as such for both and male and female.
Yeah, so message is clear that we should investigate both, not only blame the female partner, but
Yeah,
we should
definitely.
investigate both the partners and then come to the conclusion. Thank
Yes.
you. Thanks a lot.
Thank you.
Thank you.
Nihal Thomas is just on his way. He'll be joining in some time.
Thank you very much for giving this opportunity to me. Today we have got an eminent academician, Dr. Ajay Kaduskar. He is MD Medicine with PGDHC Diabetology, Fellow Euro-Asian Academy of Clinical Diabetology, Diabetologist and Metabolic Disease Consultant, done MBBS from GSC, MD from Sion, Mumbai. He is a director of Nirame Diabetic and Heart Care Center, and he was a past president of Diabetes Association of India, Nagpur, Chairman Association of Physicians of India, Vidarbha Chapter, Joint Organizing Secretary, MAPCON 23 at Nagpur, President V.S. Kaduskar Memorial Foundation and Trust Involvement in Diabetes Care, and vast experience in treating type 2 diabetes and a great academician. Or to Dr. Ajay Kaduskar, sir.
Thank you, sir. Thank you for your kind words. It's always an honor to have you as the chairperson. Good evening. I won't say good evening, it's good afternoon, everyone. And I'm aware that I'm the Butler speaker. I'm standing between you and the lunch. And for the flight of Hello Diabetes to land on time, I'll try to be as brief as possible. Thank you, Gupta sir, for giving this opportunity. I'm going to talk on Fantastic Four in HFrEF in diabetes, and time to translate whatever clinical evidence we have into our clinical practice. One era of clinical medicine that has undergone a sea change in the past decade is management of heart failure with reduced ejection fraction. Just as we are having a lot of evidence about the choice of anti-diabetic molecules and the hierarchy of their choice, the another area that has undergone a sea change in the past decade is heart failure with reduced ejection fraction. When we say heart failure with reduced ejection fraction, we mean an ejection fraction of 40% or less. When we say heart failure with preserved ejection fraction, we mean an ejection fraction of 50% or more. And then we have a mid-range ejection fraction, that is EF between say 40 to 50%. And also we have a heart failure with improved ejection fraction, that is those who had an EF initially less than 40 and with treatment it has increased to above 40. What is the relation between diabetes and HFrEF? Well, it's bidirectional. Those with heart failure, they have an increased activation of RAS, which is a maladaptive response. And this maladaptive response contributes to insulin resistance, which predisposes these patients to diabetes. And you have if you have a pre-existing diabetes, because of this increased insulin resistance, your dysglycemia tends to worsen. And on the other hand, diabetes is a known risk factor for heart failure progression, and all-cause death and rate of hospital admissions is increased because of the pre-existing diabetes. So one begets the other. It's a bidirectional relationship that we are dealing with. And talking of figures, well, we don't have any dedicated heart failure registry in our country, but then the incidence is increasing over the years, as we can see in our clinical practice. We have a lot of patients who are surviving heart failures with better accessibility to healthcare facilities and better molecules for treatment of diabetes. And the incidence of diabetes, the less said, the better. We are all aware. So all in all, this bidirectional relationship is going to increase over the years, and you are going to have more patients with diabetes, and similarly, you are going to have more patients who are surviving heart failure. How does diabetes cause heart failure? More focus is on the ASCVD, which predisposes to ischemic cardiomyopathy, but then you have hypertension, which causes hypertensive cardiomyopathy. And it's not just the ASCVD which leads to heart failure. It is the metabolic disturbances, the disturbances at the cellular function, the structural alterations, the autonomic neuropathy, the RAS activation, all of which contribute to the progression of diabetic cardiomyopathy, thereby leading to heart failure. So this is the way, it's a multi-pronged approach by which diabetes leads to increased incidence and increased progression of heart failure. Why is this necessary for a clinician like you and me to know? Because it helps us to make a better choice of therapies. Because the coexistence has a strong impact on clinical management and progression. Those with diabetes, they have worse clinical status and increased all-cause and CV mortality in HFrEF patients. And those with HFrEF, they have impaired glucose management and increased dysglycemia. So each leads to further deterioration of the other. Moreover, it leads to adverse clinical outcomes. On the left hand of the panel, you have the heart failure trials. In the heart failure trials, the persons who were diabetes had a worse prognosis. And on the right side, you have the CVOTs with various molecules which were there in the past decade. In the CVOT trials, those patients who had pre-existing heart failure, they had a worse prognosis as compared to those without pre-existing heart failure. Degree of risk is related directly to the level of dysglycemia. Dysglycemia per se is harmful in heart failure. Not just those with diabetes, those with pre-diabetes or diabetes, they are at a high risk for developing heart failure in the future. And in patients without CV disease, worsening dysglycemia is associated with increased LV mass, worsening diastolic dysfunction, and subclinical reduction in heart failure. So it's not just those with diabetes, those even with pre-diabetes, they have a worse outcome when it comes to the outcomes of heart failure. Dysglycemia is associated with 30 to 50% increased risk of CV death. It is associated with a worse quality of life and is associated with increased hospitalizations for heart failure. So what do we need? We need anti-diabetic therapies which will prevent and improve heart failure outcomes. On the other hand, we need a heart failure therapy which can prevent worsening of dysglycemia or incident diabetes. This brings us to the Fantastic Four, a trivia about Fantastic Four. This is a Marvel series movie, those who are all aware of. Marvel series, all youngsters are very fond of. That is the Fantastic Four in the Marvel comic series. And similarly, we have the Fantastic Four when it comes to management of heart failure. They are namely ARNI, SGLT2 inhibitors, beta blockers, and mineralocorticoid receptor antagonists. ARNI has been there for a decade now, but it has gone off patent, and so it is more accessible to our patients. The beneficial effects are two-pronged. The AT1 receptor blockade leads to the correction of the maladaptive RAS response, which leads to increased insulin sensitivity, and the sacubitril part, that is the neprilysin inhibition, leads to increased natriuretic peptide, increased bradykinin, increased GLP-1, increased skeletal muscle cyclic GMP, and decreased DPP-4 activity, which all contribute to a beneficial effect when it comes to the control of glycemia. So the two components of ARNI, the sacubitril part and the valsartan part, all have a favorable effect, not just for heart failure, but also for control of glycemia as well. This was proven in the Paradigm HF sub-analysis, which led to its approval for its incorporation in the heart failure guidelines. In the sub-analysis 1, compared with the effect of ARNI with enalapril, those on ARNI had better glycemic status, and they had a lesser need for glycemic for up titration of glycemic benefits. ARNI provided a 20% reduction in the risk of CV death, and a decrease in HbA1c was persistently and significantly greater in patients receiving ARNI as those compared to receiving enalapril. Talking of SGLT2 inhibitors, we are all aware of the results of the Dapagliflozin and the Emperor-reduced trial. In fact, the Dapagliflozin led to the birth of a branch called as diabetic cardiology, and it showed a beneficial effect when it comes to not just the reduction of hospitalization for heart failure, but a reduction of mortality as well in patients with diabetes or without diabetes who were treated with Dapagliflozin and heart failure. Similar results were seen with Empagliflozin in the Emperor-reduced trial. In fact, the patients in the Emperor-reduced trial were much more sicker as compared to those who in the Dapa-HF trial. The third component of the Fantastic Four, the beta blockers. In fact, the evidence with beta blockers and MRAs was seen much earlier as compared to the evidence that came out with SGLT2 inhibitors and the ARNI. The Merit-HF study and the other studies showed that selectivity of the beta-1 blockade provided a favorable outcome when it came to seeing a beneficial effect as regards mortality in patients with established heart failure. So carvedilol, bisoprolol and metoprolol are the beta blockers which have shown evidence as regards mortality benefit when it comes to heart failure. And talking of the MRAs, eplerenone and aldactone or spironolactone, they have shown benefit when it comes to mortality benefit in patients with heart failure. So we all know that these four molecules are beneficial when it comes to treatment of heart failure, but how should we be sequencing these treatments for heart failure and reduce heart failure is what we know. The earlier approach, just like in treatment of diabetes, the sequential addition of anti-diabetic molecules it doesn't hold true in today's era. Similarly, for heart failure, sequential sequencing doesn't hold. You need to start them at a lower dose, start them early and up titrate. The present dictum is that start early, even in patients who have been hospitalized for heart failure, start at low dose within 2 weeks, all the four molecules, and then up titrate to a maximum dose within 12 weeks. Why? Because although the evidence was there since 20 years, but it's not that the molecules which showed earlier evidence were the best. We need to give the benefit of all four molecules to our patients. This is the McMurray's patient which compares the conventional sequencing with the proposed new sequencing, which says that SGLT2 and inhibitor and beta blocker are much safer when used earlier, followed by ARNI and MRA. But again, the choice is individualized for each and every patient. The evidence of rapid sequencing is in the form of the strong HF studies showed that a rapid sequencing of the four components led to better outcomes, better tolerability and better effects as compared to the conventional sequencing. The HFrEF stage C is those who are symptomatic. Start all these molecules. These are the ACC 2024 guidelines. Start them at a low dose, start them early and up titrate to a maximum tolerated dose in period of 2 weeks or 12 weeks. And if needed, add a diuretic agent, add hydralazine, add evaporatin or add variciguat, which has also shown a benefit. This is the way we should be going about. This is the last slide. I have tried to stick to my time. Coalitions are needed everywhere, not just in politics, but in medicine as well. So be it management of diabetes, be it management of heart failure, you need to use multiple drugs. You need to use drugs which have shown benefit, and you need to use them early. Thank you very much.
Thank you, Ajay, for your nice talk and quite elaborative on fantastic four drugs. I think previously AC inhibitors were used, but now I think it has been replaced by ARNI. Is it?
Sir, the paradigm HF trial showed that ARNIs have a mortality benefit over enalapril, which was the molecule tested in the study. So, but the problem with ARNI in our setups was the cost. With it going off patent, we should give the best benefit. So ARNIs are preferred. Secondly, one more point which I would like to make: if patient is on ACE inhibitors and you are planning to initiate him on ARNIs, you need to give a 36-hour washout period, because the level of bradykinin can go up and it can cause angioedema. If the patient is on ARBs and you are planning to shift him on ARNI, you need not give a washout period.
Mission of chair, I would like to ask one question. Fantastic four are definitely, they are very useful for saving the life of, and we are getting less number of patients for the repeated hospitalization. But another molecule like Verisogot,
Yes.
fifth, is also knocking the
Yes.
door.
It
So
is
I would
also in
like
the
to-
guidelines now, sir.
Yes,
Very good.
Victoria
And it is
Tara-
available now.
Are you using that?
I haven't used it, but it is available in our country.
And doses are also very small,
Very
2.5
small dose,
milligrams,
yes,
and
yes.
side effects are also
Yes,
less.
side effects are less, because when you are using, these are decompensated patients. Most of the times they have compromised renal functions, they have hypotension. So you have to be very cautious, and especially in our setups, our patients are not very regular with follow-ups. You need to monitor the patient's QFT quite frequently in our setups. And so using beta blocker and SGLT2 inhibitor ahead of ARNI is a safe approach, I would say.
There are other two molecules like Mavacomtiv and Omecomtiv.
Yes,
So
yes.
what is their status also?
Sir, they are in the pipeline. And just like anti-diabetic space is changing fast, this heart failure space is also changing fast.
Is there any question from the audience? Thank you. Thank you, Varun.
Good afternoon, everyone. I would like to welcome Dr. Sanket Pendse, sir. He is MRCP Medicine, DNB General Medicine, postgraduate diploma in diabetology. He is consultant diabetologist and internal medicine specialist. He has organized many events and organized type 1 diabetic education program on the occasion of World Diabetes Day in 2017. Participated as investigator in the landmark trial. He has completed enhanced patient care program for specialist doctors and completed online course of an advanced course in ECG interpretation. He has completed certificate course in management of thyroid disorders also. Without wasting our time, I would like Dr. Pendse sir to proceed.
Thank you. Thank you, chairpersons, for the kind introduction, and thank you, Dr. Sunil Gupta, sir, for this opportunity. So I think my talk is the last talk in the session of all flights, and it is similar to when the flight has landed and we all are standing in the queue with our luggage for the door to open and then at the baggage counter to collect our baggage. So I'll be very quick so that we can all have sumptuous food. My talk is about glycemic pentad. So I'll be talking about a newer dimension in the field of glycemic monitoring as such. So to begin with, uh, as we all know, in the last decade or so, the therapeutic approach to diabetes has changed. It has become more comprehensive. So earlier it was more of glucocentric, and as we can see here, in the last 3 or 4 years, 2018 onwards, the approach has become more organ specific or complication centric, that is more cardio-renal event centric. So all the therapeutic changes are based on development of complications or prevention of complications of diabetes rather than glucocentricity. But still, I would like to say that glucocentric approach is still relevant for those patients who are severely symptomatic, who have severe hyperglycemia, who are elderly, who are more prone to develop complications of diabetes or infections. So we need, in a practical world, a combined approach where we address the cardiocentric approach as well as the glucocentric approach. Now, to have this approach, we need to monitor our patients appropriately, and classically, for most of the time, the glycemic monitoring has been the glycemic triad. That means fasting blood glucose monitoring, postprandial, and HbA1c. These have been the strong three pillars of glycemic monitoring, which constitute the glycemic triad in for the past several years. But what has been realized that despite having a good HbA1c value of around 7%, still there was lot of glycemic variability in our patients. Almost up to 40% of patients, despite having a HbA1c of 7%, will have lot of glycemic variations. So in clinical practice, we can recognize this by listening to our patient carefully, where the patient says, when we tell the patient that your reports have very good, your fasting is under control, HbA1c is 7, but the patient is not happy. He says that, sir, I'm having hypoglycemic events almost every alternate day, and sometimes when I check, the blood sugar goes up to about 250. So that is a clinical clue that the patient has got glycemic variability, and we need to ask them to monitor more frequently so as to detect the highs and lows in this particular patient. So it's very important to listen to our patient. So to encompass all the factors and to make it more comprehensive, the triad has now been shifted to glycemic pentad. So whenever along with glycemic triad, if we add glycemic variability and quality of life, that may constitute the glycemic pentad. So now onwards, we need not only look at the fasting, postprandial HbA1c, but we also need to incorporate glycemic variability as well as quality of life to give a more complete care to our patients with diabetes. So on one hand, the glycemic triad looks at the efficacy of our treatment, and then the safety is taken care by the glycemic variability and quality of life. Now, if you look at each component of this pentad, for example, starting from fasting blood glucose and its contribution to HbA1c. So it is well recognized that if the HbA1c values are very high, it is primarily because of the high fasting plasma glucose. So any patient who has, say, HbA1c of about 10%, usually it will be more of basal hyperglycemia, or his fastings are more likely to be very high. And this patient, we need to give them an approach of fix the fasting first. That means we need to add medications, advise dietary rule, which will reduce the fasting blood glucose. For example, basal insulin is a good modality to reduce the fasting blood glucose. And if we bring down the fasting to a safe range around 100 or so, then it will also have an impact on the postprandial blood hyperglycemia. So that is the first part of the glycemic pentad. In the Indian setting specifically, where many individuals, they eat 2 or 3 meals per day and also continue to eat a lot of snacks. They keep snacking throughout the day. A lot of Indian population will spend time in the postprandial state. And in patients with diabetes, the patients typically tell us that at the end of 2 hours, my blood sugar is high, it is around 250 or more, but by 3 or 4 hours, it comes down to normal range. So by this, what I wish to tell that 3 or 4 hours, the patients will be in hyperglycemic state after every meal. So a large part of the day, maybe almost 60 or 70% of the day of entire 24 hours will be spent in hyperglycemia. So it is another very important contributing factor of the glycemic pentad to the glycemic variability. And hence, especially in Indian setting, because of high carb intake, we need to address this postprandial hyperglycemia also. So it has been now very well recognized that postprandial hyperglycemia is an independent cardiovascular risk factor. So if you look at this slide, pretty old data around 20 years back, when the postprandial blood glucose is rising in the normal range, so up to 140, starting from 87, the coronary artery lumen goes on reducing. So even when the blood glucose, postprandial blood glucose increases within the higher limit of the normal range, the coronary artery lumen decreases. So that means postprandial hyperglycemia is a independent CV risk factor. It leads to oxidative stress, endothelial dysfunction. All this contributes to more cardiovascular disease, and hence this again aspect is extremely important in addressing the glycemic pentad in patients with type 2 diabetes. Now, coming to the important aspect, fasting, postprandial, and HbA1c, we all are very well accustomed to. But the most important part of the pentad is glycemic variability. So, what is glycemic variability? It is basically the acute day-to-day fluctuations in blood glucose that occur. So, both peaks as well as the lower blood glucose values constitute the glycemic variability. And on the other hand, there will be patients who have got chronic hyperglycemia. So at any point of time, if we check their blood glucose, the blood glucose will always be high. So that is chronic hyperglycemia. We all know it is very well correlated with development of micro and macrovascular complications. But it is also now recognized that these wide fluctuations in blood glucose, that is glycemic variability, also increases the risk of complications of diabetes. So we need not only focus on chronic hyperglycemia, but also on the wide fluctuations on a daily basis. So the method by which we measure glycemic variability is by using a continuous glucose monitoring system or CGMS. We have several devices like Abbott or Medtronic, or previously the speakers told about Dexcom sensors. All this can be used to measure CGMS or glycemic variability. And this is how the graph looks. We can see that this particular patient over 24 hours is having severe hypoglycemia at night time, and then followed by severe hyperglycemia. Also a lot of variability in the evening time. So all the blue zone, since it is so wide, it indicates that there is lot of variability between different days over the 14 days duration of this CGMS. And the second part of this report comes as every individual day, we can see here what is happening. So based on these two kind of graphs, we can tailor-made make the changes in therapy of a patient with type 2 diabetes who is uncontrolled. Now, some patients, it may not be possible to do CGMS in every patient. So in such patients, we have to resort to 7-point SMBG or self-monitoring of blood glucose. We can ask the patient to jot down on a piece of paper, or we can also use this My Sugar app. And if the patient feeds all these reports, then this app also generates a similar kind of report or a graph, which will tell us at what time the sugars are going up, at what time it is going down. So this is, if the sensor is not possible, then we can use all these methods. And in a survey, it was shown that glycemic variability, all the physicians looked at importance of glycemic variability. They said that it is extremely important to do glycemic variability, and no none of the physicians voted for glycemic variability is not important. So it is now well recognized across the physician community that we need to address this aspect of glycemic pentad as well. Now this is how we come across in clinical practice. We'll have a patient one with HbA1c of 7%, another patient with 7%, but both the HbA1cs are not same. For example, this patient with around 7.1%, all the yellow zone, it indicates the patient is having hyperglycemia in the 14 days duration of test. If you look at another patient with 7% HbA1c, most of the sugars are in the green zone, which is the normal range of blood glucose. So patient 1 had severe multiple episodes of hyperglycemia despite HbA1c of 7%. The other patient was more consistently having good control of diabetes along with HbA1c of 7%. So this is the same thing. Now, glycemic variation can be of two types, intraday versus interday. So on a daily basis, the sugars can fluctuate from morning to evening, or the sugars can also fluctuate in between days. For example, first half of the week can be patient may have hyperglycemia. In the second half of the week, there can be more controlled blood sugars or vice versa. So that is called as interday variation, or morning and evening patients can have different blood glucose levels, which is called as intraday variation. The ADA guidelines also say that one should do, along with HbA1c, CGMS at least once or twice a year in every patient with type 2 or type 1 diabetes. And why is it important? Because if there is decrease in time in range, that is the amount of time that the patient spends in the normal range, if there is decrease by 10%, then the risk of complications increases dramatically. I'll just take 2 or 3 minutes. And hence the recommendations include time in range as a part of glycemic pentad. And this is the kind of graph that the report is generated. And this is a very useful tool to show to the patient, where the green zone is the time in range, which should be around 70% for most of the patients. The above thing is the time above range, which should be less than 25%. And time below range, that is hypoglycemia, should be less than 5%. So again, these are two different patients. One having a very big green zone, that is 93% of the time is in the time in range zone. On the other side, we can see the green zone, that is the target range is small. Patient is in 48% of the time he is in time in range. So this is what will have a huge impact on the patient and will motivate the patient to make certain changes. I'll skip this one. So ideally, as per the guidelines, every patient should be doing CGMS, but that is not practically possible. So these are some of the indications. For example, when we are changing the regimen from premix to 4 times insulin, that is a good time to do. For a planned major surgery for pre-op blood glucose control, we can do it. If the patient is having unexplained symptoms of hypoglycemia versus syncope versus seizure, then again this might be useful. And it can be a good educational tool regarding diet education for a patient with type 2 diabetes. Now, based on CGM or glycemic variability, we can make specific decisions. For example, if the patient is on multiple oral drugs and if the CGM shows that there is a single spike, say after lunch, then we can just add one single dose of rapid acting insulin analog. Or if there is nighttime hyperglycemia, then we can add basal insulin. But when we cannot do CGMS, then to reduce glycemic variability, we should prefer drugs which are non-hypoglycemic. For example, DPP-4 inhibitors, GLP-1 analogs, or SGLT2 inhibitors, pioglitazone, metformin. All these are non-hypoglycemic drugs. They will not exacerbate the glycemic variability. And a lot of Indian patients have postprandial spikes, so alpha glucosidase inhibitors are good drugs. And blindly, if we want to start insulin, then probably the latest generation basal insulins can also be a good option. Now, lastly, last 2 slides regarding quality of life. This is the most neglected aspect, especially in the Indian setting. But we should know that quality of life will have an impact on poor glycemic control. And quality of life can be impaired because of complications of diabetes. Patients can have distress due to diabetes. There can be severe neuropathy, which can again lead to impairment of quality of life, and again cognitive decline. All these things can impair the quality of life of individuals. So it sets in a vicious circle. So poor quality of life leads to poor self-care. Is not compliant with diet and exercise. This leads to worsening glycemic control, more complications, and again poorer quality of life. So we need to address this extremely important aspect in our day-to-day clinical practice. Now moving to from pentad to hexad. If we add nocturnal hypoglycemia, then it becomes hexad. So it is again another important aspect to be looked into. And this is the last slide, which is called as the therapeutic hexad. All this while I was talking only about this part, that is glycemic pentad, but we need to also address the lipids, the anthropometry, that is the body weight of the patient, the blood pressure, and metabolic health. All these things constitute the therapeutic hexad of management of type 2 diabetes. So, to sum up, I would like to say that instead of sticking to only triad, we should address the glycemic variability and, very importantly, quality of life of patients with diabetes. And this pentad encompasses all the aspects, gives a comprehensive management to our patients with diabetes. And we should, whenever possible, use CGMS and for our patients with all types of patients with diabetes, and definitely rational use of OADs with limited use of sulfonylureas, which can cause hypoglycemia, or newer insulins will help to reduce the glycemic variability. Thank you.
Hello. Thank you, Dr. Sanket. An excellent way you have covered this topic on glycemic pentad. The total topic of diabetes is a topic of numbers. And if the numbers are favorable, the outcome and quality of life is also good. In pursuit to comprehensive care, we have moved from glycemic triad to glycemic pentad and hexad. And every part has been nicely covered. If there is any question from the audience, we can go for that.
Uh, I would like to ask one question, sir, from myself. Uh, in practical life, what would you prefer? Means following pentad or hexad? Because nocturnal hypoglycemia also
Needs to be
is
addressed.
important aspect, I guess.
Yes, so hexad definitely should be looked into. In the hexad, they have not included quality of life, so it should be after hexad, whatever it is, to add quality of life, and that becomes the exact thing that we should address. 7 things. I don't know what it is called. Septad or something.
Certainly, he has hit a 6 on the last ball. Considering this as a last session, because hexad is also called as glycemic sixer, I guess. So, thank you for now. Thank you, everyone.
Thank you very much for the
Thank you, everybody. I think this was the last session we had, and thank you for flying with us. And thank you for your patience and patience.
5 minutes thing. So we have the last part of the academic session. Of course, the हमारा उधर other hall we have still JDCon going on. JDCon is juvenile diabetes conclave, so that's for type 1 diabetes and their parents. So that hall is jam packed. But we have a pleasant task, which is a very though it is name seems to be formal name of valedictory function, but I feel it's sir please come. So I request कैसे खड़े खड़े ही करना है स्वीटी जी कहाँ गई आप हाँ जी मेरा ख्याल है हमारे पास इस बीच में सबसे सीनियर डॉक्टर DS वासनिक सर और डॉक्टर सुशील जिंदल सर हैं तो सर प्लीज कम सर हमारे बच्चे लोगों को सबको या हाँ सब लोग वहाँ पर है तो वी हैव टू वाइंड अप फास्ट सर आइए सर कुछ नहीं करना है कुछ भाषण नहीं देना है चिंता नहीं है so I request Dr. DS Vasni sir, Khobragade sir, Madhukar Khirade sir to please join us and yeah क्या है तुम्हारा प्लान में क्या किसी को मोमेंटोस देने हैं अरे valedictory फंक्शन का सचिन का है सचिन has called me here Sachin what was your agenda okay so let us ask from the senior people who are attending meeting from someone and few feedbacks I feel I'll start with Khobragade sir because he's there.
First of all, it was really a 10th annual conference, and I have attended so many conferences, even international conferences, 4 ESC conferences, every year RSSDI. But this conference, it looks like a very academic activities, and today also there were 14 lectures on Sunday, and total 118 lectures totally you have, and 1100 delegates. It is not a joke actually. It requires work of 365 days, and now we could learn so many things in Nagpur, and all the people from the Vidarbha, Akola, Amravati, and from Mumbai, Delhi, international. This is international conference, and MP, all the states. So definitely, Dr. Sunil Gupta, Kavita Gupta, Shlok, all the family members, they are taking a lot of this for education is very important, and knowledge from every field is welcome. And at home we are getting this update, and a lot of activities, lot of friends, lot of so Dr. Sunil Gupta definitely is the next candidate for Padma Shri, and yes.
You have defined that gift very nicely. Can you just talk about that gift? Madam, wo gift lo na. Table pe rakho. Yeah. I think he defined it so nicely that I wanted him to speak now.
Yeah. This gift, Buddha said, there is no soul, no Atma, but rebirth is he has accepted. So how this is possible? You will ask me, when there is no soul, how there can be rebirth? The Buddha said, rebirth of the things. There are 4 things like earth, we call Prithvi, Aap, Tej, Vayu, solid and liquid. So there are seeds inside, and these seeds actually they will regenerate. So these are actually ATP, adenosine triphosphate, and that energy will be liberated, and it will again give a big plant like some mango trees or so. This is a Buddha's philosophy, and actually you implemented it. So nothing is dead, everything is inside, and rebirth definitely. So this is a concept from the Buddha, and this is prepared from that cow dung, and there are seeds also. When I will give, and yes, it will regenerate, and it is a new life will start.
And it has tulsi ka seed है इसमें. So I request every one of us to carry those things with you. Pot में डालना है हो जाएगा. Yeah, sir.
In one, I will say this is a par excellence 11 kilo. Sunil has got a best, I think, capacity. No, he's the best organizer since I am seeing him, looking him when we organize a Diabetic Association of India, Nagpur branch, since more than 35 years. He has a great capacity to gather the so many together of the persons. He is in a very straight talking fellow and a great organizing capacity in his, I appreciate him.
And new talent, yesterday is a very good singer.
Sir, Dr. D.S. Vasnik is my teacher. When I was doing my MD medicine, I used to go to his home. He used to teach me. And he is now based in Chandrapur, one of the senior most physician of this part of the country. Sir, he was bestowed with the Legacy Award last year. Sir, few words, 30 seconds.
Very good conference, well organized by Dr. Gupta, Vita, and whole team. And next year also, next year also we expect the same. Huh?
1 decade हो गया अभी.
Oh, one day. Nice lectures and delegates. Thank you.
So next year's date is 5th, 6th and 7th of June 2025. नहीं नहीं जून ही तो चालू है सर. आज कहाँ पानी आया अभी 15 सर एक ही बार हुआ ना सर. सर 30 साल में एक बार हुआ. आशीष कम यू हैव अटेंडेड फॉर द फर्स्ट टाइम और फर्स्ट टाइम तो पहले दिन से है, पहले लेक्चर से है, तो with preparation से है. So what is your experience? What are new things which you want us to do?
Sir, as a student, workshops, all the lectures were par excellence. I mean, I have attended conferences, but the quality of academic content that I have seen here is par excellence. This has been the best experience for me, as a student. I would like to say one thing. For others, it could be ADA. For us, it is HDA. So, hello Diabetes Academy. I was talking to my colleagues that the way other students and colleagues have best of ADA, we would like to discuss the best of HDA. I mean, the content that we have received and we have seen is something world class. And मैं धन्य हो गया अटेंड करके, पहली बार है मेरा. एंड जितना सुना था कॉन्फ्रेंस के बारे में और सुनील गुप्ता सर के बारे में, उससे ज्यादा हमने एक्सपीरियंस किया है, देखा है. थैंक यू सो मच. थैंक यू.
Vishal is from Bombay and currently is in Ahmedabad. He is working with Dr. Bansi Sabu. आज मेरे को समझा कि ये स्किल इसको कहाँ से सीखा है. वो बंसी का ही दिमाग हो सकता है कि ADA से HDA वाला. This no one else can think of it. So even we never thought of it. But certainly we can do that. That after a month or so we can come out with the best of HDA and put it on the website, and we can have, wonderful. So nice of you, Vishal. Thank you. I called you earlier. Vishal बोला क्या? मेरा सबका नाम बदल देता है मैं. हाँ? मैं आशीष बोल दिया था मैंने. हाँ, आशीष. मेरे हॉस्पिटल में जितने हैं सबके दो नाम है. एक मेरा दिया हुआ, एक उनके पिताजी माताजी का दिया हुआ. ऐसी. चल. You want to say something, Ashish? Yeah. Ashish is coming almost from the day one. Yes.
So he is the versatile Amitabh Bachchan of diabetology. I call him versatile because he has having clinical acumen, and the education part I have learned from sir, and from the first day he has taught how to develop diabetology in Jabalpur, and where I am here today because of him. So give a big round of applause to HDA, and we do NDID because of him, because he has given the guidance. In the clinic, I have developed the practice because of him, and I am whatever I am him because of him, because he is my mentor. From the first day I followed him, and I am the successful diabetologist because of him. Thank you, sir.
So nice. Thank you very much. Do you, Sanket, you want to say something? पितुल सर का बाद में नंबर लगाता हूँ मैं. Sanket, you or yeah. Then and legacy awards and scientific program. Please go ahead.
Thank you, sir, for giving me the opportunity yet another year. So I'm really humbled by this opportunity to be a part of this wonderful conference. It was an excellent conference, and a very unique thing was a Padma Shri symposia. That was very unique, which I saw. All Padma Shris were speaking at this conference, and two excellent orations also today. So thank you, sir, for this opportunity.
Well, like Ashish said, Gupta sir is the guiding light for all of us. Whatever we learn, whatever we do, we take his advice and we do as per advice. And he has made HDA, he and Kavita madam, Nagpur is identified with HDA now across the country and across the world. And that is their dedication, their commitment. And this is what I have said to Sachin also a few hours back, that now HDA is on autopilot mode. So it is increasing in its capacity, in its academic content, in its overall quality. It is one of the best conference, not just in our country. And like Vishal said, it's not, like ADA, it has the academic content is what all clinicians want. And that's the reason behind its success, that people come and people stay for 3 days and attend all the lectures. Even till the last lectures, you have a full house. That's the characteristic of it, and that speaks volumes for its academic content. So everyone looks forward to the next HDA.
Thank you very much. Anyone from the audience? Then we'll have Vitul ko आखिरी में Sachin बोलना है.
Actually, I'm part of the team only. I'm associated with sir last 12 to 13 years. So I know how hardworking sir is. You know, he just sleep for 4 hours through and always work. मेरी भी लगी थी वैसे ही. तो लेकिन इसलिए मैं आप सबको एक रिक्वेस्ट करता हूँ कि सर एंड मैडम नीड ए स्टैंडिंग ओवेशन. थैंक यू.
Thank you very much. Anyone else from the, yeah, please come. Dr. Shahane.
There was a time that I used to practice only critical care medicine, but somewhere 2017 I joined his CCBDM course, PHFI, and by watching him, by listening to him, it is like to falling in love with diabetes practice. So he is really a mentor for all of us, and the way he carries out his lectures, the way he carries out his program, and what to say about HDA. It is like really memorable, too good. And
For PDM patients,
yes,
the
definitely.
care got, the sir has taught, and we are following it. and the
Education,
patients are
patient
getting the results.
care to the T. And जब भी सर जो बोल रहे थे कि best question award, and that handicapped people have designed that, something very unique, very unique. So, Kavita madam, Sunil sir, स्वर तो क्या गाना है ने, it's like तूफान, and Shlok is too.
So nice.
Okay.
Thank you very much. Yes, so now Vitul sir, आपको कुछ बोलना है, फिर हम सर से फाइनल. सर की ट्रेन है, सर को पकड़ के रखा हुआ है हमने. जैसे बहुत सारे लोगों के ने बोला कि उनके मेंटर में हूँ, मेरा मेंटर भी मेरे बाजू में खड़ा हुआ है. ये बिल्डिंग जब नए हॉस्पिटल की बन रही थी, उसके पहले ही हैड कम टू माय प्लेस एंड सॉ द बिल्डिंग. ही सॉ कि कैसा स्ट्रक्चर डालेगा, उसमें क्या क्या रखना है. एंड आज भी एनीथिंग, इफ आई गेट सम डिफिकल्टी इन सम डिफिकल्ट केसेस, then I call him, sir, ये ऐसा यार मेरे को समझ नहीं रहा है, बताओ क्या. He will give me half an hour lecture and he will ऐसा किया क्या, ऐसा किया क्या, ऐसा किया क्या, ऐसा किया क्या, अच्छा ऐसा कर, ये भी कर ले, शायद कुछ तो भी निकल जाएगा. बराबर निकलता भी है. So he is with me. इसे आखिरी में होल्ड करके रखा हूँ उनको मैंने.
So thank you, Dr. Sunil, for giving me this opportunity to speak on the very important function or ceremony, which I consider is more important than inauguration or any other function. Because here you recognize what the organizers have done. So that is very, very important to boost their morals for the next year. Inauguration में आते हैं सब अच्छा बोलते हैं, सब चले जाते हैं, but that valedictory function, if I am there, I make it sure to attend all valedictory functions to boost the moral. You know, academics, everything goes on. But what is unique with Dr. Sunil,
I came in contact with him about 6 years back. And he visited my conference in Bathinda, Punjab. And that changed whole of the scenario, my attitude towards diabetes education or any education you think. Before that, I was little bit cynical. कहते हैं ना कि यार मैं क्या कर सकता हूँ अकेला गवर्नमेंट करे वो नहीं होता used to find faults in everything. But once I saw him doing the job for diabetes education, he became at least my role model. So I presented the lecture on primary prevention of diabetes today, but I didn't talk about any barriers. I put photograph of Dr. Sunil, Dr. Bansi Sabu, Dr. Shashank Joshi, Dr. V. Mohan. Great personalities doing lot of job for diabetes, but what Sunil is doing, nobody else is doing. So there are no barriers. My motto became after coming in contact with him, do a little bit what you can, don't crib about it, do what best you can for diabetes or anything what you want to do. So that is how I consider this personality. All have talked, talked about HDA or anything, but he is one person who is taking care of all aspects of diabetology into his grasp and inspiring so many people. Thank you very much.
Thank you very much. Thank you. Last, anyone from that group? Any? कौन? हाँ, नहीं पर तेरे वो उनका पहले बात सुन तुम फिर बॉस फिर बंद. हाँ, मैडम का वोट ऑफ थैंक्स. Anyone want to speak anything? हिंदी में चल मालिक का जल्दी अभी सर का ट्रेन है, सर को छोड़ना है.
थैंक यू सो मच फॉर द अपॉर्चुनिटी टू टॉक. मैं अभी सर से बात करके बाहर हम लोग बात कर रहे थे. सो आई हैव बीन पार्ट ऑफ DCRC सिंस 2014. दैट इज द इंसेप्शन ऑफ हेलो डायबिटीज अकेडमिया. We have seen one day Hello Diabetes Academy, and today we have done 3 days. And we have seen how it has grown from people, national speakers to international speakers. But then the one person behind all of these 10 years is Dr. Gupta, and he has sown those those seeds of diabetes education. And wherever I am today, he keeps telling me that I keep seeing your posts on social media, and he keeps encouraging me कि तेरा तो social media इतना अच्छा है, your social media game is all very good. But sir, this is all because of you. You have sown those seeds. And I have seen how he has grown. Like, pehle we used to do these offline sessions, but because of COVID, when the new normal came in, he had actually adapted to online things as well. I recently did this Prega talk, Sindhi language. So we were there, like he has done these Prega talks in 22 languages, which is like a big thing. And so, heartiest congratulations, sir. Thank you for all that you have done for us. Thank you for your motivation. And we look forward to having this HDA for 7 days. Thank you.
Anyone? आरसी तो आज ही के दिन आई है, क्या बात करेगी वो? आज 3 दिन से absent थी वो. परविंदर तेरे को आना है? No. Okay. चलो. Otherwise. आरसी कम बेटा कम. मैं तो मजाक कर रहा हूँ.
No, she was there from the inception.
From the day.
उसको
साइंटिफिक प्रोग्राम बनाने के लिए उसको बुलाता था सर. मैं तो उसकी वाली स्टोरी सुनाई, कैसा डांट पड़ती थी, क्या होता था बता.
सर के बारे में मैं कुछ बोलने के लिए सबने इतना सारा बोल दिया है कि और कोई वर्ड्स है ही नहीं. लेकिन सर के साथ काम करने में जो एक्सपीरियंस है वो मैं बोल ही नहीं सकती. बहुत ही अच्छा सर पढ़ाते हैं, और जो सिखाने का तरीका है सर का, वो भले ही दूसरों को बुरा लगता होगा, लेकिन वो सबसे अच्छा तरीका है सर. सर बहुत अच्छा है. मैंने मिस किए 2 दिन, मैं बाहर थी, लेकिन मैं बहुत मिस की.
She was a part of the सर वो प्रिपरेशन था ना, इसका निकालो उसका निकालो, ये टॉपिक डालो, कौन से रह गए क्या डाले, तो उसमें बहुत दिमाग, और ये इनको करना पड़ता था. We used to work only from 9 to 11 मॉर्निंग में, या फिर रात को जमेगा नहीं तो 9 to, तो every day she has to come at 8:30, 9 and then sit with me. So she and the Parvinder, yeah. So these 2 people are there. What you rightly said ना, पीछे क्या हो रहा है बैक साइड में. So they have to work really. रात को 1-1 बजे तक केस को मैंने लिख के भेजा है. अभी कौन था, कौन एब्सेंट है, किसका कैंसिल हुआ, कौन से चेयरमैन नहीं आ रहा है, all these things. You know, Kiska, everything she used to really remind me for all this. So thank you very much, Parvinder. Thank you very much, Arshi. Thank you everyone, every DCRC staff, Sangeeta, रूपाली वो बच्चे को लेके उसका 3 महीने का 4 महीने का अभी 11 महीने की हो गई 11 महीने की उसको बोला तू बच्चे को लेके आ यहीं दिन भर फीड करा पर यहीं काम कर so she prepared all CV slides of everyone so we have involved less event manager is less and this is our event team of Hello Diabetes Academia.
ये हमारी DCRC की नारी शक्ति है.
नारी शक्ति साक्षी वो साक्षी है सब हॉस्पिटल वाले ये साक्षी जो लड़की है छुट्टी इसने सब छोड़ दिया.
She has resigned. She's shifting to Pune,
She's
but
getting-
still she said, "I'm going to be
So
there for
15 days
1
she
month."
came up back from Pune
Yeah,
just
and
to work
she'll be
with us.
working there with us. So there is a story with each one of them, and that is why that day I got emotional. So because we know at back of the stage that we have to, you know, every person has a story, and everything comes into my mind. So that was the thing. ठीक है, but thank you very much. It was मतलब आपके बिना ये सब नहीं हो सकता.
So big hand for DCRC staff. Hip hip.
Hooray! 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 And finally, I would just like to say, I don't say much about him, but yeah, मैं बहुत बार चिढ़ भी जाती हूँ कि my God, I'm like people say कि पागल है, but I should also say कि he's absolutely passionate about things because sometimes settle अरे यार आज सैटरडे आज संडे रहने तो मत करो ये वाली चीजें अभी ओके हो गया मतलब every time you need not run over things but no I have to do you don't want to come don't come I'm going to do it so the thing is that on छोटी छोटी चीजों में he is so passionate and he wants to do the best मतलब अगर ये ऐसा हो गया है ठीक है सब अच्छा लग रहा है बट नो स्टिल ही विल फाइंड आउट कि नहीं अब इसमें और भी क्या एडिटिंग करके हम इसको और क्या बेटर कर सकेंगे so giving the best to everyone and trying to give the best academics उसमें भी बहुत सारी चीजें होती हैं like literally from 4 o'clock in the morning he'll start doing tick 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 on the phone and like what is this 4 o'clock you're getting up and doing this and like that is the passion he has because ये वाली चीजें आप लोग नहीं जान पाओगे कि सुबह 4 बजे उठ के भी कोई you know मैसेजिंग कर रहे हैं हमारे अलग अलग ग्रुप्स हैं
है ये आप बता रहे हैं.
यस एक्चुअली क्योंकि हमारे अलग अलग ग्रुप्स भी होते हैं तो उसमें व्हाट्सएप मैसेजेस करना एंड लाइक उसमें सबको स्ट्रीमलाइन करना ये बहुत सारी यू नो दैट इज वेरी वेरी इंपॉर्टेंट सो आई थिंक ऑल दैट इज बीइंग डन बाय सुनील सो थैंक यू वेरी मच एंड आई डोंट
पागल है
नो
डायबिटीज के पीछे सेकंड आपके पीछे.
no he is not mad behind me at all चलिए अब हम
Sir.
yes
Sir.
sir no
Dr. Sushil Jindal, I told you, is my elder brother. He stays in Bhopal, and we have different chemistry altogether, and this almost since 25 to 30 years.
थैंक यू सुनील मैं सुनील को जैसा सुनील ने बोला 30 सालों से जानता हूँ इतना क्लीन हार्टेड इतना सीधा साधा एकदम स्ट्रेट फॉरवर्ड जो कुछ होगा मन में सब बता देगा ऐसा मैंने बहुत कम लोगों को देखा है जो इतने खुले हुए होते हैं कई लोग होते हैं अपनी बातों में वहाँ फिरा के बोलते हैं छुपा ले जाते हैं सब कुछ नहीं है इसके बारे में बिल्कुल प्योर खालिस जिसको कहते हैं वैसा है जहाँ तक सवाल कॉन्फ्रेंस का है मैं जानता हूँ कितना बड़ा काम है और इतने सारे स्पीकर्स को लाना उनको स्टे कराना उनके सारे अरेंजमेंट करना मुझे याद है मुझे शायद हाँ 2013 में मैंने ऐसी कौन किया था भोपाल में 1 महीने तक प्रैक्टिस बंद 4 किलो वजन कम हो गया उसके बाद कुछ लोगों ने जो बहुत जिनको मैं बहुत अपना समझता था उन्होंने भी मुझे कुछ कमेंट कर दिए कि तुमने एक कॉन्फ्रेंस ऐसी कर दी जिसमें डायबिटीज़ ज़्यादा था और एंडोक्रिनोलॉजी कम थी तो मैं जानता हूँ कितना बड़ा टास्क होता है पर एक चीज़ और भी है कि जो डायबिटीज़ है वो इतनी तेज़ी से बढ़ रहा है कि आप देखिए साल में 2-3 नए मॉलिक्यूल आ जाते हैं और जो चीज़ें हम पहले कर रहे थे उनके बारे में कुछ और आ जाता है तो एक इवॉल्व होती हुई मैं आपको छोटा सा एग्जांपल दूं पहले एडीए की गाइडलाइन में लिखा था सबको एस्प्रिन दो फिर एडीए की गाइडलाइन चेंज हुई, उन्होंने कहा कि प्राइमरी प्रिवेंशन में मत दो, ठीक है। फिर आया कि नहीं, जिनमें प्राइमरी प्रिवेंशन करना है, जिनमें हाई रिस्क उनको दे दो। तो मतलब हर बार कुछ नया हो जाता है। तो इसलिए ये बहुत ज़रूरी है कि हम अपने पेशेंट्स को सही तरीके से इलाज कर सकें। और मैं ये भी जानता हूँ, मैं खुद भी जितना भी कोशिश कर लूँ, मैं खुद इतना नहीं पढ़ पाता जितना मुझे पढ़ना चाहिए। मैं भी जो चीज़ ज़्यादा पढ़ने की इच्छा हो, फिर अल्टीमेटली मैं अपने डीएम स्टूडेंट को दे देता हूँ, तो इस पर सेमिनार कर देना। तो होता है, उम्र के साथ में वो इतना एंथुजियाज़म भी नहीं रहता। तो इसलिए ये बहुत ज़रूरी है कि हम सबको ये नॉलेज, जो नई नॉलेज आ रही है, सबको बांटें, सबको इम्प्लीमेंट करें, जिससे कि सोसाइटी का भी फ़ायदा हो और हम भी कुछ अच्छे से पेशेंट। मैं सही में कई बार मैं जीपीज़ के पेपर वेपर देख के ऐसा लगता है कि मैं अपना सिर फोड़ लूँ। कुछ तो मैं क्या कहूँ, मतलब कि जो मेरे कलीग्स हैं और शायद मेरे से सीनियर थे, की गलतियाँ देख के सही में ऐसा लगता है कि इनको बेसिक क्यों नहीं आते। ये भी तो मेरे साथ कॉन्फ्रेंस जाते हैं, मेकिंग राइट डायग्नोसिस, मेकिंग राइट करेक्टराइजेशन ऑफ डायबिटीज़। क्लियर कट पेशेंट दिख रहा है सुनील की लाडा का है, और ऊपर से फिर उसको टाइप 2 बना के और उसको 5-6 OHA चल रहे ही हैं। तो फिर ये सब चीज़ें सीखने की होती हैं जो इन कॉन्फ्रेंस में हमको सीख। मैं सही में सुनील को कहूँगा कि कीप इट अप, ये बहुत ज़रूरी है। और एक और बात मैं बोलना चाहूँगा कि टीच इज़ टू लर्न ऑल्सो। कि मैं किसी को पढ़ाऊँगा तो मैं खुद भी पढ़ूँगा, और हर बार पढ़ूँगा तो कुछ नई चीज़ सीखूँ, ठीक है।
बिल्कुल नया दिया, सीलियक डिजीज, उस पे कोई सोचता नहीं है, बट आई एम थैंकफुल कि बहुत कुछ सीखने मिला। और अब पेशेंट्स जो आएंगे एब्डोमिनल कंप्लेंट से, तो हम बहुत कुछ सीलियक के डायग्नोस कर सकते हैं। वी वर मिसिंग दैट लिंक।
देखिए, आज डॉक्टर सुनील जैन ने बताया, मैंने भी कई पेशेंट्स को सीजीएम लगवाया। थोड़े दिन बाद मुझे लग रहा है कि कुछ गलत सलत दे रहा है। पेशेंट बोल रहा है मेरे को हाइपो हुआ, पेशेंट बोल रहा है कि मैंने शक्कर खाई ठीक हुआ, मैंने अपने ग्लूकोमीटर में देखा मेरा उस समय 65 था, और वो सीजीएम बता रहा है कि उस समय 100 था। मुझे कुछ अटपटा लगता था कि ये क्या चल क्या रहा है, कि पेशेंट जब बोल रहा है। मैंने बैठे बैठे सोचा, हाँ गर्मी का टाइम था, हाँ उस समय पेशेंट जरूर बाहर रहा होगा, तो हो सकता है इसके कारण गलत रीडिंग आई। आज जैसे ये हर बार कुछ ना कुछ सीखने को मिलता है। तो प्लीज़, I think I must give kudos to Dr. Sunil for organizing such a beautiful conference, and we all are going back wiser, and we will be utilizing this knowledge. So definitely आप लोग सब जिन्होंने अटेंड किया, टाइम निकाला, I hope all are benefit. Thank you.
Thank you very much, sir. Let us have a group photograph here, and then we'll wind up. Yeah, all of us, please. Here, na here only. हाँ, वही तो बोल रहे, वही पीछे पीछे। ऊपर कम, हाँ ऊपर चलो। कुछ लोग खड़े रहे, जल्दी जल्दी करो। नहीं सर, कुछ लोग सामने खड़े हो जाएंगे। अच्छा, ये पीछे दिखो, पीछे दिखो।
अपन नीचे रहते हैं,
हाँ, ये लोग पीछे खड़े हो जाएंगे, ऐसा रहता है। चलो बेटा, जल्दी जल्दी आ जाओ। चलो चलो आओ, जल्दी जल्दी आओ। एवरीवन इज डायरेक्टली और इनडायरेक्टली इन्वॉल्व। प्लीज डू जॉइन अस।
आइए, नहीं आप आइए।
गुप्ते सर या अरे कुणाल, ये लवकर, तुला बोलायची गरज नाही। साकेत, कम 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 फॉर फोटोग्राफ, जॉइन अस। सागर, विवेक, हाँ चलो अभी ले लो उसको। विवेक के लिए जगह छोड़ो, वहां फोटो चिपका देंगे फोटोशॉप से। एवरीवन इज देयर। चलो, ए अपन यूएस जैसा करेंगे ना। छुट्टी क्या करता था वो? क्या? नहीं, हाँ
मैं हाँ बोलूंगा।
नहीं, ऐसा नहीं करना पड़ता। दैट इज जल्दी 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 जल्दी। ओके नहीं ये वीडियो नहीं था सर, ये वहाँ यूएस गए थे ना, तो वहाँ का एनर्जी फोटोग्राफर ऐसे करता था, वहाँ कूदने लगता था वो। सही बात थी। You have to take a video also, huh? वीडियो भी ले, ये हो रहा है ना, वीडियो इस तरह, या तो से वीडियो है सर, वीडियो चल रहा है। So thank you very much, thank you everyone, thank you.
Ma'am.
Sir.